Somebody takes the mic, one mic, could you give it to that girl? Can you just tell the inspection finding? Yeah. Use the mic and speak. I just want you to tell on inspection, just like a swelling. Where is it located? Location, extent, size, shape, surface, border, skin over the swelling. That much is enough for inspection. Can you just tell? On inspection, yes. Don't worry. Hold the mic closer.
On inspection?
Yes. There is a mass.
There is a mass
visible. Okay.
In the right iliac fossa.
Very good. Correct. Where it is extending to?
Extends.
You know the extent. Has it gone to the umbilical region above a little bit?
Yes, sir.
Has it gone to the midline here? Midline? Yes. What is that area? Hypogastrium. Yes. What about this area? Lumbar. This is right iliac fossa. That's what my extent. Don't you say that extension from this to this. Yes. Next. What do you think approximately shape? Approximate. Approximate. You can call this as some irregular or vertically elongated. Vertical. Then horizontal. Correct?
Yes.
Ascending colon is a vertical structure or horizontal structure?
Vertical structure.
Very good. This should give you some clue. This is something is there going up like that. So it is not just cecum, it's ascending colon actually. This is what is the clue for you. Look at the disposition of the mass. Yes. What is the surface depicted there? Irregular. Or you say nodular, I accept it. Borders, irregular. Skin over, we say normal. I will tell no pulsations. Why did I say no pulsation here? In the neck, we say yesterday, lymph node, that person. We say no pulsation because it may be sitting on the carotid artery, transmitted. Here also it's possible. So what artery comes behind this? Right iliac fossa. Iliac means? Iliac arteries only. Why doubt? Anatomy is so simple. If it is a posterior structure, if the lymph node, you would have got it. This is bowel, more anterior. Correct? Yes, sit down. Give it to the mic next. On palpation, you tell what is the thing which you expect to palpate. Palpation. Palpation, if you are asked to palpate, what do you expect to get in this patient?
Mass in the right iliac fossa.
Excellent.
And then the surface will be irregular. Margins are irregular. Consistency.
Better use the word edge or border. Okay, border. There's a mass, again on palpation. Abdomen is soft. Yesterday I mentioned abdomen is soft, no guarding, no rigidity. A mass is palpable in the right iliac fossa extending to. Same. You are going to confirm it now.
Right lumbar.
Very good.
And right hypogastrium.
Yes.
It reaches the midline.
Excellent. Vertically measuring about, you have to have a tape now. Now it is not approximately. Vertical, what is your assessment?
Vertically around 7 into 9 centimeters.
That is very good. Everyone should know what is the length of your index finger. You don't have to. That is how you measure. Length of your index finger you should know. Most of the surgeons would like to do a rectal examination always. And we say 5 centimeter growth is felt, 7 centimeter growth is felt. On table, we would like to know how much intestine resected. You would like to know also the stretch. Stretch your hand like this. And always you should know the length from your little finger to thumb length. So he gets roughly, this is 8 centimeter. 10 centimeter intestine I am resecting. This is away from ileocecal junction. Like that, it's better to have some approximately measurements to your own hands. Yes.
Consistency, sir. Hard and consistency.
Very good. I will stop you at this stage. Yes, that's what I told you about mantra of carcinoma cecum. Imagine if this is tuberculosis. Same thing can happen. 39-year-old, female, fatigue is due to anemia, loss of weight, blood, and everybody need not have evening rays of temperature. Please don't expect everybody is going to have evening rays, so it makes your diagnosis easy, not like that. What may be the difference in the mobility and fixity as far as this mass is concerned in tuberculosis?
Mobility is restricted.
So, yes, it is possible that it will definitely not be that much indurated and hard, but it will have some kind of a restricted mobility or mobile also. Consistency need not be hard. And anything else you would like to mention if it is tuberculosis? Anyone? What happens to the
Lymph node, sir.
Lymph node, not that you cannot get, this is a complex mass. This can have bowel, this can have lymph node together. Yes? Anybody knows what happened to the cecum? Cecum?
Pulled up cecum.
Very good. Pulled up cecum. Pulled up because of fibrosis. So cecum actually will be little higher. So that is, sit down. So this is how you say, right? Yes. Look at that picture here. This is how you please depict the pictures. And that lower border is so important to tell you what is the surface, what are the borders, and lower border is well felt, how much away from the iliac crest, so you know that it is not infiltrating or not going down below. And look at this patient, had female, that same patient, diarrhea, weight loss, temperature, abdominal distension due to ascites. In fact, this patient landed in the nephrology department. This is how it happens. Like yesterday you were telling, no, some role play. This patient comes to the outpatient department, tells somebody bilateral pedal edema. She was having little breathlessness. They thought, yes, naturally it happens. You refer to nephrology department thinking of a renal problem. After evaluation found to have a severe anemia. After evaluation found to have a mass by going into 2-3 areas. And that's how we picked up ultimately a mass and related to bowel pathology. So, typically, they are non-tender. Appendicular masses are tender. So, we told no, third diagnosis could be resolving mass. So, this is what is typical illustrations of whenever you get a mass. Swelling in the neck, mass in the abdomen, both more or less presentation, minimum 10 points are expected from you. Mass, location, extent, size and shape, surface, border, skin of the swelling, consistency, mobility, fixity. Then comes the plane of the swelling. This is a minimum. After that, you mention about pulsations and some other whatever is present. Same thing similar in the neck also. If you are able to do it, it should never be a problem for you. So, some of these patients can present with, yes, just carefully watch. Yes, next somebody can take the answer for this. What is this written there? Step ladder peristalsis. Yesterday, what peristalsis we saw? Yesterday, what peristalsis we saw? Visible gastric peristalsis. Where was it? Upper abdomen. Where it is coming from? Left to right. And what is this you are seeing? See, look at that picture also there, that side picture. So you will have a very nice step ladder here. So, see that? You carefully watch the loops getting prominent, one by one. And this patient had some abdominal pain on the right side, and somebody said it is appendicectomy, and there was some difficulty. Bowel loops were distended. Somebody put a vertical incision, and somehow with the great difficulty, they thought intestinal obstruction due to appendix. Appendicectomy was done, and after 5th day, patient was referred in this position. What he had was a cecal tuberculosis, hyperplastic ileocecal tuberculosis. And this is this patient's X-ray. Yes, can somebody take next? What do you see in that row? What do you see in this X-ray? Plain X-ray or contrast X-ray? Quick.
Plain X-ray.
Very good. What does it show?
Air and
Air under the diaphragm or air inside the bowel?
inside the bowel.
What is the difference between air under the diaphragm and air inside the bowel? Air under the diaphragm means it is the air which has escaped. Air tends to go for the highest position. Highest position in the abdomen when you are standing is
Diaphragm.
subdiaphragmatic collection of the air. This is all intestinal loops. So what next? Can you tell the diagnosis? Next. Multiple? What does it show? Multiple air fluid levels. Just see this, whenever you see a line like this, no? Fluid is also there. It's an intestinal obstruction. Sit down. This is a classical intestinal obstruction case. You see the central loops there. That's how you make a diagnosis. So hard, indurated, fixed, right fossa mass, loss of weight, loss of appetite, altered bowel habits, easy. Carcinoma of the cecum or ascending colon, that's accepted. Bowel mass of tuberculosis. Hallmark of tuberculosis everywhere is matting. Matted. Bowel is matted. Loops are matted. Omentum gets crumpled up there. We say granular omentum, rolled up omentum, like a carpet you roll. Something granular you feel. Intestines you feel. Mesenteric nodes, somebody said. Difficult to feel as separate entity. They all form together a complex mass. Very difficult, hyperplastic variety there. Hyperplastic in the right iliac fossa. A granulomat reaction, some omentum, lymph nodes, cold abscess. All this forms together a mass which has been called as classical mass arising from bowel. That is ileocecal tuberculosis. Invariably, cecum is pulled up. This is what gives you a little edge when you give a diagnosis. The lower border will be little higher up. Yeah, that's the dilated loops there. That's some amount of cocooning and matting. Yes. What are the tests you do for if you suspect? Whenever you have a patient like this, tuberculosis is easy. Like yesterday, they have mentioned the big list of investigation, correct? Including CB-NAT, you do all those things last. You do a laparoscopy, biopsy, and undergo limited colectomy. Yes. Carcinoma of the cecum, pallor is present. Now, see that mass. So, practice now. Practice what I told you. How will I describe this? Again, location, size, shape, surface, border. Palpation-wise extra, consistency, mobility, fixity. Lower border is free. Look at that lower border. Very important, lower border. Upper border, see how much it has gone. So practice 5-6 masses presentation. Present the case to your friend. Ask your friend to present to you. Inspection, palpation, so that you will not miss the findings. Right? That's what is inspection. Patient prefers to lie down with the legs flexed. Yes, can somebody tell why is that? PG solve. Something infiltrates. What is the muscle behind the cecum? Muscle behind the cecum. Malignancy infiltrates. Yes, iliacus, iliopsoas. So what happens? Your psoas is irritated. Psoas is irritated. You tend to flex because extension causes pain. So that is the reason why legs are kept flexed. And this is what is location here. This was the size. And again the lower border, how you say that. When it is a malignancy, yesterday also I mentioned to you, I showed you one big liver which moves with respiration. That was a nodular liver. So you are thinking in terms of carcinoma cecum, mention any liver is palpable, any ascites is there, and any induration in and around umbilicus. Yesterday we already mentioned about this, Sister Mary Joseph's nodule. And this is field for ovarian masses. Why do you feel ovarian masses? Again, we mentioned about Krukenberg tumors yesterday. So, bilateral, big bulky ovarian masses maybe from stomach, maybe from colon, maybe from breast. We would like to rule out ovarian masses. They are Krukenberg tumors. So, keep it in mind, all these things. Yes, that's what it is. So, this I think yesterday also we have mentioned. Lack of time, we'll proceed. So, usual questions. Why cecum? Why carcinoma? Why not tuberculosis? Any other diagnosis? I think I have already answered most of them. Anatomically, why do you say cecum? And why do you say cancer, hard, indurated, all that thing you say. And then you proceed with investigations. Whichever case is given to you, stomach or cecum, first thing learn, some investigation we always, for the fitness. You mentioned about Karnofsky, we talk about ECOG in cases of malignancy. I mentioned to you yesterday, Eastern Cooperative Oncology Group, scores. That's a fitness. Patient is moribund, there's no point in you doing, patient is 90-year-old, not that 90 is bad or something like that, but moribund I said. You can't go on doing a big surgery, and so that's why you put those criterias. Fitness. Patient might have had 2 myocardial infarctions, he may be on 2 stents, he may be on anticoagulants, he had a stroke. These are type of patients we get. You have to treat. So fitness. Next, always remember when they ask you, what will you do next? Whether stomach or right iliac fossa. Ultrasound is accepted today as a first-line extended investigation. You can always mention, nothing is wrong. At least it can tell liver secondaries are there, ascites is there. It may not tell properly for the bowel which is containing lot of air. So full of air, if it is trapped, it may not tell properly, but at least it can rule out. Diagnostic investigation comes later. So that is colonoscopy. When it comes the cecum, your case is right iliac fossa mass, cecum or tuberculosis or whatever it is, colonoscopy and biopsy. Easily you can take a biopsy. That will give you the diagnosis. And if it is a cancer, anywhere when the discussion of cancer comes, thyroid, breast, please add the word staging. I would like to do the staging. Always remember this. Otherwise the word is metastatic workup. Always. Whether it's a carcinoma of breast or thyroid, anywhere. Usual investigation, fitness, diagnostic, metastatic workup. Metastatic workup for the sake of staging. There you add the CT scanners. Just few images. I think time is already, one bell is over. This is the typical apple core. You can see here. And these are, nowadays, if the colonoscopy facility is available, bariums are not being done. So for some reason, somebody has sent this patient outside with the barium. That's what is the picture. This is one of the most favorite illustrations. Look at the tuberculosis and look at the carcinoma. So what has happened to the cecum? What has happened to the cecum? Pulled up. So classical it is. And this ileocecal angle, which is acute, has become obtuse, widened. So that's how the very classical. This is the colonoscopic picture of a growth and biopsy is taken. This is that mass. You can see the gas outside there. This cursor. So this is the typical look of the patients who are having cecal mass there. I'll take the pen. Yeah, so that's, you can see, no? Previous picture, yeah, polyps, you can see polyps. Adenomatous polyps and a growth there. This is apple core. And this is the classical hyperplastic tuberculosis with the pulled up cecum. And yes, why do you do CT scan if they ask you the question? You have made a diagnosis carcinoma, cecum, why you want to do CT scan? Helps in staging, but more importantly, what ultrasound can't tell you is this. Yesterday we mentioned about operability and resectability, etc. So we want to know ureter is behind infiltrated or not. So that is the reason why when you do a radical surgery, you want to know surrounding areas, more important. You try to remove a growth and iliac artery and iliac vein starts bleeding, ureter in the hand, patient is dying, and you don't have support from your vascular surgeons, etc. Patient dies. So CT scan is required for that purpose, and that is what it is. Yeah. I'll just take one more minute so that one case capsule I will put. Yes. Anybody? Anybody has got a right iliac fossa mass in the lumbar region and right iliac fossa contracting, and somebody examined the oral cavity. I don't know why he examined the oral. It's not coming that picture. Oh, sorry, this is the picture. Yeah, this is a oral cavity examination, and this was the case. Mass in the right iliac fossa, which was contracting, gurgle, gul sound it used to make. Yes? Anyone knows pigmentation in and around the oral cavity? Yes? Huh? Any syndrome? Peutz-Jeghers syndrome. Who said? Very good. After the clue, no problem. So what they can have? What they can have? What they can have? Interception. Okay. I think I will stop. So, thank you very much for giving this opportunity. There are few more images are there, which we will probably do it in the quiz time is there. Give that time questions. Yeah, one or two. Yeah. No. See, we will do later during role.
Thank you so much, sir, for conducting that much needed session. I hope all our participants now have an idea on the same. I request the audience to give him a big round of applause for the presentation that he has just concluded. Carcinomas or cancer as such is a condition that has a varying mode of approach and treatment. Every management varies from person to person, stage to stage, and so on. One such carcinoma that we as undergraduates are supposed to be aware of, besides carcinoma stomach and carcinoma breast, is carcinoma cheek. It comprises quite a few questions in the paper. Hence, to give us an idea to approach to a carcinoma cheek case, may I now invite to the stage Dr. Srinivasan, Professor and Head, Department of General Surgery, Government Medical College, Coimbatore. Please put your hands together and help me welcome sir. And to introduce our speaker, may I welcome Dr. Amuda ma'am onto the stage.
Some men see things as they are and say yes. But here is a person who dreams things that never were and say, why not? Dr. Srinivasan, you're most welcome here to deliver your lecture.
Final PPT.
Hello? Hello? Hello?
என்னமோ வேஷம் போட்டு விடுறீங்க, பயமா இருக்கு. Not used to these gadgets, just oral talk only. So good morning everyone. பத்தல சவுண்ட் பத்தல கேட்கல. Yeah, that's good. So nice to see a good audience, beautiful audience. I usually when I start talking I talk அன்னை தமிழை வணங்குகிறேன். அன்னை தமிழை வணங்குகிறேன். மாதா பிதா குரு தெய்வத்தை வணங்குகிறேன். Now, respected dignitaries of the dais, my good friend Professor Shanoy, he's a good, not only a good friend, my friend, philosopher and guide, because you saw my photo, I was holding his book. So, one of the finest teachers in the entire country. And I don't bother whether he's a fine teacher or but he's a fantastic human being, a down-to-earth person. A down-to-earth person. I'll tell you. Not only I'll say, then I have to talk about everyone. Everybody is a down-to-earth person. I'm just talking, he's one of the senior professors. So, thank you, sir. And it's very difficult to talk after a fantastic man spoke. And I don't know how bad my slides are, but kindly bear with me. Don't assault me when I go out. Professor, respected, I get goosebump shivering when I go to Lord Mugambiga temple. I just, that's the same feeling here when I saw Dr. Mugambiga. That's a friendly thing. Thank you, madam, for inviting me. And hope to come. This is the first time I'm coming here. Hope to come again. Then respected senior professors, Soundarajan, Dr. Amuda madam, we were all associates for a long time. We were examiners, Subbaratna madam, Mageshwari madam from Kovilpatti. I still remember. I don't know your name, sir. Sir Pandi, sir, right? And respected other dignitaries of the dais, and my dear beloved children. I call all my students as children. And so with these few words, I start my lecture. It will be just more of theoretical. I didn't bring because I was traveling. I couldn't make a good slide. I hope I'll do my duty. Right. This is my mata, my pita. So my pranams to them. And I bow before them. No, both of them are no more. My father was a professor and HOD of surgery, the same post which I'm holding. So all things goes to him and my mother. I bring greetings from the Coimbatore Medical College Hospital. இந்த போட்டோவுக்கு ஐ தாட் இன்னும் சவுண்டு வரும்னு பார்த்தா வரலையே. இந்த போட்டோ ஒரு ஸ்பெஷாலிட்டி இருக்கு, என்ன தெரியுமா? இந்த போட்டோ நான் எடுத்தது. இட் வாஸ் டேக்கன் அட் வைசாக்பட்டினம் போரோ கேவ்ஸ், இல்லையா சார்? if I remember. Yes. Just I run through the slides fast because it's more of theoretical, which I can give it to you. And if the things permit, I got some more educational slides for you. I got x-rays, specimens, instruments and operative surgery, PPT. Do you all want it? No, pathale 4 பேர் தான் சார்ங்கறீங்க. Right. That side nobody is talking. This cancer ranks among the top 3 in men. Oral tongue is the common subsite in the men. Buccal mucosa is common in women. I'll go through this very fast. Anatomy, etiology, histology. These are all self-explaining slides. The opposing borders of the lips, hard palate junction. Subsides are the oral tongue, floor of the mouth, I'm sorry for the SMS. And retromoral trigon, buccal mucosa, alveolar ridge and the hard palate. Tongue, floor of the mouth has got the richest lymphatics. Hard palate is the least. And most of them drain into level 1 to 3. Anybody can say the level of the lymph nodes? Yes, somebody in the second row. How many levels of lymph nodes are there? Please, one of the, give something. Yes, stand up, stand up. You introduce yourself.
Good morning, sir. I'm
Yes,
Surya
very
from final year MBBS, sir.
Yeah.
Levels of lymph nodes, sir.
Yeah.
Level 1, 1A, submental, 1B,
Yeah,
submandibular.
fine.
Level 2, upper jugular. Level 3, middle jugular. Level 4, lower jugular. Level 5, posterior triangle. Level 6, central compartment.
Yeah.
Level 7, mediastinal.
Sit down, thank you, very good. Oral cavity drainage, 1 to 3 lymph nodes, group of lymph nodes. Tongue may show skip metastasis. The midline lesions are bilateral. Can you say any midline lesion in the oral cavity? Yes. Boys come, somebody answer. Which has got a bilateral lymphatic. On the side, Mauna Varadama. Don't be afraid, Pa. See, it's not an exam. This is what previous surgery alters the pathways in the oral cavity drainage. The depth of the invasion, the grade, and the subsite are very important. Histology, most of them are squamous cell carcinoma. Some arise from the minor salivary glands. What are the histological which arise from the minor salivary glands? Is it squamous cell carcinoma? Right. Somebody can stand up and say in histology, what could be the features of squamous cell carcinoma? No beating around the bush, no. Yes, somebody stand up and just a few words, 1 or 2 lines. What is it called? The third. The mic was given to speak to you, not to pass on the mic.
Good morning, sir. I am Anjana from final year MBBS.
Very good.
The squamous cell carcinoma in histopathology, we see keratin pulse.
Onion. What is it called?
Onion ring appearance.
Is there a grading for it?
Yeah.
Yes, anybody next? Can. Borders grading. Yes. Good. You are all doing good. Nothing.
Good morning, sir. My name is Idar Sharon. I'm from final year MBBS. Broders classification, greater than, well differentiated will have greater than 75% of keratin pulse.
Very good. Yeah, no,
Moderate will have 50 to 75.
When you start answering like this in the exam, the examiners will know that you are doing well. Okay. Another way of answering the exam is to answer fast so the examiner doesn't understand and you also don't understand. See, that was a joke told to me long time ago. One of my professors said, somebody asked, what are the beta blockers? You answer fast. Metoprolol, propranolol, Mohanlal, Jawaharlal. So, no, yes, very good. Because, no, it's very difficult to sit in the exam. Now, knows, all the examiners knows. As especially undergraduate, 25 candidates per day, repeating the same thing. Sit down. So, we'll be drinking all cups, and when we come to Mugambe, we'll be eating a lot of things. So, they make us sleep. That's why. So, you're answering. There will be a lot of perineural spread, periosteum, and locoregional spread. These are the histological features. Etiology. Tobacco, alcohol is a synergistic with chronic irritation. HPV, mainly the oropharynx, susceptibility, submucosal fibrosis. What are the 6 Yes? Now pass on the mic to the other side. Let one of them, yeah. That is why the reservation is going up to the ladies, because all boys are silent now. இப்பமே சைலண்டா இருந்தா கல்யாணம் முடிச்சு எப்படிடா இருக்க போறீங்க? தயவு செய்து வாயை திறங்க. I think we are going. Yes, somebody answer from this side. Abba, uttar. See, I have to finish fast. Come. 6 yes. Yes, give it to that. Okay, nobody is. Yes.
The 6 is sharp tooth, spices, spirit, smoking, sunlight exposure, susceptibility, syphilis.
Yes, very good. The etiologist, the second primary is tract. What is field canceration? Can anyone say that one?
Field cancerizations are on because of continuous exposure of mutagens to the oral cavity. Their development of other than primary lesion, they are more prone to develop other tumors.
Okay, very good. Sit down. So, what could be the clinical feature? A non-healing ulcer of more than 3 weeks. You should warrant biopsy, shaky tooth. And what are the types of growth? Is proliferative and infiltrative, smooth swellings, trismus. What does mean by trismus? Now give the mic to this, the third or fourth row. That side, I think you can put a screen and cover those people. Keep a separate TV for them and cover them because nobody is answering. I think the third day you're waiting for the fourth day to finish, isn't it? Anybody? What do you mean by trismus? Yeah, the girl in the second row, white, who looks fat like me. Please get up. I think fatter than me.
Good morning, sir.
Very good morning.
I'm Mohani Shivani from final year MBBS. Trismus is painful, inadequate mouth opening.
Right. What is the normal mouth opening?
3 centimeter.
3 or 3.5?
3.5.
Very good. No, luckily, you didn't say 3 fingers. Then I will ask, is it your finger, patient's finger, or my finger? So it is 3 centimeters. 3 centimeters is, what is the trismus due to in oral cavity? What was the trismus? Why do you get trismus in any oral cavity malignancy?
Infections, pterygoid.
Infection.
Infiltrations.
Any which muscle?
Infiltration of the pterygoid.
Which pterygoid?
Medial pterygoid.
Medial pterygoid. Any other condition? Submucosal fibrosis, severe submucosal fibrosis, infiltration into the floor of the mouth, all lead on to the trismus. Sit down. Thick speech, dysphagia, or other things which, I think the next case is carcinoma cheek where we can discuss in detail. Now, raised, rolled edges, contact this. What do you see? Is it an ulceroproliferative growth? With what do you mean by edge? I come to the basic. I just leave this one. What do you mean by edge in an ulcer? Because 2 things you should be very, the first chapter is swelling and ulcer. Definitely you will be kept a case of a swelling and definitely one ulcer will be kept. So ulcer, you have to be thorough. What are the parts of an ulcer? I think it's coming down. So I'll stop. What do you mean by edge? What are the edges you know? Somebody?
Good morning, sir. I'm Hepzibah from final year MBBS. So edge is the area between the margin and the floor of the ulcer. Sloping edge, it is seen in healing ulcer. Next is punched out edge. which is seen in syphilis. Undermined edge is seen in tuberculosis. Rolled beaded edge is seen in rodent ulcers. Everted edge is seen in squamous cell carcinoma.
Why do you get undermined edges in tuberculosis?
Tuberculosis destroys more the subcutaneous tissue more than the skin, so there will be undermined edge.
Right, very good. Keep it. So in a oral cavity ulcer, you should know the size of the ulcer, the depth, the morphology, whether is it crossing the midline, bone or muscle or nerve involvement. These are the points you should note down. Clinical examination is done, sometimes done under anesthesia. The rest of the oral cavity is examined. The indirect laryngoscope, look for the second primary, pan-endoscopic and tumor mapping. Examination of the levels, number, size, and contralateral nodes also should be examined. These are the various imagings which we will be asking in the clinical examination. So what are the biopsy? When do you take the biopsy? Why did I put that first slide? After imaging. See, any investigation, if you do, the first investigation is a non-invasive investigation. Why you do, the basic thing is, why do you do a non-invasive followed by an invasive? Yes. Yeah, it destroys the artifact. So always do a non-invasive, imaging first, followed by the biopsy. You can take a biopsy from the anterior wedge or edge wedge biopsy, or biopsy from the edge, wedge biopsy from the edge. Why do you take it from the edge? Wedge biopsy from the edge. I think you keep standing, I'll ask you all the questions because others are not answering. Yeah.
More cell activity, sir.
More cell activity, one. Number two, you can compare it with the normal cells. That is what. Why don't you take a biopsy from the center of any ulcer?
Necrosis.
Necrosis there. Can you tell me one condition where you take it from the center? Before I leave tomorrow? Tomorrow you find out and tell me. So staging to know whether it is operable loco-regional disease, spreads by extent of the disease. So based on things you can know for the prognosis, the choice of treatment, and compare the results of the treatment. The aim is curative. All self-explanatory slides, multidisciplinary. Early surgery. Early cases you can do early disease. So T1, T2 and N0 you can do a surgery and RT equally. Locally advanced combined modality. Sir, I am in a meeting. I'll call you later. I am in our CME at Mugambiga. I'll call you later. Anything urgent? Okay. So what are the basics of surgery is 1 to centimeter, for 2 centimeter margin should be given for a wide local excision. If it's a small tumor, you can do a wide local excision. There are some other things like marginal segmental hemimandibulectomy as warranted. So how do you examine the mandible? I would have kept quiet. Alex sir தான் வரும்போது 3வது ரோ 4வது ரோ 5வது ரோ கூப்பிட்டு கேள்வி கேளுங்க அப்படின்னாரு. So all the enemy is there only. So you're just asking, just answer, nothing wrong in it. It is not an exam, it's an interaction. Then only you will not sleep. He was telling there's a chip kept under your chair which beeps when you sleep. Run your fingers along the mandible and look for any thickening or thing. How do you look whether the temporomandibular joint is involved or not clinically? It's not yawning. All of you put your right little finger into the ear. Open your mouth and see. You feel any click, it is normal. You feel anything, you feel any tenderness or irregularity, that means the temporomandibular joint is involved. These are basic, some small clinical points which I want to say. The reconstruction is done by the flaps. You remember the PMMC flap, radial forearm flap, free flap. I'll skip the slides, certain slides I'll slip. So what are the stages of a buccal mucosa where you don't have unresectability is when it extends into the masticator spurs, pterygoid plates, skull base, encasement of the carotids and prevertebral fascia infiltration. Neck dissection, do you know what is neck dissection? Again, you stand up. I'll give you a gift at the end of the talk because you are answering more.
Radical neck dissection, modified radical neck dissection.
Are they doing R&D now?
Modified radical.
What was modified from the R&D?
Preserve the structures.
What are the structures you preserve?
Sternocleidomastoid, spinal accessory,
No shouting. The கூட்டத்துல கோவிந்தா போடுறதே வேண்டாம். கேட்கும்போது கம்முன்னு பொத்திட்டு இருக்கிறத இப்ப கேட்டா கிடுங்க. அதை கூட்டத்தை சொன்னா என்னமோ சொல்றீங்க. So I was thinking everybody is answering. So give the mic to them. They'll. You answer, ma.
Internal jugular veins.
You preserve. There is MRND 1, 2, and 3. Then you have a selective neck dissection, okay, based on the things. These are the incisions which are made, which is not and Martins or McPhee. Others are not needed. The complications of an surgery: orocutaneous fistula, infection, flap necrosis, chyle leak, nerve injury, very carotid blowout. Postoperative radiotherapy is given for node positive on the examination of the histopathology, T3 and T4 and the margin positive. It is given 3 to 6 weeks after surgery. Bill adichtiya? Adikarna adichide. Illaya? அமுதா எங்க போனாலும் நம்மள பெல் அடிச்சா சீக்கிரம் முடிக்கலாம்னு நினைச்சா given to 360. What is mean by margin positive? Does anyone know about R0, R1, R2? Right. These are the complications, common complications of radiotherapy. What do you mean by upfront surgery? Anybody? We'll discuss. I think a bit advantages. We have recurrent surgery with. You all know about these pre-malignant conditions which occurs in oral cancer. Okay. And the slide should have come first. Yeah, what is leukoplakia? What is erythroplakia? Which is more dangerous? What is leukoplakia? How many types of leukoplakia are there? Homogeneous and speckled. There are 2 types of leukoplakia. So you should know in oral cancer, you should know about the pre-malignant condition, all these things. Morning, sir. Professor Balaji Singh from SRMC. So these are the recent advances. Supravital staining, toluene and bloom, oral brush, chemiluminescence, and tissue autofluorescence, which are the newer techniques. Good morning, Dr. Gayatri, madam. Professor Gayatri from head of the department, Stanley Medical College. Nice to see all teachers. Great teachers. Yeah, since Professor Gayatri has come, I should hand over the mic to the next speaker. Very strict, madam. So I'll finish with this one. Thank you, madam, for your wonderful opportunity. The ever-smiling madam, and I heard she's ever-smiling, short, sweet lady, but strict also. Because after she took over, because yesterday I was traveling with one more Mugami student. Mugami is coming with me. After she took over this college only, it was well structured and organized. And students, she'll be strict to the students, but very sweet to the students. That's what I heard. So all of you make use of her. And she was very proud that she was educated in the famous Coimbatore. And I would like to say a few words, because wherever she goes, Guru Brahma, Guru Vishnu, Guru Deva, Guru Brahma, Guru Vishnu, suddenly it gets Guru Sachat Parabrahma, Tatvaisi Samanga. That is in her. Wherever she goes, I see her. She will put a slide on one person who is another very good friend of mine from 1987, Dr. Jayachandran. And she really, that Gurutvam is there with me. That Gurutvam is where now I have a lot of gurus in my thing. And my now guru is the students. You are my gurus because it is from you I learned the art of teaching. It is from my students I learned the art of teaching, how to improve myself and present a paper. This time I made a mistake. I learned from the students. Somebody asks a question, I don't know. I say I don't know. And if he says this one, I said I'll find out. So I'll find out from them, then he'll be correct. I appreciate him. So I learn from my students also. So you are also my gurus. Wish you all the best. As take up one idea, make that one idea your life. Think of it. Dream it. Live on that idea. Let the brain, muscle, nerves, every part of your body be full of that idea, and just leave every other idea alone. This is the way to success. Said by, right, what is his original name? Nobody knows. Ask you the original name of Nayantara, you will say. Huh? The original name of Swami Vivekananda? Narendranath. Okay. With this, I finish my lecture. Thank you for your patient listening, and thank you for everything.
Thank you so much, sir, for elucidating on such an important topic. Audience, please note, if you have made best use of this session, then I'm sure your exams will be a breeze. Thank you so much, sir, once again. Okay, guys. Up next is yet another important session, one that has been repeated in all our classes from time to time. For those of you who find it difficult to recollect, well, take this course as a refresher to your memory. To expand our knowledge on the topic, approach to salivary gland tumors, we have with us Dr. Gayatri, Professor and Head Department of General Surgery, Stanley Medical College, Chennai. Please help me welcome ma'am with a large round of applause. And may I now request Dr. Amita ma'am to invite the guest speaker onto the dais.
See, the more the diamond is cut, the more it sparkles. And she is a gem of a lady surgeon in our group, and she's the professor and HOD of Stanley Medical College. We are very happy to have you here, Gayatri. Over to your talk.
Good morning, all. I think this is a little too much for me early in the morning. What Amada ma'am says. I'm just a surgeon, and amongst the males, The males dominate the surgery department, and I'm one person in that. Yes. So I thought, why should the males alone dominate the surgery? Yes. So let me just enter into the surgery department. That's all. Otherwise, they're all still there. Thank you for that very nice introduction, Amuda ma'am. I think she told this because we are both friends. Yeah. Hand mic irukuma? Thank you. So, that's me. Yes? What's my name? Oh, good. And so, what is my topic today? Yes? Salivary gland tumors. Do we all have salivary glands? Yes? All of us? How many types? Salivary glands. Have you seen the salivary gland? Have you seen it? Can you tell me the types? I can't hear it properly. Okay. Have you heard of parotid? Have you heard of submandibular? Sublingual? Anything else? Oh, minor salivary glands. Okay. But none of these you've seen. None of these you've seen, right? Yes or no? Yes. So the anatomy of the salivary glands we don't know, right? But do you know the physiology of the gland? Yes? Innada ellarum silent ah irukanga. Is the salivary gland working or not? Yes. How do you know? Okay. So because of the saliva in the mouth, you know very well that your salivary glands are working. Yes? Do you know if your parotid gland is working? Do you know if your parotid gland is working? Do you want to try to know? Yes? So, the parotid gland drains through what? Through the duct. Yes? And what is the name of the duct? Okay. So, is there an opening for the duct? And where is the opening for the duct? Okay. Now, all of you, take your tip of the tongue to this duct orifice. Let me see. And just tell me what is your experience. Yes? Even I'm trying. Yes? Do it. So, the opposite the crown of the upper, second molar. Yes. Just palpate. Anybody has experienced anything? You should, if your parotid gland is going to be normal. How many parotid glands you have? 2. So when you have the tip of the tongue onto the opening of the Stenson's duct, you can see a little bit of serous fluid coming out. And that is the... Yes, did you all experience this or not? Yes. So that is what? There is a saliva coming from the... Okay. Now lift up your tongue. On either side, you put the tip again. Yes? And just see what you can experience there. Again, the saliva is there also? Yes? Okay. And what type of saliva is it? Is it a thin one like what you saw in the orifice of the Stenson's duct? Or is it going to be a little thicker? A little mucus, right? So what does it tell you? That the secretions from the parotid gland is going to be thin, yes, fluid. And the secretions from the submandibular gland is, yes, is a little thicker. So where do you think the stones are going to form? Good. So with that, shall we go? So we have seen a saliva, where it is secreted, and the types of saliva also, right? Okay, good. So these are the salivary gland tumors, and this is the WHO classification. What is WHO, first of all? Oh, nice. Okay, so that's the epithelial, non-epithelial, malignant, lymphomas, lymphoepithelial tumors and the secondaries. Okay, so these are the epithelial tumors, and the main thing is the adenoma and carcinoma, and pleomorphic adenoma. Have you heard of this word? Yes, good. So we are going to discuss about it. And carcinomas again can be graded into high and low grades. And non-epithelial, we're not more interested in this. Anyway, for completion's sake, hemangiomas, lymphangiomas, neurofibromas, and neurilemomas. Okay, so that's about the lymphoma, and that is common in the parotid. Incidence of this salivary gland tumors. So amongst these, what you said, which is the most common gland to get involved in these tumors? The larger gland. Which is the larger gland? The parotid. So the parotid is involved in the neoplasm. And which is the most common neoplasm? Is it benign or malignant? Always, anywhere for that matter, except a few. When there is a tumor, it is usually benign. And so 80% of the tumors will be 80% of the tumor, what tumor will it be in the parotid? Yes? Pleomorphic adenoma. So you would have seen cases of pleomorphic adenoma, right? Yes. So in the salivary, again, in the submandibular gland, 50% will be benign and 50% will be malignant. So in the parotid, most of it is benign, whereas in submandibular gland, 50-50, and in your minor salivary glands, what is more common, benign or malignant? Malignant is more common. So this is the topic for today, actually. So this is what? He has got a swelling there. Yes? In front, below, and behind the ear lobule. Right? So that is what? That is the parotid gland tumor. The common, the most common one is pleomorphic adenoma. So what does it contain grossly when you touch it? So it has got cartilages, cystic spaces, and even solid tissue, right? And microscopically, again, two basal things are there, epithelium and the stromal components, epithelium and stroma. So it's predominant in the females with an incidence of 3:1, but then we have a male picture there. And then it is often unilateral, and it is usually single, and it is painless, and it is firm, mobile swelling in front of the parotid with positive curtain sign. What is that curtain there? What is that curtain? Yes, everything is fine. You would have heard of all this. Single, painless, not smooth actually, firm, lobulated and all that. But what is this curtain? We'll come to it in the next slide. So what is this obliteration of the retromandibular groove? So we have the mandible, the ramus. Behind that is a space, a gap. So that gap will be obliterated here. The tumor is usually capsulated, but then it has got pseudopods also. So what is a pseudopodia? Yes, in a school we have read about pseudopodia. What has got pseudopodia? Amoeba has got pseudopodia. So something like that, it has got some extensions. Yes? Okay. And so the tumor, what is that? How many lobes are there in parotid? Yes? 2 or 3 or 4 or 5? 2. They are anterior and posterior lobe or superficial and deep lobes? Superficial and deep lobe. So which is more commonly involved? The superficial or the deep one? No. It is a, I think only I'm talking to this crowd. Huh? Adha. Yennada? Huh? Surgery field is dominated by males. சரி ஏதோ இப்பதான் நாங்க நுழைஞ்சிருக்கோம்னா அங்க எல்லாருமே சர்ஜன்ஸ் ஆயிடுவாங்க போல இருக்கு. You people are not bothered. MD general surgery, MD general medicine. என்னடா வெள்ளிக்கிழமை மௌனம் வருதம்மா? Okay, I want interaction from this crowd now. Yes? Yes or no? Shall we? Good. So this is about the deep lobe. The parotid has got the deep lobe also, right? Yes or no? Yes. So what is wrong with the deep lobe now? You will not be able to see the deep lobe. Yes? Just like people here, sitting quietly without any involvement. But sometimes the deep lobe also gets involved, right? As now. Okay? So how will the deep lobe, how will you be able to see the deep lobe? The deep lobe is deep inside, so you'll not be able to see the deep lobe. So how do you know that the deep lobe, something is wrong with the deep lobe? Because there'll be a swelling there. Where will the swelling be? In the pharyngeal wall, lateral wall of the pharynx. Okay? And then, as I said, here in front of the ears, it's not going to be any swelling because it's going to be deep-seated. And sometimes there is also involvement of the parapharyngeal space involvement be so big. Yes? So the inner one is so big, the outer one will be, the deep lobe will be smaller involvement, whereas it will become bigger inside where there is space. So what is a dumbbell? மேல நம்ம பார்க்குற இடத்துல சின்னதா இருக்கும், உள்ளார வந்து பெருசா இருக்கும், parapharyngeal space. So what is that? What is dumbbell first of all? பார்த்திருக்கீங்களா? எல்லாரும். Good. So here the facial nerve is not involved. Why? Facial nerve is not involved. In the lobe involved, the facial nerve will be involved. And here the deep lobe is involved. The facial nerve is not involved. Why? Because the facial nerve, yes? What is that plane called? Facio-venous plane of Patty. Good. இப்போ அங்கிருந்து தாண்டா வருது. So what are the clinical features of a pleomorphic adenoma? There is a swelling, right? Okay. Pain இருக்குமா இருக்காதா? Sometimes it's going to be painful. Sometimes there will not be any pain. So it can undergo ulceration. The patient can complain of dysphagia. So you all know what is dysphagia. Yes? Thyroid la படிச்சிருக்கீங்களா? Dysphagia. Okay. So what is this curtain sign? Yes? So when you move the swelling above, yes, it will not go into the scalp. Why? Because the zygomatic bone is preventing the movement of the swelling because of the fascia that is attached there. So that is called the curtain sign. And this is a definite question in a case of parotid. Okay? And then if there is malignant transformation, what is going to get involved? The facial nerve will be involved, the masseter, the skin, lymph nodes and the bone will be involved. So what are the complications? So even after surgery, it's going to go for a recurrence. What is the reason for recurrence? We already said, even though it is capsulated, it has got pseudopods. Yes, because of that, there is recurrence and sometimes it can turn into malignancy also. So what are the investigations you're going to do? Parotid gland, somebody comes with a parotid swelling, what are the investigations you're going to do? Yes? You're going to go for an FNAC. So you know what is an FNAC, right? Okay, good. And then you're going to take a CT scan. So why do you want to do a CT scan? Because you want to know about the involvement of the surrounding structures, right? And MRI also complements it a little, right? So a long-standing pleomorphic adenoma can turn into malignancy or not. And what is that called? What is it called? Yes? Let me see if you know. Okay. So what are the features that suggest carcinoma? The swelling is there forever. Yes, 5 years, 10 years, 15 years. Then suddenly there is pain and nodularity. There is involvement of the skin and ulceration. Involvement of the muscle, that is a masseter there. Then the cervical nodes are enlarged. And then restriction of the jaw movements. Involvement of the facial nerve. So all this occurs. What does it tell you? That is getting converted into malignancy. Okay, so what is the treatment for this? The swelling. தடவி கொடுத்து அனுப்பிடலாமா சரியாயிடும் ஒத்தர வச்சிருன்னு yes that is what they do no okay so what are you going to do so surgery is the first line of choice okay so what are the types of surgery so when the superficial lobe is involved you're going to go for superficial parotidectomy when the deep lobe is involved you're going to go for deep lobe parotidectomy total parotidectomy right So what are you going to do with the parotid nerve, facial nerve then? Facial nerve is a spinal nerve or cranial nerve? What is the number? So are you going to remove the nerve or not? Why not? Okay. So in benign cases, we are not going to remove the nerve. When the nerve is involved in malignant cases, then we are going to remove it, right? And what is that parotidectomy called? When you remove the facial nerve also. Yes? Radical. Very good. Ma, clap pannungada. They all answered. Okay. Now we have said something about pleomorphic adenoma. Then this is also an interesting tumor of the parotid gland about which you should know, because even in the exam they're going to ask you about pleomorphic adenoma and then they will ask you about adenolymphoma also. So what is the other name for adenolymphoma? Warden's tumor. And then here it is a benign tumor that occurs in the lower pole. Usually involves a lower pole. The males are involved. Okay. So here only the superficial lobe is involved. And it is multicentric also. So if it is multicentric, yes, in breast you would have read multicentric. So what is the significance of that? If it is multicentric, what does it mean? There's going to be a recurrence if you're going to leave some behind, right? Okay. So the risk again, smoking and radiation exposure. Clinical features, as I already said, it occurs more in smokers. Investigation, so you go pick up a hot spot with technetium 99 per technique scan, and again you go for an FNAC. You don't go for core needle biopsy here. Why? In breast we go for core needle biopsy, right? Yes? Yes. Here we don't go for core needle biopsy. You should tell me why. Again, this is something nice. Adenolymphoma doesn't turn into malignancy, whereas pleomorphic adenoma can turn into malignancy. So what is the treatment? Superficial parotidectomy. This is one more interesting case of malignant parotid tumor. Okay, so this is malignancy. And that was benign, which can turn into malignant, the pleomorphic adenoma. The second one was benign, and now this is a malignant one. Okay. So here it's a slow growing tumor, and then it can have many grades, and the lymph nodes are involved. Radiation is the commonest etiological factor. Facial nerve is involved or not? It can get involved at later stages. So this is about, I'll come to, so what is this? I asked you, what is the malignancy that develops in pleomorphic adenoma? Tell me. Yes? Carcinoma, X pleomorphic adenoma. Okay? So, rapid change is there. There is fixity. Facial nerve is involved. Neck node involvement is also there. Okay? So, this is the most aggressive salivary malignancy. And you already told the treatment. What is the treatment? Radical parotidectomy. So, now I'll go to okay. So these are the investigations we do, we said. We already spoke about FNAC. We already said about CT scan. We want to know about the extension, yes, where all it has gone. And then the MRI, it tells about the perineural spread. So that is a word you should use. When we talk about MRI, you should always say, we should know about the perineural spread. Okay, so what is the management for your pleomorphic adenoma, we said? We already discussed, right? So these are all the types of parotidectomy we already discussed. Yes? And so you would have seen this. Yes? The first one I like, the lazy, just like us. Yes? Yes or no? Yes? Yes or no? Lazy like us? Dey, ennada ennayo seetittinga adala? Okay? So, this is a laziest incision, okay, for the parotid. So these are all the steps. You are supposed to identify the facial nerve, and then you are going to raise the flap and look into the facial nerve. Then you are going to close with a suction drainage. Okay. What is this total conservative parotid? Total conservative. Total means you're going to remove both the superficial and the deep lobes. What is this conservative? You're going to conserve the facial nerve. Okay. So you know what radical parodectomy is. Yes, so you're going to remove the structures all around. Okay. Suppose the facial nerve is cut inadvertently. Yes, by mistake we are going to cut the nerve, right? What are we going to do? We can reconstruct it with another nerve. So what is that nerve? Greater auricular nerve or the sural nerve எங்க இருக்கு? Auricular எனக்கு தெரிஞ்சிருச்சு காது கிட்ட. Sural எங்க இருக்கு? Oh, nice. Okay. So radical neck dissection என்ன? என்ன எடுக்க போற neckல? You're going to remove the nodes, neck nodes. So what is this? Why is his face like this? Yes? And who is the reason for this? And who is the reason? Okay. So this is a complication of parodectomy. But complication, when they ask you for complication, you are supposed to talk about intra-op complication and then post-op complications. Do you understand? So intra-op complications, what do you get? Surgery panna enna varum? Bleeding. Yes. Hemorrhage. Yes. Hemorrhage, then injury to the nerve also. So later complications will be your salivary fistula, then the flap necrosis and all. Now what is this? Fraze syndrome. Yes? Right. I can hear a voice there. Gustatory sweating, auricular temporal syndrome. Here the sympathetic nerves from the superior cervical ganglion, yes, they get united with the postganglionic parasympathetic fibers from the aortic ganglion. This must be your reply. Definitely this will be asked when you are given a case of parotid. Do you understand? Definitely this question will be asked and you will have to answer. So what is the management now? What is the management? Yes? So enna nadakkum modalla? Flushing, sweating. Yes, gustatory sweating. So gustatory sweating na enna artham? While eating, right? Good. So you're going to do a starch iodine test. Yes, you're going to paint the skin there with iodine, then let it dry, and then you'll have to apply starch, and then it becomes blue when it sweats. The color will change blue. And treatment enna? Erkanave surgery panni, we have created this. So again, another surgery, yeah? Yes? Yes. Innoru surgery panni, adha cut panni vittallam thirumbi. Okay, but usually it is conservative management, and this will be again asked in even your theory. Okay, so this you should remember. Anticholinergics, antiperspirants, and then botulinum toxin, but we don't go to that extent. Do you understand? And then this point also you should say, placing the sternocleidomastoid muscle under the flap. So that will prevent the union. Okay? Sorry. So these, okay. Now we'll go to submandibular salivary gland. So have we finished parotid gland? Yes? Everything about parotid gland? No doubts at all. You'll be able to present a case well. Yes? Okay, good. So now about the submandibular salivary gland. Okay, we already said 50-50. Benign is 50, malignant is 50. Yes, so we should be more careful. And then, what is more common? It is firm to hard, bidigitally palpable. So what is bidigital palpation? So when the submandibular gland is bidigitally palpable, there is something that is not bidigitally palpable, the same area, same location. What is that? So how do you differentiate between a submandibular node and a submandibular gland? So that is where this comes, bidigitally palpable. Do you get it? Again, you go for FNAC, and if you have any doubt, you can go for CT scan also. So that is a, you can see, you just know it is a malignant one. So what are you going to do? FNAC and CT scan. So if it is going to be a benign one, you're going to go for an excision. Otherwise, you're going to go for a block dissection of the neck nodes also. So this is about the minor salivary glands. Yes, we wouldn't have encountered much, but then a lot of theory. So what are you going to do? If it's going to be small, you're going to go for an excision, or if it's going to be a little larger, you're going to go for a complete exenteration. Okay? So I think we almost covered. The only thing is about submandibular gland is you should know the difference between submandibular lymph node and submandibular gland. So this is about the surgery for your submandibular gland. Okay? Now I needn't talk about the facial nerve and all that, right? All of you will know the branches of the facial nerve. All of you will know about what is pes anserinus. Yes? Yes or no? All of you will know about the masseter, buccinator, buccal pad of fat. Good. So this is about the mobilization of the submandibular salivary gland. And you should be careful about the lingual nerve and the hypoglossal nerve there. And you should be careful about the facial artery. Yes? Which takes a tortuous course and it comes again and again in the submandibular gland when you dissect it. So the anatomy and the dissection of the submandibular gland is very interesting. So in conclusion, what do? Salivary gland tumors are usually benign. Yes, that is what we said. Most of it are benign. It is rare in children. Clinical and FNAC are the diagnostic methods, and CT scan and MRI can complement it. And when the nerve is not involved, it has to be preserved. And when the nerve is involved, what are you supposed to do? Even then should be preserved? What is radical periodectomy we said? If the nerve is involved, we are going to remove the nerve. So that is it in short. I had to rush through like the way I came rushing here. Is my time over? I heard a bell. Yes. Thank you all. And I should thank the organizers. Ma'am, until 2 years back, must be 4 years back, I didn't know about this college at all because I'm born and brought up in Chennai. So I always, yap about Chennai. And Kanyakumari is at the far end of Tamil Nadu. No, I've never been here. Only one batchmate had come to Puvar, and from there I just left. So I didn't know about Mookambika Medical College at all. And then I had a student, my PG student. She was very good. Then I asked her where she came from. And then they told me it's a private medical college and all. Then I said, okay, I just left it. But again, she was performing well. Then I asked her where in Kanyakumari. Then she said Mookambika. I said, what Mookambika Medical College? Yes. Then I started showing, she was really good. So I became interested in this Mookambika Medical College. But then I said, I thought it's somewhere, then why should I bother? I don't even know anything about the Mookambika Medical College. Then she finished with flying colors last year. And I was proud because of her. She did it very well in clinicals also. My HOD called me. I was not a HOD then. He called me and appreciated that girl. And then she has got neurosurgery, MCH neurosurgery this year. She is in immense now. Yes, that's about your student. So when I heard all this, I was very proud of this college. I thought from this college, somebody is doing so much. And then when I got a call from Alex sir, I could correlate everything and I said yes immediately. Yes, and now I'm meeting you. I'm really proud to be here. I'm honored. Thank you. And my friends all. Sir, hi. So all my friends here, I'm meeting them all. And I'm very happy. I think you should also bring so much of orals that all of us should yap about you all hereafter, right? Okay, all the best all of you. Thank you all for this opportunity.
Let's give ma'am another round of huge applause. Thank you so much ma'am for conducting such an important topic with so much diligence. We hope that all our students in the audience have utilized this session well. Thank you once again ma'am. And that's our cue for a short break. I would request everyone to return by 10:30. final year MBBS. To chair and supervise and tone down the fine flaws of our presenters, may I invite on stage Dr. Rajagopal sir, Dr. Balaji sir, Dr. Srinivasan sir, and Dr. Gayatri ma'am to the dais. Professors and audience, please give them all a large round of applause. And I would also like to welcome I'd also request Dr. Jailal sir to come onto the stage. Please audience, let's give them a huge round of applause.
It gives me immense pleasure in welcoming our guest speaker today, Dr. Balaji Singh, Professor and Head, Department of General Surgery, Sri Ramchandra Medical College and Research Institute, Dean of Students, SRIHER, Porur, Chennai. He has various publications and research papers, including on colorectal surgery and minimally invasive thyroid surgeries, many media interactions, and many honors and prestigious awards to his credit. He is members of various institutions, and we are deemed glad to have you here, sir. Thank you so much for joining us today.
So, we'll have a students and moderators. So, we have got 8 minutes for presentation. So, 8 minutes they will finish their presentation. So, 12 minutes for discussion. So, 20 minutes for one case. We have got 3 cases. Okay. Thank you, sir. There will be a bell rung by about 6 minutes, and then 8 minutes, then 15 minutes and 20 minutes. Okay, please stick on to your timing. Thank you.
Good morning, sirs. Good morning, ma'am. Good morning, my dear friends and colleagues. We, Anjana GK, Idal Sharon Joseph and Bala Nandini are here to present a short case. Mr. Ramesh, 45-year-old gentleman who is a painter by occupation, from Tirunelveli, belonging to lower middle class, according to modified Kuppasamy scale, came to the OPD with the complaints of ulcer in the inner aspect of right cheek for the past 3 months, which was insidious in onset and initially small in size of around 1 centimeter and now gradually progressed to present size of 5 centimeter and is associated with pain while chewing and increased sensitivity to spicy food. History of swelling in the upper aspect of right side of neck for 1 month, which was insidious in onset and gradually progressed to present size. History of smoking BD for 20 years and tobacco chewing for 7 years. On general examination, the patient was examined in a well-lit room with adequate privacy after obtaining consent. The patient was conscious, cooperative and oriented to time, place and person. Moderately built and nourished. Performance status according to ECOG, it's 1. No pala, icterus, cyanosis, clubbing and pedal edema. Cervical lymphadenopathy is present. Vitals, pulse rate is 76 beats per minute. Blood pressure, 130 by 80 mm of mercury.
You can go for the regional examination.
Yes, sir.
Actually, short case in exams, we never give you this much of time. So you have to take relevant history, okay, whatever is relevant. Similarly, general examination is important. Okay, then you go clear cut to the case because we give 3 short cases. One is definite an ulcer, one will be a swelling. Okay, some universities keep 2 and one has orthopedics. So in the time given, you cannot be so elaborative. So make it a practice to give relevant history alone, whatever is relevant to it. For example, in this case, what is relevant, more relevant? Tell me. What is more relevant? You have already told. His habits, isn't it? His habits, his personal things. whether he's chewing tobacco or smoking tobacco or sniffing tobacco, any form of tobacco, right? So that is more relevant here. So family history is not relevant. Okay, CHX cannot be familial, right? So likewise, whichever is important, you have to stress. Because for your exam, I'm telling you. Okay, now it's a CME-like thing. It's like a CME, okay, that's different. But you tell relevant things alone, because we won't even ask you to write a case sheet. You have to go off and sit there and start presenting, and we should get relevant history alone. Only then you'll have a time and discussion also, though you'll get good marks in it.
I think you would have listened to Professor Chittamani's lecture in the YouTube or something. He used to say there's nothing called short case or long case. There's nothing but a short form of a long case. So relevant history as Sir was in. Okay.
So when it comes to relevant, just only one point, just go back. Go back. So most important point in your case is, you know very well, it is the carcinoma buccal mucosa, whatever it is. The strong risk factor in this patient is tobacco. So can you add one more line here? It is not just the chewing, any quid. What is quid? So that is what is the most common asked question. What is quid?
It's a combination of betel leaf, areca nut, slaked lime and tobacco.
Yeah, but quid means correct. What is that methodology of keeping in a typical place? This is actually Indian cancer actually. It's very classical. Keeping the tobacco quid. You know this the gingivo-alveolar sulcus here is there, no? So that is what you should ask. How many quids they normally keep? 2 times, 3 times, 4 times, whole day working in the field. So eating and keeping it here. This is the strong risk factor. Is it clear?
This is the risk of malignancy. And night quid, furthermore. Some people keep it in the sulcus and keep it in the night also.
So that's what you should ask. Some more question is, what is countryman's lip? What is countryman's lip? Who is a countryman? Countryman is a farmer. So lower lip carcinoma. See, he is also smoking bidi here. So if you see carefully, these are all the carcinogens affecting in particular area. So that where you need to give more stress. That's all.
And one more thing is, this is a cooked up case or?
No, ma'am.
Okay, go to the previous one. No, previous one. So no secondary, what is this neck swelling? What is this neck swelling?
Lymph node enlargement.
Lymph node enlargement. Is it secondary or a primary? Secondary. It is a secondary neck, right? Okay. A secondary neck will usually not progress. Do you understand? So when they see whatever size it is usually that size. So it cannot be 1 centimeter then going on for so many centimeters. Usually what size it presents? When it will be a vague swelling, then presents as a swelling. Okay, no, the slowly, gradually progressing in size. This is what you say for a malignancy? You never say, no? Okay, so that you should understand. Okay, yeah.
Finish your local exam. Finish your local examination, we can go for discussion.
Examination of oral cavity. The patient was examined in a well-lit room in sitting position after obtaining consent. Inspection, adequate mouth opening, no trismus, poor orodental hygiene, nicotine-stained tooth, no loss of tooth, tongue and palate was normal, mobility of the tongue is not affected, gums, nicotine-stained, floor of the mouth, normal. Small leukoplakic patches over right buccal mucosa, ulceroproliferative lesion in the right buccal mucosa. The growth is of 5×3 centimeter in size. Shape is irregular. The extent anteriorly 1.5 centimeter from the angle of mouth, posteriorly 2 centimeter from the retromolar area, superiorly 1 centimeter from the maxillary gingivo-buccal sulcus, inferiorly 1 centimeter from mandibular gingivo-buccal sulcus. Floor, slough is present, edge was raised and everted. There was no discharge from the lesion. Retromolar trigone is not involved. On palpation, inspectory findings were confirmed by palpation, tenderness over the lesion, An ulcer of size 5x3 present in the right buccal mucosa, which was irregular in shape. The margins were irregular. Marked induration felt at the base and 0.5 centimeter beyond the margin. Edges raised and everted. Ulcer does not bleed on touch. Tongue, palate, gums were normal. Bidigital palpation of mandible was normal. Lymph node examination, a single mobile hard nodule of size 2x2 present in the right cervical region at the level 2. No other palpable lymph nodes. My provisional diagnosis, ulceroproliferative growth in the right buccal mucosa and presence of cervical lymphadenopathy, most likely carcinoma of right buccal mucosa with stage T3 and 1 M0.
Okay, ma'am. Upon inspection, you said like floor is occupied by slough. So what is slough?
Unhealed ulcer produce slough, sir. Produce some necrosis.
It's a dead necrotic tissue, okay. Mostly it will be for infected ulcers, right? Diabetic foot ulcer, trophic ulcer and all. But for malignancy, better to tell unhealthy tissues seen in the floor. Okay, you know the healthy tissues, the adjacent sides, whereas in the floor what you see, right? Of course, can get infected, right? Can get infected, but once you say slough, it is a dead necrotic tissue. So we don't see a dead necrotic tissue in a malignant ulcer. So you can always tell unhealthy tissue seen. That's it. That should be a better terminology instead of slough. Otherwise they'll catch you on slough. What is slough? Where do you get slough? Everything you want.
It is an ulcer or ulceroproliferative lesion? The palpation you are mentioning as an ulcer. Inspection you are saying as an ulceroproliferative lesion. That you must be very careful. What you are talking about, ulcer or ulceroproliferative. You said it is 2 centimeter from retromolar trigone. How did you measure?
Do you have the picture of the
2 centimeter from the retromolar area. What is retromolar area?
Sir, it's mucosa over the ascending ramus of the mandible. Medially, it is bounded by the temporal crest, laterally by the ramus of the mandible, and base is on the third molar.
So you measured from there.
Yes, sir.
What is the lower end of the retromolar area?
Third molar.
Third molar. Oh, very good. So you have seen that third molar and you have measured that.
Yes.
Oh, good.
Okay, can you go back to inspection? Okay, so the patient opened the mouth. Yes? Yes? And there is an ulceroproliferative growth, and you said the slough is present, and there was a very pleasant odor, is it?
No, order was not.
No order, ma'am.
There was no order, ma'am.
You never said anything. What is it called?
Halitosis.
Halitosis.
You never mentioned.
Halitosis
Yes?
was absent.
Okay. What are the, this is the inspection one, is it?
Yes.
So you mentioned about leukoplakic patches, right?
Yes, ma'am.
Did any of the leukoplakic patch turn into this ulcer? I still don't know whether it is an ulcer or an ulceroproliferative lesion because you've confused us totally. So the patient in turn will be confused, right? Yes, so you should know whether it is an ulcer or an ulceroproliferative lesion. Okay, so the patient had a swelling followed by an ulcer, or the patient presented with an ulcer. That you should be very careful. Because here you are getting confused. You are getting confused because the patient said ulcer. And you didn't bother to ask whether there was a swelling which later ulcerated. Do you get it? So that is the most important history. So there must have been a swelling which ulcerated later on. That is why this ulceroproliferative swelling. Okay. Now you never said anything about the saliva, whether the patient is able to swallow well, whether the speech is altered.
No, ma'am. There was no any alteration of speech, and there was no any dysphagia or anything, ma'am.
How will I know? Such a huge swelling here, you said. Yes, what is this? 5 into 3
5
centimeters. And the patient doesn't have any difficulty in eating, swallowing,
Ma'am,
chewing.
but, when he is eating, he is having pain, ma'am. That is because of the ulcer, ma'am. Spicy foods when he is having.
Okay,
he's having
only
pain.
spicy food and nothing otherwise. When he is got such a swelling and there is an ulcer also. So you should think twice before you present this case
Few
as
things
saying
like,
normal. Okay?
yeah, few things like what are the types of these malignant lesions in the oral cavity you get. Most common is what you said, non-healing ulcer. Wherever you have a person who is having an ulcer which is not at all healing, so that's where you start suspicious. The growth is little more proliferative, exophytic like. Too much proliferation, you get ulceroproliferative growth. Right?
Yes, sir.
Any other varieties you know?
Verrucous
Verrucous is a frond-like thing. And lastly, some of...
Infiltrative.
Very good. Where do you get it? Especially excavating, like excavate, deep. Especially that area, retromolar and so. Where you find everted edge and all, it is better to say with this proliferation, also proliferative growth.
Okay,
That's how it is. And if patient says swelling in the mucosal lesion which later ulcerates, Madam had just finished her talk before. What do you suspect? Last, you heard salivary glands?
Yes.
Can you get anything else there? Ectopic? Salivary gland tumors. That's just for a discussion. Okay. Yeah, please go ahead.
We're able to pinch the skin over the ulcer because it's a local spread, isn't it?
Yes,
The buccal mucosa malignancy spreads posteriorly to the retromolar tract. Anteriorly, it can come up to the lip. Down, it can go up to the floor of the mouth. Upper to the gingival sulcus alveoli. And deep, it can pierce the fascia, buccal pad of fat, subcutaneous tissue, involve the skin, and produce something. What is that called?
Orocutaneous fistula.
So, are you able to pinch the skin?
Yes, sir.
Have you mentioned? So you should not tell because the extent, you said retromolar trigon is free. Anteriorly it does not come up to the lips.
Yes, sir.
So down does not gone into the floor of the mouth. So was the skin pinchable? Or the skin indurated? That should be told, okay?
Yes,
Right.
What is that leukoplakia you mentioned? Leukoplakia page means what?
It is the white patch that cannot be classified clinically or pathologically as any other disorder.
Why you are bothered about that? Why you want to know?
It is the pre-malignant condition of the carcinoma of
So where was it present?
On the right buccal mucosa, sir.
No, all you are saying right buccal mucosa. It was ulcer is also in the right buccal mucosa, no?
Yes, sir.
It is where retromolar trigon is free. No, where is this?
Anterior to it, sir.
Anterior.
Anterior to it.
That is a common site also.
Yes, sir.
So in other words, oral cavity lesions can be multiple. That's what we are trying to. You can also examine left side also for any such changes. And what is submucous fibrosis? And how does it look like?
So bands
So
of fibrosis.
that is another thing you have to look and later confirm under palpation. Go to the palpation slide. That one, yeah. So again here the confusion was same. Here you have written only ulcer.
Okay,
There you have written ulcer of proliferative.
growth.
So that's what you have to clearly tell us.
Yes.
What exactly is that?
It is ulceroproliferative.
So that is what is important there, right? Other things are all you have written there, everted, does not bleed and all that. Yes.
That's raised and everted. I think for undergraduate it is fine. But postgraduates, when you say raised, invariably you will not see a raised and everted in an ulcer, in an oral cavity ulcer. If there is only everted, please say everted. Otherwise, just say what you are seeing. Don't just bring the theoretical knowledge here. For undergraduate, it's fine. You are saying it is a ulcer is raised and everted.
Yes.
How did you elicit the tenderness? Over the ulcer, no?
So we kept a gauze piece.
Gauze piece? No, you said tenderness over the lesion.
So we kept our hand over the, palpated.
So normally we don't expect you to see the temperature on an ulcer. Ulcer, nobody go and press and see that is any. If the patient already has a pain, it is fine.
The patient had pain, is it?
So only when
the patient eats.
He had pain.
You look for any tenderness around the ulcer because the malignancy has got a desmoplastic reaction, okay? So you should look for any tenderness around the ulcer if it is infected. Over the ulcer, see any open area you touch, the abrasion if I touch it will be painful. So over the lesion in an ulcer, surrounding the ulcer, you look for any tenderness. No, since the bell has rung, can we go for the, how will you manage this patient?
So, start with investigation, sir. I'll do.
Sorry, just go back because, yeah, don't write provisional diagnosis. There's nothing like provisional diagnosis. First is diagnosis.
Okay.
It may be wrong, right? You have to give only one diagnosis.
Okay.
Again, when you give a diagnosis, we don't expect to write all the big lines. Carcinoma, write buccal mucosa. Nice to write T3, N1, M0. That is good.
Okay.
Then they will ask you, why carcinoma? There you are going to tell all those ulcer, proliferative, non-healing, induration, irregular. Cervical lymph nodes. So that's what you also people expect to talk more about cervical nodes.
Yes.
Induration, was it hard? Was it enlarged? What is the size? At least subcentric means not very significant. That is what we need. But give a diagnosis.
Okay.
Right? Do you have any differential diagnosis here? Just for the sake of writing 10 differential diagnoses, please don't write all those things. You will be in trouble. Cases like this, fairly straightforward, nothing like a carcinoma of the breast, big lymph nodes, nipple retraction, there are no differential diagnosis. But if they ask you what other possibilities are there, you can say. So diagnosis, clear, right? Okay,
Yes.
proceed.
So I'll manage the patient. First, I'll do investigations. That is, I'll take wedge biopsy from the edge, and FNAC of the lymph node, CCT of head and neck, and MRI scan of head and neck.
How do you take the biopsy?
From the edge of the ulcer.
How do you take? You give anesthesia?
Yes.
What anesthesia?
Local anesthesia.
Local anesthesia. Or you justified in giving local anesthesia, taking an ulcer biopsy?
Madam, simple thing, you are in the outpatient department, this patient has come, you told, and you are seeing a growth. You try to take a what instrument? Are you going to introduce a forceps? Are you going to introduce a scalpel? You think he will allow you, he will bite your finger? So you need to understand that way and try to give the answer.
I had put it in my slide, examination under anesthesia. It will be better. See, you treat the patient, not the disease. That's what. So you are taking a wedge biopsy, FNAC of the lymph node. Why you want to take an FNAC of the lymph node? Can that lymph node be enlarged due to some other reason? Infection. So you want to take an FNAC to know whether it is?
Malignant or
Okay.
metastasis or due to
So wedge biopsy, you told in the morning, it will get keratinization. In lymph node, what are the things you see if it's malignancy?
hardness.
You take an FNAC, do you know or not? I'll just go through it. One is alteration in the shape. If the lymph node, if you do an ultrasound, then you will get a taller, wider cells, vascular invasion. An ultrasound in size itself, it will be more than 10 millimeter. So say it's a lymph node is malignant. So you've taken, it has come as secondaries. Why you want to take a CECT? When you're taking a CECT, if it comes as normal, do you want to take an MRI?
It's a soft tissue invasion. I want to see any.
Okay, what will the FNAC be like? If from the node, tell the biopsy, how will the biopsy? See, usually that's what we ask. So what will be the biopsy like? What malignancy is that?
Will show
What malignancy it is?
squamous cell carcinoma.
Squamous cell carcinoma. Okay, so what do you see in that? What is the pathology?
Keratin pulse.
Keratin pulse. Okay, what do you see in the lymph node? If it is malignancy, if not. Infection and malignancy, node. You see malignant cells, right? It's a cytology. So how will a malignant cell look? These are the basic things we ask in the undergrad. How will a malignant cell look? So, the cell will be larger, okay? The nucleocytoplasmic ratio will be altered. High mitotic figures, okay? Hyperchromatism and prominent nucleoli. These are the 5 points to tell it's a malignant cell. That's all. That's what we expect, right? Not in depth. So, because you have to read so many subjects, not only surgery, right? For PG, it's different. For you guys, you should know the basics, and we expect only the basics, especially CBME-based curriculum and all. It's all the basics, integrated curriculum. We expect you to know your pathology a little bit, along with your clinical findings.
Okay. Good. Time is up, so you summarize what is the treatment you would like to give. Madam, time.
Wedge biopsy, when you say wedge biopsy, it is an incision biopsy. When it is an ulceroproliferative lesion, what is the biopsy you will take? It will be a punch biopsy. Okay? So it is ulceroproliferative along with your ulcer. So if the ulcer is going to be farther in, you cannot take a punch biopsy. If it is going to be near the lip, then maybe we can go for a local, otherwise it is always under anesthesia. That is what it is. You cannot just put the finger into somebody's mouth, they will bite you. And you cannot introduce a scalpel or a punch biopsy like this, they will bite it. So always say under anesthesia. Okay.
Good, well done, ma. You have studied well and prepared well. All the best.
These types of discussions are only some kind of a inspiration for you people. It is never a complete discussions. But this helps other people also to know how to present the case, where mistakes are pointed out, and how to improve on that. That's the only purpose. The best way is you keep on practicing. Okay? Thank you.
Thank you so much, Anjana, Balnandini and Adil, for that wonderful case. I'm sure this presentation would have helped you all for your exams.
Up next is a case presentation on the topic of swelling. As Chintamani sir rightly told, long or short case doesn't matter. More the time, more the assessment, more the marks. So make the best use of the upcoming session. To present a case on the topic of swelling, may I now invite Kiran Paul and Surya Narayanan from final year MBBS SMIMS.
Good morning, professors, on and off the dais. Good morning, students. I am myself Surya Narayan and Kiran Paul. We are here to present a short case on swelling. Summary of this study: Mr. Arnachalam, a 52-year-old gentleman who is a manual laborer by occupation from Tirunelveli, came with a chief complaint of swelling on the back of the neck for the past 4 years. It is not associated with any pain. Local examination, informed consent was taken. Patient was examined in a well-lit room in a sitting position with adequate privacy. Patient was examined from behind. Inspection, a single swelling was present on the back of the neck with ovoid in shape with 8 into 7 centimeter in size, and it appears smooth. The extent is the superiorly 5 centimeter below the occipital protuberance, inferiorly at the level of the C7 spine, and laterally 5 centimeter from the posterior border of the sternocleidomastoid muscle. And the margin is well defined, and the skin over the swelling is normal, no scars, no sinuses, no dilated veins surrounding the area, normal. And palpation, not warm, not tender. All inspectory findings are confined by palpation, and the margins appears smooth and well defined.
Don't mention as margins, okay? Margin is for ulcer. Okay? Here borders. To make it a point, you have to say as borders are well defined. So margin is for ulcer, borders for swelling. Okay, one thing. And history were very brief. Actually, you have to ask whether it's multiple or not. You missed that. Okay, you said single swelling in the back, right? But in that region, if you see, strikingly it looks like a lipoma, right? Strikingly it looks like. So you should ask any other swelling else in their body, because they'll ask you what are the swellings elsewhere. I mean, it's important because this may be the biggest one he's telling you. Let me have tiny ones across. Okay, then your diagnosis becomes multiple lipoma, subcutaneous, whatever it is, right? So you should ask that also. Pain, of course, you mentioned. So that's, so maybe that short also, right? You have to tell relevant, the progression, when it was noticed, being in the back, okay, and how it progressed. Okay? Right, good.
The surface appears lobulated, soft in consistency, and skin over the swelling is pinchable, and plane of the swelling is subcutaneous, and it's freely mobile in all directions, and the slip sign is positive. Regional lymph nodes are not palpable. Diagnosis, it is a case of a benign swelling, probably lipoma.
So, no, the diagnosis is not complete. You have to tell solitary, encapsulated, subcutaneous lipoma over the nape of the neck. See, lipoma patient himself will tell, okay? So you have to tell the solitary, right? You said single, solitary, and you said the plane. So you have to put the trapezius into contraction in that region probably, and you have to see whether it is contracting or not, right? Then solitary, subcutaneous, encapsulated, because diffuse lipoma is also common in that region. Why you say encapsulated? Slip sign is positive. In diffuse lipoma, slip sign is not. Huh? What I'm telling is, you have to practice that way, right? So the diagnosis should be complete. Okay?
Diagnosis was lipoma. Lipoma different, lipoma. You said lipoma. Lipoma? Spell it. Lipoma. Yeah. Benign swelling, probably lipoma. I was wondering, is any lipoma different from lipoma?
No, sir. Lipoma.
Just one question. Can you just go back to the slide? Because, what is important is when you have a lobulations there, consistency is soft, everything is okay. So slip sign, they expect you to elicit fluctuation.
Yes.
Because you have to mention you are an undergraduate or postgraduate. Examination findings are for both. PGs and UG, there is no difference. Yes. Only the discussion level and other things may be. Lesser the mistakes, problem. More the mistakes, problem. Like that. So, fluctuation.
Yes.
How do you do that?
Sir, since it's a large swelling.
Large swelling.
Sir, 8 cross.
Moment you have told soft swelling,
yes.
Fluctuation is present or not. That's all. Fluctuation indicates fluid inside.
Yes.
So you know the method for your case, 4 fingers you have to keep, yes. Both hands, watching finger, displacing finger or active or passive, both directions. Okay. Yes. So soft fluctuation. Then next question comes, I know this cannot be that disease. Suppose if the child is born like this swelling, soft, fluctuant, what else test you will do? I said child. Yes?
Sir,
yes?
It appears in the midline, sir.
Definitely.
So meningocele.
So meningocele. Or so, what is the next test you will do? Soft fluctuation, transillumination. Yes. Because that is what is expected as a differential diagnosis. This is for postgraduate level when we go, we'll modify the situation. This is, we say young, suppose this patient is this. Suppose this patient in that same area, consistency is more towards firm or hard swelling, what you would have thought of? Is same. Yes, soft fluctuant, lipoma, slip sign, is very easy. Yes. A little bit of firmer swelling, harder swelling. Anything else you suspect some from the skin here or something related to? Yes? You might not have seen probably dermatofibrosarcoma protuberance also is one of the sites of this. So think in that direction. Fibrolipomas can be more firmer like that. So this is how broadly we analyze the clinical situation. Never forget this. You are written there C7 spine. Suppose there is spinous tenderness, what do you suspect?
So, TB, you can get
cold abscess.
Cold abscess.
Don't tell TB, right?
So,
cold abscess.
So
in the lateral limit, you are measuring from sternocleidomastoid. The swelling is in the back. Why do you want to see from sternocleidomastoid 5 centimeter?
Actually,
that's not, this trapezius is the next muscle,
yes.
Or the shoulder point. Even that whole thing is not needed when you say in the midline.
Yes.
The swelling is the midline, don't go for all this extent.
Yes.
It is not necessarily needed for us to do that.
Yes.
You said slip sign, how did you elicit the slip sign?
Slip sign is, you have to palpate the edge of the swelling and it slips under the finger. Usually it's a pathognomic feature of lipoma.
So what will be the pathognomic feature of sebaceous cyst?
So presence of a black punctum is...
No, like when you are pressing it.
So indentation or molding
yielding.
Yields under
yields of that.
the slip sign tell you? You said typical of lipoma is, sir already answered. Adan sonna, it is a question you have answered, sir. Okay. So what is slip sign now? Why does it slip?
It is a soft swelling.
No, that's not the reason.
Soft, solid swelling.
That's not the reason.
I told you the complete diagnosis is not
It's an encapsulated.
Yes. So because of the capsule, it slips away. Yes? Okay. So nape of neck, that is what your diagnosis, I mean, the site is. Go to the spelling now. Usually in the nape of the neck, what sort of a lipoma presents? Everything sir answered. That is why I said these are all questions, sir. You are just outing the answer.
Usually it is a diffuse.
It is a diffuse lipoma in the nape of the neck. Okay. So what is a diffuse?
It is not restricted by a capsule, so it can.
Then where will that be? It will be in the skin?
Subcutaneous.
Subcutaneous tissue?
Yes.
That's all?
Lipoma can present everywhere, ma'am.
So what is the muscle there?
Trapezius.
Okay. So the lipoma there is usually diffuse and it will be intermuscular. Okay. So that is why you don't get a slip sign there. You're lucky to get this patient here with a capsule. Okay. If it is going to be larger than 5 centimeters, a lipoma larger than 5 centimeters, can you suspect anything? Always it's going to be benign, or can you suspect it to be something else?
Usually lipomas don't transform into malignancy.
It doesn't transform, but this can be something else, no?
Liposarcoma, it can.
No.
Okay, one thing I want you all to be clear about fluctuation, right? Some books mention fluctuation, some books mention pseudo fluctuation. Okay?
Yes, sir.
Right? Can you tell what you mean by pseudo fluctuation? That's for clarity, because some examiners expect that.
Yes, sir.
Okay. What do you mean by pseudo fluctuant?
Sir, fluctuation is actually a test which we perform in cystic swellings. But then lipoma is solid swelling, and other examples are myxoma, etc., which are soft, and lipoma also, it may also, since it's fat, it may be semi-solid, so it may mimic a cystic.
Then why do you call pseudo?
Sir, it is not actually.
See, what some examiners expect is, it is fluctuant, it will be on both the axes, vertical and horizontal. Okay, whereas if it means pseudo-fluctuant, one axis alone, either vertical, that is what is pseudo-fluctuation is about. Just for because some examiner expected, so you should know it, that's it.
You have said
huge lipoma, the flat globules are big enough, they said they transilluminate light also. So sometimes you will get transillumination. Some examiners are huge lipoma with flat globules, you can have transillumination.
You have mentioned no regional lymph nodes. What regional lymph nodes you examine?
Sir, posterior triangle lymph nodes can be.
Posterior triangle. This area drains into where?
Sir, back.
Excellent. It will not drain into.
Don't tell about lymph nodes at all, man, in this case. Okay. Not necessary.
Not necessary, you are going to.
See, spine is okay, because you can get a cold abscess, but again, duration can't be this long.
Yes.
Shorter duration, such as swelling, you may suspect cold abscess, examine the spine.
Yes.
But never comment on lymph node for this.
Okay.
What is lipoma?
Sir, it's a benign tumor of the mature adipocytes, which arises from the yellow fat.
What is hibernoma?
So it arises from the brown fat. Sir.
So soft fluctuant swelling, transillumination is a must, followed by, if it is negative, you have to make a policy to mention compressibility.
Yes.
The reason why, because we all know it is lipoma, but remember something like that happens in the posterior triangle, you will also another site for a lipoma, but it was compressible. So compressible means?
Sir,
compressible means?
You can, it's not completely, it doesn't go completely
when you
inside.
compress, about say 15 seconds or so, when you leave, slowly it fills back without any counteraction.
Yes.
What is reducibility?
Sir, it is in continuation with any cavity, so it will completely go inside, and on opposing force it will come back.
So this is the difference between reducibility and compressibility. Use that reducibility for a hernia example. It goes to a cavity, and when you ask the patient to cough or stand, it comes back, counter force.
Yes.
Compressibility, you just press and leave. It fills back. So soft fluctuation, swelling should immediately followed by these are the things. Whether it is fluctuant, whether it's transluminant, and whether it's compressible. Is it clear?
Yes.
That's how you start with. Do you ask expansal impulsum cough here?
No, sir.
In which condition of the swelling in this area you ask expansal impulsum cough?
Sir, if there's any aneurysm, you can ask.
Aneurysm? No,
Expansal.
Aneurysm, I didn't ask you the pulsation. I asked you expansal impulsum cough. We already just discussed.
Laryngosal, sir.
So, if you have a slightest doubt of a dermoid, may not be exactly here, some here, have a intracranial communication with the underlying bone, it also soft, fluctuant, transnegative, may have impulsum cough. The importance of that is to have a intracranial communication. You may start trying to remove this, and you may land with a massive bleeding because it's having intracranial communication. I'm not talking about this in particular. So this is how you practice in every case. This is a sequence of tests which you are expected to do. Okay?
Yes.
Thank you.
Is it painful?
No, sir.
So if it is history of pain, and what do you suspect?
Sir, lipoma can also form neurolipoma if it is involving the nerves, sir. Or
Any particular type of lipoma which will be painful?
Sir, Derkham's disease, which is present in the trunk and the girdle, it's painful. Multiple lipomas, sir.
So it's a universal tumor. Any part you will not get lipoma?
Sir, in the brain, since it lacks adipose tissue, but now they are saying...
no, brain you will get.
Yes, sir. In the sinuses, you can...
There are still some spots. Shaft of the penis, likely, and the upper eyelid. There is no space that you will not get normally you don't get a lipoma. Like Senai sir said yesterday, you never said, never in medicine. You can get, but still these are the sites you don't, normally you can get. Lipoblastoma?
Sir, this is the mature, arises on mature cell, that is when immature cell, if it arises from, you get lipoblastomas.
Okay, very good.
How do you treat this patient?
Sir,
You investigate? Any investigation you do?
It's a clinical diagnosis, sir, but you can confirm it using FNAC, ultrasound.
Ultrasound, why?
Yes, sir. It's a general...
Ultrasound guided FNAC?
Yes, sir.
Okay. Right, what is the treatment you want to give?
So treatment is excision biopsy, sir.
Excision biopsy, okay.
Sir, ma'am, enucleation is when you remove it without the capsule, and excision you remove it with the capsule. In enucleation, there may be recurrence, ma'am. Since you leave the capsule, there may be recurrence. And you can do it only for small swellings, enucleation.
Hey, why do you want to operate on this patient?
Sir, cosmetic.
Cosmetic?
Yes,
What
sir.
cosmetic? Somewhere in the neck there, cosmetic? What can happen to this?
Sir, it can fix to the spine, sir, and restrict
Spine?
movement.
No. It
Restrict
won't.
movement.
Subcutaneous, it won't. It may get enlarged. Obviously, it will have a problem while he is sleeping, pressure, like that it happens. Don't tempt, these questions are asked, then don't jump and say, it will turn liposarcoma and all.
Yes.
That is the reason I asked you. This will grow. Definitely it will grow. Only thing, well encapsulated, so it doesn't grow, like, it doesn't fall on the back because of the gravity. Whereas diffuse ones, we tend to go really big ones there. Because of the gravity.
It will like
as
a
is working.
pillow for them. And normally they don't accept to operate because they think it is a fortune. Good, well done.
Thank you. Thank you.
Thank you, Kiran Paul and Surya Narayan, for that case presentation. Up next, we have yet another case presentation on the topic of ulcer. For this presentation, may I now invite Hepzibah and Steffi Prasad from the final year MBBS SMIMS. May I request our evaluators on the dais to evaluate this session too. All the presenters, over to you.
Good morning to all the dignitaries on and off the dais and colleagues. I'm here to present a case on ulcer. Case summary: an 80-year-old lady, Mrs. Radha, residing at Nagarkoil, belongs to lower middle class, came with a complaint of ulcer in the dorsal aspect of the left foot for 3 weeks, which started as a small ulcer and gradually progressed to present size, associated with pain for 3 weeks, which was burning type of pain, continuous in nature, and history of serious discharges present. She is diabetic for past 25 years. Past history of healed ulcer over the left foot is present. No other comorbidities. Examination of the left foot. Patient was examined in a well-lit room. After getting consent, I was standing on the right side of the patient. Inspection: attitude of the limb is normal. Limbs are bilaterally symmetrical. No shortening of the limbs. No deformity. A single ulcer of size approximately 3 × 3 cm is present on the dorsal aspect of the left foot, irregular in shape. It extends anteriorly 3 cm from the proximal end of the metatarsophalangeal joint and 5 cm from the ankle joint. Margins are irregular, edges are sloping. Floor is formed by healthy granulation tissue medially and tendon laterally. Non-foul smelling serous discharge is present. Skin around the ulcer is hyperpigmented and an healed ulcer is present. No dilated or engorged veins are present.
Confirmed by palpation, no warm tenderness is present, base is not indurated, no palpable regional lymph node. Examination of peripheral pulse, normal pulsatile felt on dorsal pedis artery, posterior tibial artery, anterior tibial artery, popliteal artery, femoral artery, no restriction of joint movement. Examination of nervous system, no loss of sensation over the foot bilaterally, no muscle wasting, deep tender reflex are normal. Diagnosis: a case of healing ulcer in the left foot, probably due to diabetes.
So you have to tell us non-specific, you add to it. It's a non-specific ulcer, probably due to diabetes. Okay, and healing. That should be the combination. You have to tell specific, non-specific, malignant ulcers. In this case, it becomes a non-specific ulcer, right? That's how you should go about it.
You mean to say this is a diabetic foot ulcer?
Yes, sir.
Is it common to have a diabetic foot ulcer? Diabetic foot ulcer on the top like this?
Dorsum.
No, sir.
Dorsum.
It is on the plantar aspect is the common side, sir.
So the patient is having diabetes. That doesn't mean it is a diabetic foot. Diabetic foot is entirely a different concept.
That's why you have to tell non-specific.
Non-specific is ideal word.
Non-specific, probably. That, see, the healing aspect and other things, the diabetes may intervene. So that's why you always use non-specific.
The description you have said healthy granulation tissue. What do you mean by granulation tissue?
So it is for
Granulation tissue means what?
It is newly formed blood vessels with a fibroblast intermingled with red blood cells and white blood cells along with covering epithelium over it.
Covering epithelium is there. If there is a covering epithelium, it is a different concept. Granulation tissue, you are right. It is a proliferation of fibroblasts. That is the main thing. The fibroblast is proliferated. Along with that, you are having a neovascular tissue and the nervous tissue is there. How do you say it is healthy granulation?
So there is no presence of slough or any serious discharge, seropurulent discharge present, sir. And on touch, it may be, it bleeds on touch, sir.
Which one?
Healthy granulation tissue.
So it's malignant ulcer also bleeds on touch.
So it's a punctate like hemorrhage is present in on granulation tissue, sir.
Can you just show me that slides inspection and palpation? Just I'll take more. Doesn't take more time. Just inspection. Yeah. So just look at that ulcer there. Yeah. Limbs are symmetrical. What is that in the center? You see that?
So it is extensor brevis tendon, sir.
So that's not the way you say it's a slough. Basically, this is what is slough. That tendon sheath might have undergone necrosis. You understand? Because of the infection. can you see some whitish scar-like thing there?
Yes, sir.
What are those 3 stages of healing of the ulcer? This particular slide will tell you all the 3. Stage of extension, stage of transition, see, you can see that transition zone, stage of epithelialization. Look at that color. Can you see this blue area there? Yes or no?
Yes, sir.
That little blue area is there nothing but it's a transition where slowly the skin is now trying to cover that. And this side is where the slough is there. Okay, that's how you can see that margin and it very clearly in your case. So that is the center is the slough. Surrounding area, do you think there's edema of the feet there? Edema of the feet.
Mild
See,
edema is present, sir.
no, don't say mild tenderness, mild edema. Edema is edema. Mild tenderness. Because any person who is having an ulcer like this will have some edema there. You can see the toes there. You see the wrinkles like that. It's showing the evidence of healing. What I am trying to tell is, ulcer case is the most commonly kept case. It is for PG also, UG also. Very often you tend to neglect the clinical findings. And very often, see carefully, you will get every findings. Not only surrounding area to be checked, more details. Like here, no, not much of changes are there, but maybe 8-year-old lady, she's having that little bit of dark skin and all that thing. But otherwise, look at the toes. What type of toes you get in diabetic ulcers? Toe. Clawing. See, we are all talking whether it is due to diabetic neuropathy. There is no neuropathic evidence. Clawing is not there. Suppose diabetes patients were having microangiopathy causing ulcers. Where do you get it? Where do you get?
In the toes.
Tip of the toes. It is also not there. So this could be related to a trauma or ischemia. Only 2 components. Mostly trauma. Diabetes is the one which might have delayed this. She might not have noticed. So this is how you analyze the case. Did you check for any lymph nodes here?
No, sir, no regional lymph nodes
So
present.
why you should check for?
Any infective pathology, there will maybe enlargement of the lymph nodes.
So you have to look for any enlarged nodes, groin nodes, significant nodes, if they are hard or if they restricted mobility, etc. Right? So one is pulsations that you have written. Did she have varicose veins?
No, sir.
You have mentioned?
Yes, sir.
So really significant. Is that the site of varicose ulcers?
No, sir.
No. So you get medial or lateral. It's a very unusual site. So veins, pulsations, sensations, then of course limb, that attitude you have already mentioned. So that's where it is. You give a final diagnosis. Okay.
You have mentioned no warmth. How did you measure the warmth? Slide next.
Don't mention for ulcer.
In ulcer, please, no warmth. You should not touch the ulcer without your glove. With the glove, you can never make it out. How did you measure the size of the ulcer?
So,
see, if at all you tell warmth, the surrounding area.
Surrounding area you
Because
can
cellulitis can happen, the infection can spread. So you can tell the surrounding area is this. And another reason for pulses, varicose veins, sensation and all, that may impair the wound healing. Okay, so not necessarily that you are looking for because the site is like that. So if she has varicose veins, obviously the healing will be delayed. That's the reason why you are also looking for it. Okay. And lymph node, you are very correct. You tell only for infection because because you see the edge, right? It's sloping, so no issue. But if the edge is slightly raised or reverted, okay, it can turn margolins. Margolins also will not go to node until it goes to the normal area. Okay, so you should have it in mind. Suddenly students may say lymph node because malignancy. No, okay, you have to be very cautious. What you said is perfect.
You also mentioned joints movements are normal. Which joint you test?
so metacarpophalangeal joints and the ankle joints.
Metatarsophalangeal joints. How do you test individually? No, as far as possible, avoid all those which is not necessary, which is not.
Sympathetic effusion, can get septic arthritis. Okay, if it is close to the joint, yes, the infection can go, right? So then you, okay. And if it is a diabetic, you may get Clutton's joint, okay? So that's why again, if you strongly suspect a diabetic foot ulcer, examine the joint to know whether it's Clutton's joint or not, okay?
So as soon as you presented, you said the diagnosis to be diabetic foot. We thought it's going to be in the plantar aspect. Then we thought in the tip of the toe. Then nothing. Then again, when you said it was not on the plantar aspect and all, we thought you were talking about a varicose vein ulcer. So we thought in the gaiters area, medial aspect. Again, it was not there. So we discarded varicose ulcer. We were wondering what it was only. When you said dorsum again, it is only a non-specific ulcer, maybe because of trauma, exaggerated by diabetes. Okay, it's a healing ulcer. And there was one small ulcer, you said, healed ulcer. So it's going to, scar of an ulcer. So this is also going to heal a few days maybe. And this is a healing ulcer. So the diagnosis of diabetic foot, yes, you made us think about so many things. The examiner will not like. We really enjoyed. But the examiners will not like it, okay? So diabetic foot ulcer, you should know what exactly it is. Okay? So this is not a diabetic foot ulcer. Okay? Okay.
How we are going to manage?
Now one more thing. You said dorsalis pedis artery is palpable and also the rest of the arteries. One artery you needn't palpate because the dorsalis pedis is palpable. What is that artery? It's a quiz. I think I'm asking quiz questions. When you are able to palpate dorsalis pedis artery, there is no need for you to palpate one of the arteries. Which one? Yes. So why do you want to? Okay, that is unnecessary again. It tells me that you are not aware of this. Okay? Yes. Proceed.
Investigation, hemoglobin, ESR, total count, differential count.
You said there is no discharge from the ulcer.
Mild serious discharge present, ma'am.
Present, you said? Oh.
Okay, everything is normal. Joint is normal, right?
Madam, don't write lower limb arteriovenous Doppler. There's nothing like arteriovenous Doppler. Arteriovenous fistula is there, okay. Arterial Doppler, venous Doppler. So
X-ray foot again, sir. The view. X-ray foot view.
See, if they ask you investigation for ulcer, two important things, right? From the discharge, culture sensitivity, and X-ray of the foot epilateral. That's all, right? These are two important things other than the routine. Everything else you do examine, but specifically if they ask you, there are two important things there. Then if you have not felt the pulses, then you add on to it. If you see varicose veins, then you add on to your venous duplet, right? That's how you have to go about it. Don't mention all the investigations for every ulcer.
Why you are particular about lipid profile? What is martorals ulcer?
Martorals.
So martorals ulcer is seen in hypertensive patient and in old age. It is present on the calf muscles, bilaterally present.
Due to atherosclerotic.
Yes, sir.
So you can say that if you are seeing lipid profile, you must think 10 times. I am ruling out, trying to see the pen. Otherwise, normally don't use all those things. Please try to specific. So you have done that, all normal. What do you want to do?
Management glycemic control, debridement of the wound and clean dressing, broad spectrum antibiotics, regular foot inspection and dressing, and foot care.
What foot care? What foot care? What foot care, you said?
So the wound must be kept dry and
Dry. Wound must be kept dry.
You saw the surrounding skin, right? There is thickness, ichthyosis. One because of aging, one because of diabetes. So you have to use moisturizers. Okay, moisturizers are important, right? Dry skin and ichthyosis will lead on to pruritus. So patient unknowingly will do it in the nights and all. Okay, that may be the cause, right? So you have to use moisturizers.
So if you are ruled out arterial disease in this patient, simple elevation of the leg is important part as the bedside. This is what we expect you to tell during your internship time, a foot care. If provided you are ruled out, arterial disease. What happens if the arterial disease patient, if you elevate like this and put a crepe bandage?
More blood won't be present.
So it may lead to gangrene. Please remember, she is 80. So if you have ruled out that elevation, and then the moisturizers, the dressings, and whatever you have written, most of them, regular this one, dressing, it will heal. Suppose if it is much bigger than that, how much time you think it will take for healing with this conservative? What is the size of this ulcer?
3 cross 3, sir.
3 cross 3.
It heals, okay. If it doesn't heal, is there any ways of covering the ulcer?
So that's what we are
Split skin graft can be done, sir.
Right. How many types are there in it? Superficial? Do you know wolf's graft? Deer's graft? They should know, huh? So superficial is tears, deep is wolf's graft. Then they may ask you one thing, what is the difference between graft and a flap? That's all. Along with the blood supply, you take it as a flap. You take only the skin which derives the blood supply from the base or the where it's from the donor area, recipient area. It is graft. Okay. Full thickness and partial thickness. This is enough for us.
By the picture which you are showing, it may not need a broad spectrum antibiotics. It doesn't look like an infected. So don't put unnecessary antibiotic for an ulcer.
It is already healing. Yes, you said healing ulcer. Then you want to go for debridement? And clean dressing. You want to do a clean dressing or you want to clean the dressing? Okay. So all this is important. The examiner will ask you for this wound, you want to go for a debridement, and you said that it's a tendon.
Yes, ma'am.
Then you will cut off the tendon only. Okay. So for this patient, what are you going to do? A cleaning and dressing will do. As Sir said, surrounding area you should also take care of. Okay. Then the footwear. She is a diabetic. He or she is a diabetic. So the foot care is also important now. Okay. To avoid injuries and all that. Right. Okay.
So that's what, as far as skin grafting is concerned, they'll ask you the types. Split skin graft and full thickness graft. Okay, split skin is Thier's graft. Wolf's graft is full thickness. And for lower limb, we always use split skin graft. Next question they'll ask you, what are the layers of skin? Usually, okay? So what are the layers you are splitting and removing? You say epidermis and the papillary dermis is removed. Okay, you leave behind the reticular dermis so that that area will heal by itself. Okay, this is what they'll ask you. Understand? Thank you.
Thank you. You have done well.
Thank you, sir.
Good.
Thank you, Hepzibah and Steffi, for their case presentation. Thank you, professors, for evaluating and rectifying our presenters' errors. I hope they take this in their stride and do well in the forthcoming examination. Thank you, ma'am. Thank you, sirs.
You welcomed us to stage. You also said, please go down also.
Go down and சொன்னா கொஞ்சம் கஷ்டமா தான் இருக்கும். அதனால please can you take the seats there already provided?
Okay, everyone, it is the moment we have all been waiting for, the grand finale of the quiz session. Without any more delay, please put your hands together and welcome Dr. Rajagopal sir back to the dais and also the prelims winners who will battle it out to emerge victorious. May the best team win. Over to you guys.
Up next, as we prepare for the quiz session, ladies and gentlemen, can I have your attention, please? All right. As we are preparing for the quiz session, don't you think it's high time we had a break in between? So I don't think there is anything better than welcoming Vincy to the stage for a song. Let's hear up for Vincy, everybody. Okay, everyone. I know all of you are very excited for the upcoming sessions, but kindly maintain silence. All right? Let's give it up for Vincy, everybody. That was an excellent performance. Let's hear it for Vinci, everybody.
Okay, so it's time for the quiz. So the first team, Team A will be Apros Fatima and Mohan Shivani.
Okay, then.
Team B will be Hema Priya and Hema Nandini. Team C will be Mudukirtana and Madhura.
Okay.
And Team D will be Gautam and Abhishek.
Hello.
And Team E will be Jasim and Nitish.
Boys are not there, boys. Yes. Good morning to all of you. As the teams are occupying their places, they are going to introduce themselves. I think they don't require special introduction. But still, quickly, can you introduce yourself? Team A. Yeah.
Team A, I'm Apros Fatima and this is Mohana Shivani. From final year MBBS.
Team B, I'm Hemadarni and this is Hemapriya.
Oh, lot of cheers for Team B.
I'm Mutakirtana and this is Madhura from final year MBBS.
Team D. I am Abhishek and this is Gautam.
Myself Mohammed Jason and Nidish from year 2 MBBS.
So you can have this is a very, very simple quiz, so you don't have to worry. There are not much of negative marks, so you can always tell whatever you want, don't worry. Okay, so but participate. When negative marks are there, I am going to tell specifically, okay. So before we start, this question is not for Jailal sir and other people, okay, this rule. Yes, sir. Try also for some late. But that is not the question which I have asked. Anyone knows what disease she had? What? Huh? Hydrocele. So, you know this is one of the most favorite paintings which is there in the Louvre Museum, no doubt. India also has got much, much better painting. That's a different issue. She is supposed to have that pre-senile atherosclerosis. That is what has been, this is available in the internet sources only. If you see her, she died at the age of 37. So this is about Mona Lisa. Okay, we will try what is coming next. Anyone knows this interesting incidents? No problem. Fastest surgeon, that time when the no anesthesia was there, audience only. Any idea? What is the, even if you don't know the name, doesn't matter, but there's some important thing here. Yes?
It was the fastest limb amputation where 3 people died.
Very good. Give me a chocolate. Wow.
Robert Liston.
You can read that.
In 1847, Robert Liston amputated a man's leg in 2.5 minutes. Operation was so quick that he amputated the fingers of his assistant as well. Both later died from gangrene and a spectator reportedly dropped dead from fright, making it the only known operation with a 300% mortality rate.
Thank you. Thank you. Yes, sit down.
Abhijit, Pete.
Abhijit. Yes. Abhijit, you will get chocolate later. Okay. Yes. Anyone? Anyone? Look at the face carefully. Multiple swellings. Multiple swellings. Multiple. Multiple. Guess. 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 Audience. This is for audience. Yes. Neurofibroma. Any guess? Look at the nose. Look at the Deformities. Yes. Disease is hardly there now. Yes. Sorry? Leprosy. No. Look at those bulges. All big swellings. Big swellings. It's a gamma. Okay. Syphilis. Nowadays you don't come across that. This is easy question. Yes, she says. She knows. Loudly.
Operation theatre.
Operation theatre. You know why it's called a theatre? All the earlier government colleges, including where I studied, they used to have a gallery to watch. That's why operating area is called as Operation Theatre. One chocolate for her.
Surya. 5.
So now we'll go to the few starting rounds for the teams. Can you do, yeah, I'll tell the rules. Yeah, okay. So this round is little quickly it happens. Start from the first here only, 1, 2, 3, 4, 5. The first team will get the chance and you will get 10 marks. 10. No negative marks. If you don't answer, second team. Whoever answers next, you only will get 5 marks. Only 5. Okay? Right? So that's how we start from the history. Are you ready? Yes? This is for you. Hold the mic. I think I request all the audience, please maintain silence because all of them are your classmates and friends. So, yes. Name this person. Yes. Quick. I know some of the important personalities. I can, yes. Try. No negative marks. Second team. Third. Fourth. Fifth. Okay. I'll give a clue. He's very popular in the hernia surgery. Hold. Wrong answer. Next. Hey, tell properly. Okay, Lichtenstein's repair. Correct. 5 marks. So, since all the 5 have not answered, I have given this. So, 5 marks to the second team. All right? Now the question is for second team. Second team, get ready. Hello. Shh. Yes. Second team. Hold the mic. Third.
Robert Coach.
Sorry?
Coach.
Very good. Robert Koch. 5 marks. 5. 5 marks for the team 3. Okay. Are you ready? Team 3. Ready? Yes, quick. American surgeon. Very, very famous surgeon. Yes, team 4. Team 5. No? Anyone? Audience, Halstead, who said? Very good. Yes, 1 chocolate for her. Team 4, no? Correct? Yes. Come on. I know a little difficult one, but try. Yes, team 5. Yes. Audience. Guess some surgeons, you go on telling the names, you'll get. Yes? Hamilton Bailey. No, sir. Yes? Sorry? Can't hear. Who? Louis Pasteur. No. Okay, I'll give one important clue to you. In his name, there's one tumor name is there. Dash. Williams is, no, your turn, no? In his name, there's one name is there. Dash. Puffy tumor. Shh. Yes.
Potts puffy tumor.
Potts puffy tumor, but they get only 5 marks. Okay. 5. But the reason is not that, I just gave a clue, but this is how it is. He actually, the chimney sweeper scrotum, highest chimney sweeper cancers. He is the man who said first time environmental carcinogen, that is chimney. And he changed the British constitution in this, changed the law. That is his Percival pot. Okay, right. Question number 5 for you, 5th team. This should be easiest. Shh. This is easiest. This is very easy. Come on, quick. Hold the mic.
Lahis.
Next. Bellini, next. Fizilo, next. Huh? Tell some name, no? Next. Yes, audience. Kryles. Cocker. Okay, I'll give the clue to you now. If you see carefully, left side there is no one finger is missing. You see carefully the left hand of this man, all 3 pictures. One finger is missing. Yes. Oh God. Hamilton Bailey. No, you said Bellini something. You have to tell. Next for you. So Hamilton Bailey lost his left index finger because of the tenosynovitis. After that it was amputated. Right. Come on. Ivor Lewis, wrong. Next. Esophagus surgery. Next. Yes.
Barrel.
Huh? Barrel. Yes, anybody? Audience is looking not very old, no? Like that typical British, it's just some 30-40 years. Esophagus. Ivor Lewis, they said, wrong. So next, try again. One more round chance. Try again. Esophagus, name some surgeries, you will get the answer. Yes, audience? McKeown's wrong answer. Transhiatal esophagectomy or younger. Okay, transhiatal. Yes, next. You. Heart is there. So, heart is there. Clue. Yes. Quick. Heart. Transplantation. No. Surgeon's name. Heart. Clue is the heart. Yes. Hamilton Bailey. No, this one. No. Next. No. Audience. Ayo. Come on. Oh God. This is the famous Arthur Cooley, no? American surgeon. First, this artificial, this is a very famous surgeon. All right. Next. 8. Team C. Get ready. Team C. Definitely not a Dr. Jayalal. So Jayalal will know this. 100%. Surgeon who is MRCS, MRCP, FRCS, physician, chief minister, surgeon, what not. Politician, great politician, honest politician. Yes, chief minister I said. Yes, next. Hold.
Mr. Roy.
Mr. Roy. How can you say Mr. Roy? I want complete answer. Try. No, don't see that. Yes. Audience. I thought you should, sir, no answer. I think, yeah.
Sir, Bindu Chandra Roy.
Yes.
Bindu Chandra Roy.
I can't hear.
Sir, Dr. Bindu Chandra Roy.
Yes, very good. Very good. Is a surgeon, physician. And if you look at that, no? Physician, surgeon, politician, chief minister, and that's how we say Doctor's Day celebration. All right? He died and same day. Who is the next? At least all of us should know some Indian names. All the time we talk about. Yes, in fact, Bailey took almost 20 years to put his data in the real authenticated manner in the book. This latest edition gives this. Any hernia repairs, it goes in Indian name. Next. Hold. Can't. Shoulders repair. Next. Indian sir. Shoulders from Toronto. Stop. No. Yes. That side, audience. Who? Boys. Sushruta. Dasharatha.
Ward and Mayo's repair.
What?
Ward and Mayo's repair.
Mayo. Yes. Backside.
Roy.
So I think you should know this. Tissue repair of Jasarda. That is the external oblique aponeurosis he uses for the repair of the hernia, right? Yes. Who is the next? Next. You? There is some dash appendix. Anyone? He was a famous Hollywood actor, Italian. When he was shooting for the film in California, he developed appendicitis, and somebody operated and died.
McBurney.
Who said No. It was a case of perforated DU. Missed totally. And somebody removed the appendix because the contents have gravitated down. Even today it happens. Yes? Very good. Give her mic.
Rudolph Valentino.
Very good. Excellent answer. Rudolph Valentino. Give her a chocolate. Rudolph Valentino. That's why it's called a Valentino appendix. One more question to audience. Audience, what classification name is this? Classification name. Nowadays we accept for hernia. Yes?
European Society.
Very good. Give me chocolate. Very good.
Because
So European Hernia Society classification. This commonly they ask nowadays, even for UGs. So one round is over. What are the marks?
So at the end of round 1, Team A with 5 points, Team B with 5 points, Team C with 5 points, and Team D and E yet to open their buckets.
Can you read now? Can you read this? Can you read? Everybody should know this.
This is known as one of medicine's most incredible moments. In 1922, at the University of Toronto, scientists went to a hospital ward with children who were comatose and dying from diabetic ketoacidosis. Imagine a room full of parents sitting at their bedside, waiting for the inevitable death of their child. The scientists went from bed to bed and injected the children with new purified extract, insulin. As they began to inject the last comatose child, the first injected began to awaken. One by one, all of the children awoke from their diabetic comas. A room of death and gloom became a place of joy and hope.
This is one of the most, you can call as the most, happy moments in the history. That's why Best and Banning got the Nobel Prize in surgery, Nobel Prize for the insulin discovery. Okay, so this is the classical picture where you can imagine thousands of children dying of diabetic ketosis. First time they all got up, right, from the insulin extract. Yes. Second round we are going to start now. Yeah. So same each question now 20 marks. 20 marks. So be specific. Second team which answers will get 10 marks. All right? Yes. No negative marks. So you are going to start from this. Team B, hello, hold the mic. Team B. I want you to tell the correct diagnosis. Don't tell me carcinoma of the breast.
Inflammatory breast carcinoma.
Very good, 20 marks. Very good. You see that extensive dermal plexus infiltration and the whole breast. There's no lump, the whole breast is a lump. There's a classical infiltrating duct carcinoma, also called as galloping carcinoma, or mastitis carcinomatosis. Yes, for you. Next. Quick. Look at carefully. Yes. Try. Hold the mic. Peutz-Jeghers syndrome next. Hello. D. Try. Look at the patient as a whole. Yes, Team E. Team A. Try.
Men's syndrome.
Men's syndrome, very good. Very good. Why do you say men's syndrome?
Thyroid.
Excellent answer. Look at the thyroid swelling. Excellent. And what is that you are having in the oral cavity? Yes? How did you guess or guess? Thyroid is there. Very good. They get 10 marks actually. 10. What is it they are having in the oral cavity? That's a mucocutaneous neuroma. So what is the final diagnosis? I gave you the marks, but what is the final diagnosis of thyroid? What is that syndrome called as? Sippel syndrome. This is medullary carcinoma thyroid boy. Medullary carcinoma thyroid. Very good. Next. Next is who? Team D. No? Correct? Sorry, 3. C. You know. Correct. Yeah, so they said no, that's why. Yes. That should be...
Carbon.
Huh? Carbuncle. They will get 20 marks. I think sometimes you need element of luck. They got the easier one. But that's also equally important, right? For you, E, Team E. Come on, try. What is that, all the 4 limbs, what patients are having, you tell first.
So dry gangrene.
Dry gangrene, can you improve on that? All the 4 are there, no? All the 4. So, they are typical picture patient to take inotropes, sepsis, vasopressors, hypotension, shock. So, can you just modify that answer? Necrolytic migrate. Next. Huh? Waterhouse Fredrickson.
Peripheral arterial disease.
Peritonitis.
Peripheral arterial disease.
Peripheral arterial disease. Yes. Okay, the team E will get 10, not 20, 10. The final diagnosis is PGs. Final diagnosis, this is called a bilateral peripheral symmetrical gangrene. Typically happens peripheral because of the hypotension, shock, etc. Now we are going to start from you. Shh. They got somehow easy, I think, lucky.
Cold abscess. Tuberculosis cold abscess.
Cold abscess, correct. Anything, improve upon that whole picture if you see. Improve the answer. See the picture full. Improve some more. Hold the mic. Scar is present. Probably was operated for some condition in the abdomen. What is that, baby? Yes? We just discussed today actually. Come on. Yes, next. So 10 marks for this, 10 marks for them. Okay. Yes. So patient was operated for idiopathic tuberculosis. He was on irregular treatment. Then he developed a cold abscess. So 10 for A, 10 for B. Next is B. We started from you, no? Correct? Yes. The first one, that solar keratitis, no.
Malignant melanoma.
Malignant, pre-malignant. Anybody? Yes? Anybody? Anybody? Sorry? Actinic keratosis? No. Look at that, there's a... Yes? Yes? You heard of Paget's disease? Paget's disease, right? Yes. No. Basal cell carcinoma, correct. Can you improve that answer? Hold the mic. Try.
Ulcer proliferation.
No, that is a lesion. Okay, they will get, who said? You are lucky people, 10 marks. PGs? Any improvement? Postgraduates? Madam, you will get prize. Pigmented basal cell carcinoma. Pigmented, okay. Yes, Team E. Actually, these are siblings, brother and sister. Brother and sister. Yes, see. Brother and sister had almost 24 malignancies from the age of 2 or 3. Parents are teachers, actually. They don't have this problem. Both are no more. They died long back. Ultimately, they had some 24 skin malignancies, melanoma, everything. You see the picture, everything is there. Everything, all. The condition is? Condition is?
Sclerosis.
No, not sclerosis. Anybody? Audience? Yes? Sir, sir, Gandhos. Here. Chocolate. Who said? What? Oh, sir, we'll give it to him. Chocolate. Xeroderma pigmentosa. Who gets the 10th question? You. 10th question. For you. One side you are seeing the condition, another side you are seeing a very large squamous cell, typical, averted, everything you can see. Obviously, what is the pre-malignant skin condition? Next, B, C, D, E. Are?
Albinism.
Who said? Okay, 10 marks for them. Albinism, 10 marks. Can you tell the scores now?
Yes, sir. At the end of round 2, we have Team E with 10 points. We have Team A and C tied with 15 points each. We have Team D with 40 points.
Wow.
And the top scorers of this round, Team B with 45 points.
Now I think we are going to start with the Team C, correct? Correct. So, identify some signs. These are all very classical. Classical means classical. There's no. It is written there blue dot. You can see a blue dot there. I give a clue, it's a scrotum. Okay. Yes. Team D. Team E. Team A. You have to hold the. You can't. Check. 10 marks. So negative mark is there. So nobody is answering. Oh. Yes? Audience? See, there is a blue dot, acute. The only 2-3 things can happen with the testis. Yes. So that's what it is. Torsion of the appendix of the testis. Okay. Appendicular torsion. That's, you can see the twisted portion. Next is a D. Somehow they get easy questions. I don't know how you are placed very strategically. Yes. Try. Come on, quick. See carefully the sign. I want the sign. Hold the mic. Come on. If you tell now 20, wrong means 10. Next, E. Yes. B, C, the very classical diagnostic sign.
Belasma.
Huh?
Belas.
What? Who is talking?
Belasma.
What?
Belas.
Belasma. No, you have told what? Belasma. Team C minus 10. Hold the mic.
Platysma.
Platysma sign. Team B will get 10 marks. Next for you. For whom? Next is for you. This is also got somehow easy.
So which was known?
Wrong answer. Minus 10.
Rossius sign.
Spelling?
Troisier.
10 marks. It was the sign which was asked. Sign which was asked. Sorry to take 10 marks. They got the chance. Yes. Yeah, that's the typical description. Yes, for you. Yes. Hold the mic quick. Morning it has been discussed also. Hold the mic. Hold the mic. Tell properly.
Step-ladder peristalsis.
Step-ladder peristalsis. Ten marks for the team B. I have not deducted because they said peristalsis. So I have not reduced your marks. But 10 for you. Okay, next is yours. Yeah, that's typical. Yes.
Murphy's sign.
Huh?
Murphy's sign.
Murphy's sign, 20 marks. Team C. Team C, get ready. Yeah, that's a Murphy's sign. See carefully. It's the renal angle. These are all common clinical problems. That's the reason I brought it. I didn't want to keep any rare things. Yes. It's a renal angle. You can see the 12th rib there. Yes. D. E. A. B. C. No. Okay, suppose I say you will get only 10 marks, but no negative mark. What will be your answer? 10 marks only. Some name you tell now. I am not going to take any negative. Yes? Anyone? Yes? Audience? Sir, not for you. Yes, Murphy's kidney punch test. Murphy kidney punch test. Okay, yes. Who is the next one? Yes. D. Sign is elicited in appendicitis. Shh. Appendicitis. Yes. Your turn. Next, E. Your turn. Yes. Rousing sign, 10 marks. Because when you are pressing, the coils of the bowel impinge upon. That is the original explanation given by Rousing himself. Next is your team. Correct? Corresponding McBurney on the left side. Yes. Come on. Common problem in India. Come on, common problem. You see that dysentery. Yes. Anyone? Maybe point of further explanation. Yeah, chocolate you will get. What the next one? US? US? Next is for you. 20 marks. So, oh, God, easy. Oh, I got easy. McBurney's point, 20 marks. Easy question. You are lucky. Now, Team B. Yeah, that's the McBurney's point.
Sister Mary Joseph Nodal.
Sister Mary Joseph Nodal, 20 marks. Okay, good. Can I have the score? Scores?
Just a minute, sir.
Yeah. Meantime, we'll have one or two questions for our audience so that...
Okay, so...
Yes.
So the scores at the end of round 3. Jasim and Nidish yet to open their boxes again. We have team C with 5 points. We have team D with 40 points again. We have team A with 55 points. And the top scorers, team B with 105 points.
Oh. Yes. Audience.
Sushruta. I'm Kavya S from 3rd year.
Audience. Yes. How the word patient has come? How this word patient has come? Audience. Somebody is telling, yes. Latin word what? Yes?
Latin.
Latin, what? The word, so give him the chocolate. Audience. Audience, fingers.
Sir, I know. Sir, I only know one person. So the
One person everybody knows, sir.
Mohammed Rafi.
Mohammed Rafi, and who is that other person? Very famous music director. Baiju Bawara is one of the most very, very famous movie. The song was Hari Om, and it was R.D. Burman. R.D. Burman never born that time, sorry to say. Old. Naushad. He is actually Naushad, music director. Sir, one chocolate. So, we just have 2 more rounds, so you can still... Yes, where are we starting now? Starting? D, yeah? D. Oh, team D. I think they get some easy ones always. Yeah, that's what I said. They get some easy ones. Come on, quick. Come on. No negative marks. 20 marks. Quick. Team E.
Actinomycosis.
Team A. Team B. Team C.
Tuberculosis.
Loudly.
Tuberculosis.
Loudly.
Tuberculosis.
Tuberculosis, 10 marks. What is the difficulty? Such a common problem. Multiple sinuses, tubercular lymphadenitis. Why did you tell actinomycosis? Next for you. Okay. Yes. These are all your short cases. Typical short case. Look at that, 15 years, long duration. Sternomastoid contraction test, also written there. I think you have to tell the diagnosis. Partly underneath, partly in front. Young patient. Yes, come on. Next. Hold the mic. You have to. Next. B.
Cystic hygroma.
Cystic hygroma. Partly under sternomastoid and partly underneath. If somebody doesn't answer, I will give you marks. Let us see. Yes? Yeah, try. Ranula, I should take the marks back. Anyway, I haven't. Yes? Sebaceous cyst. Yes? Branchial cyst. See, everybody knows there. She said cystic hygroma, that team will get 10 marks. C, you give 10 marks because lymphangiomas you can get. But branchial cyst is the correct answer. Next is who? Diagnosis. It's all case, a short case for you. Typical. Try, no negative marks. Hold. Huh?
Bugus disease.
What disease?
Bugus.
Bugus. Yes. Come on, try. Morning you heard the lecture. Yesterday you heard the lecture. D. E. There is so much discussion. Yesterday happened, today happened. One more round. Anyone? Yes, audience. See? They are all answering. Secondary is in the neck with the ulcerated in the skin. It's a metastasis. Smoker, 65-year-old, unknown primary. Who is the next one? Yours? Team B. Pancreas tumor, wrong answer. Next. Look at that clue there. Some clues are there. Hold the mic.
Lipoma.
Huh?
Lipoma.
Lipoma. Yes?
Sarcoma.
Yes?
Mondes disease.
What?
Thrombophlebitis of
Mondes disease. Anybody audience? Audience? Okay, I'll give the clue. Where we started from? Here. I'll give the clue. Dilated veins. See there? Big dilated veins, large mass there. Rapidly growing. Shoulder. Yes? It's a sarcoma, synovial sarcoma. Synovial sarcoma, very classical, right? Nobody gets. Yes, next. Who is the next you? Team C. Look at that 6 years duration. So, 6 years. While he took bath, he actually fell down 2 times. He was rubbing here, Come on.
So, thyroid malignancy and it invades the carotid.
Thyroid malignancy, the swelling is that. Yes? D. E. 6 years. A. Thyrotoxicosis. Carotid body tumor. Good. Team B. 10 marks. Very good. Very good answer. Good. Yes, who is the next? You. I should have given them 20, but I gave 10. Okay. Because a second round. Yes. Team D. All this has been discussed yesterday and today in the form of different way. Look at those. Bull, like a bull neck. Both. Typical. Yes. Mike.
Multinodular goiter.
Multinodular goiter. Goiter is here or here. So next. Come on, try. E. Yes. Diphtheria. What? Diphtheria. Yes. Try. B. Try. Big ones. Hold. Anaplastic carcinoma. See here that 6 months bulky, bilateral, bulky, bull neck appearance.
So lymphoma.
Yes?
Lymphoma.
Lymphoma. Okay, 10 marks. After so many rounds they tried. 10 marks. Who is the next one? Say 7 means yours is over. E. Okay, E. I think you can see that swelling. All are my cases only. Suprasternal space. There's one swelling. That's how people come. So don't tell thyroid because we wrote written very clearly. FNAC showed some whitish, some. Yes, try. No negative marks.
So abscess in the burns.
Abscess in the burn space. Abscess in the burn space. B. Branchial cyst. Chylus, you should correlate. No swelling is there, white material aspirated. Team E will get 10 marks, not 20, 10. The actual diagnosis is cold abscess. Who said? Somebody said there. One chocolate. Cold abscess is the correct answer. Cold abscess. White. Cheesy material. White. The typical cold abscess. Yours now? Little difficult, but by chance sometimes it comes like that, no? You can see that a vertically oval swelling on the left side in the region of the thyroid which does not move with the deglutition. 5-year duration. In the region of the thyroid, but it is not thyroid. Suboid bursitis, parathyroid adenoma, it won't grow to that extent. Cystic hygroma. Okay, one clue will be given where we started here. Yours. When you are pressing, that patient is to get some dry brassy cough. Laryngocele. Brassy cough means when you press, like hoarseness. Yes. Audience? Schwannoma, correct answer. Yes, who said that? Somewhere there. Schwannoma is a nerve cell, here. Neurilemoma, schwannoma. Next is a team B. Sorry. This is easy. Come on. Neurofibroma. See, you have to give a complete diagnosis. Always. Neurofibroma. Von Reckling-Hassen's disease. Correct. 20 marks. Von Reckling-Hassen's disease. Sorry. Who's the next one? Yours, no? Just you had a talk from madam, not even half an hour back or 1 hour back. You can see the swelling there. Come on, try. Yes. D.
Pleomorphic adenoma.
Wrong. E. Just because I said madam is telling pleomorphic adenoma. E. At least tell something about that. Yes? Submandibular salivary gland enlargement or tumor. 10 marks. How did you miss that? Bidigitally palpable. Who is the next one? D. D is it? Okay. D. No, I think it's over. This round is over. Marks.
At the end of round 4, Team D, the top scorers with 135 points. Then we have Team A with 75 points. We have Team D with 40 points. Team C with 25 points and Team E with 10 points.
Sorry? No negative. No negative marks. I think this will be the last round. If there's any tie, then we'll have one more round. Otherwise, equal marks. So, there are two findings mostly in this. Two. You have a chance to improve now. Team E. If you answer one, you will get 50 marks now. 50. You can beat all these people. Where are we starting? This 5th round. Actually, you. Okay, just get ready. All of you watch carefully. Oh, I'm sorry, madam. I put a wrong slide. I'm very sorry. Extreme. So, this is my most favorite teacher's quotes, because this is the picture they used to put. And surgeon, as especially for our cases, when we see some big thing, we see that and we forget to see. The reason is, whatever is going to come now has something like this. There will be two findings. So, don't be carried away by the shark. Shark is there, shark. Start from E. So the shark is, the big thing is this, but the shark somewhere hidden. Shark is hidden. Madam knows, madam, so easy, but let them try. Yes, if you want, I won't give you a clue, but only after the 5 people round, I'll give a clue. I'll give you one little extra time. Extra time means like this, think. Shark is somewhere else, hidden. Big one is you are seeing. Try no negative marks. Try something. Hold the mic. Hold the mic.
So the top one is basal cell carcinoma.
Hold.
So on the head there is basal cell carcinoma.
Head basal cell carcinoma.
There's a swelling over there.
Okay, next. A.
Neck.
A. Sebaceous cyst. Next. Come on. Try. No negative marks. Thyroid carcinoma neck. Means what? Thyroid carcinoma neck means what? Your turn gone. Sebaceous cyst. Afterwards again. Thyroid carcinoma neck. Yes?
Follicular carcinoma.
Hold.
Follicular carcinoma of thyroid.
And?
Cox sebaceous.
Hold.
Cox peculiar.
Oh, this team
Bony
said
mets.
carcinoma thyroid. This team said follicular carcinoma thyroid and sebaceous cyst.
Bony mets. Bony mets.
Bony mets. Yes. Okay, we'll get 25 marks for this team. 25. Diagnosis is follicular carcinoma of the thyroid with typical scalp swelling. PG is very important. Follicular mainly spreads by blood spread. Flat bones. So, little bit of pulsatile. This lady was admitted as lipoma. They were about to remove. Nobody had examined the thyroid. It was rapidly growing. There's ulcer actually over the swelling there. So this is what some amount of clinical examination all of you should do. Okay? So, starting from you now. So 25 marks they have got. Yes. Little easy I suppose, but I want you to tell the complete diagnosis and it's hold.
Parotid enlargement.
Parotid enlargement. Yes, next B. Hold, tell.
Carcinoma cheek.
Carcinoma cheek. Okay, we'll see. We'll come back to you. Yes, B. Both of you together discuss and talk. She is telling parotid, you are telling carcinoma cheek. Hold, tell. Properly, loudly. Sollu. Yes.
Parotid tumor with facial nerve palsy.
Parotid gland swelling with facial nerve palsy. Yes, next.
Pleomorphic adenoma.
Pleomorphic adenoma
With
the
involvement of the
lateral pterygoid muscles. Yes, okay. D. 50 marks, man. Now 25, of course. Mucoepidermoid carcinoma. Okay. Hold.
Pleomorphic adenoma with tonsillitis.
With the tonsillitis. Madam has told this today. Pleomorphic adenoma with the tonsillitis. Yes, we'll try again. Try. Carcinoma, pleomorphic adenoma. You are all right, parotid correct, but you are somewhere near the answer, but not complete. Yes. Facial nerve palsy. Last chance. Yes, audience. Parotid. What is that, madam? Did one action actually. Dumbbell tumor. Yes, deep lobe enlargement. Parotid with the deep lobe enlargement. See, you can see that such a large one. So, I don't think anybody will get prize here. No marks. Next is who? Shh. Easy question. B. Elderly man, that is a clue. 75 with the loss of weight. See carefully. Shark is there somewhere. Shark is there and swelling is there. So, come on quick. Who has to tell? Hold the mic. 50 marks is there. Pancreas tumor with the Horner syndrome. We'll give them 50 marks. Very good, boss. Ice. Yes, very good. Next. A little difficult first. So I think you are going to win, probably. We don't know. Yes, next. It is a little difficult, but that by chance they are sitting there. What to do? Yes. A lady with the cord-like thickening of the something in the neck. You see the direction. I'll give you a clue. You see the direction of that structure. You see the direction where it is going near the ear lobule like this. And one swelling below. There are two findings. I am showing you the direction towards like this. I can't give you more than that. Yes, next, D. E. This is difficult. I agree. A, B. Sternocleidomastoid is different. This in the subcutaneous plane is feeling like a cord. And one swelling there. It is also soft there, one round like thing, you know. This structure gets thickened. Now I'll give the clue, 25 marks only. Which structure gets thickened in leprosy?
Lymph nodes.
Shh. Somebody said, correct? Yes.
Peripheral nerves.
Yes. Yes. What structure is that? Probably here. Going like that. Spine accessory will go like that? Accessory will not go like that. Post-auricular nerve, peripheral nerve thickening with a abscess there. Leprosy. Leprosy, nerve thickening with an abscess. Yes, next. Who is the next? C, no? C. Who? This is easy. Very easy. Already one of this has been shown here. 50 marks are there. Look at the skin carefully. Skin changes are there. And some, try, 25 at least you can get. Long time. Since birth he's been having all this small things everywhere. Yes, E. Look at the skin. Skin changes. A. Huh? Skin. B. Okay, clue. Some nodules you can see. Multiple nodules, coffee colored, some spots. Come on. Marks are reduced, but you take a clue. Coffee. You drink coffee? You drink. Congenital? Coffee. Hey, what man? See the color there. Coffee. Yes. Capillary spots and multiple neurofibromas, and look at the right side of the neck there. Neurolemoma of the right vagus nerve. This is neurolemoma of the right vagus nerve, partly going into the mediastinum. He had a cough impulse. This is a PG exam case with multiple skin lesion. Typical, right? Okay, with the next one now. You are the one. Next. Mass and the tube. This also has been mentioned yesterday sometimes. Easy for you. 50 marks you will get. 50.
Nasogastric tube.
Hold.
Nasojejunal tube.
Nasojejunal tube. At least he has heard my talk yesterday. Good boy. Yes. But what is that other one? Some mass is there, no? Severe abdominal pain. Admitted to the hospital. 4 weeks over. He's got something there. Very tender. He can't eat.
Pyloric antrum.
Pyloric antrum. Next. Anyway, they will get 25 marks. Okay. 25 marks. Yes. Mike. Quick. See a head of pancreas. Body of pancreas. Acute abdominal pain, some tenderness, mass palpable, epigastrium. That also epigastric mass yesterday I have shown. No marks will be given, so pseudocyst of the pancreas and nasojejunal tube for feeding purpose. Okay, only 25. For you next. Over. Sir. Yes. Sir, J.C. Bade, he's a, so his sign was, when the pseudocyst is enlarging, Ryle's tube, feeling the Ryle's tube in the abdominal wall. So, yes, next is you. Very easy. You got very easy one now. You. Please remember diagnosis and the sign which is given in that other picture. Very, very diagnostic. Yes. Look at that swelling. Look at that area. And look at that picture. No negative marks. Try. Virtuous node. Yes. Look at that structure going up on the other side. See. Yes. Okay. You. Yes.
Common carotid artery.
Common carotid artery. Common carotid artery. Yes. Something. Common carotid artery. Yes. Correct. Correct. Try.
Sir. Carotid body tumor.
Carotid body tumor, 25 marks.
Very silent.
You will not get 50 because the second round. What is that sign?
Very
Very sign. Can you give the answer for that? I can give you 25 marks. Carotid artery? Yes. Common carotid artery? Bifurcation, you can see that. They are separated. So what is this sign called as? Yes? Tuning fork. You are nearer the tuning fork, correct? Yeah, what is that sign called as? Yes? It's a musical instrument actually, lyre sign, okay? Splaying of the carotid artery, very classical of a carotid body tumor. Only that will get 25 marks in this. So this is the carotid body tumor. Who is the next? You? As I told you, the marking which I did in the abdomen was a shark. This patient was treated by some department, medicine and all, for months. As some viral hepatitis, this hepatitis, that hepatitis. Nobody had palpated the abdomen. Yes. Who?
Obstructive jaundice.
Obstructive jaundice. Can you see the age of this patient? Young. And can you see the problem? 23 years he's been having. You think you'll have that kind of, but on and off he used to get. Next.
Congenital hypertrophic.
Congenital?
Hypertrophic pyloric stenosis. Duodenal atresia.
Congenital hypertrophic pyloric stenosis. When you told congenital, I thought to give you 25 marks.
Duodenal atresia.
Yes. Duodenal atresia. Hey, tell me. Look at the eyes.
Sir.
Jaundice is there, correct. So, wait.
Sir, hemolytic disease.
Huh?
Hemolytic disease.
Hemolytic disease, 25 marks, correct.
Splenomegaly and jaundice. So splenomegaly and jaundice is present.
Now they are telling splenomegaly and hemolytic anemia, but ultimately only 25 marks, but that is the final answer. It was a hereditary spherocytosis, okay. 25 marks. 25 marks. Over, huh? Who is the next? 9. Who? No, this is for them because that earlier it has been shown. We'll have one more, only one for remaining now for the other one. Come on, try. There are two aspects in this. Two. Look at the feet and look at the back. Correlate. These are all the exam cases. All are exam cases, whatever has been put here. Look at the feet. Look at the clawing of the claw. Look at the non-healing ulcers. And don't say diabetic neuropathy, leprosy. He's not diabetic, he's not leprosy. Come on, try. Try. That is the back. Here. Back. I have given the clue. Yes, D. D. Come on. E. You can still make it.
So infectious disease.
Infectious disease means what? Infectious disease is very broad. One infectious disease.
Spina bifida.
Spina, bifida, occulta, and I'll give you some marks because you attempted a good answer. Yes? Spina, bifida, you have given a clue to next. With, huh? What? Meningioma. Meningioma. Meningiocele or myelocele or meningocele or meningomyelocele. Correct? Tell. You have to make a myelocele operated. Very good. We'll give you 25 marks. Okay, 25 marks. I think only one remaining. Just. So there are many in this, but yeah. So who is that now? D. Tell. Again, things are very clear. It should be easy for you now. After going through so many cases now, I asked you, have you taken coffee or not also? So he has not taken coffee, it's D. Come on, try. There is a big mass, umbilicus below, there is a big mass is there. Not from bowel, not from urinary bladder, but it is pressing on that. Not from intestine, yes. Try, no harm. Solu.
Enlargement of spleen. Spleen.
Spleen. Gastric. Below the umbilicus. Gastric. Rectus sheath. Large mass hypogastrium pressing on the bladder. Outside it is pushing. Again, you people are not watching carefully, like only when that peritonitis. Ovarian torsion. Patient was a it's possible sometimes to get ovaries in males also.
So omentum.
Omentum. Okay, man. Again, give a clue to you. Skin, you can see the capillary spots. Again, capillary spots. And what are they more prone for? Yeah, somebody has answered the capillary spots. Good. Yeah, okay, yes.
Is it retroperitoneal tumors?
Very good. Retroperitoneal tumor. Very good. See, they are answering. Retroperitoneal tumor, correct. Looking at the general examination finding, that's why we tell, general physical examination. Look at the skin there. Retroperitoneal, typically called as nerve sheath tumors. Large retroperitoneal nerve sheath tumor, rapidly growing, causing compression of the bladder, and this is what is, they are more prone for sarcomas. That's typical. Again, classical nerve sheath tumor. Okay, I think I will stop now. We'll tell the final results. He is going to announce. So, there are many in this, but I think we'll stop. Yeah, just give me the pen.
At the end of 5 rounds, in the 5th place, we have Gautam and Abhishek from the 3rd year of MBBS. In 4th place, we have Muthu Kirtana and Madhura from the final year of MBBS. in a shocking twist of events and giving a tough fight, we have Nidish and Jasim in the third place from the second year of MBBS. Before I announce the winners, congratulations to all the participants. In second place, we have Apros Fatima and Mohana Shivani from the final year. And last but not the least, the winners of the quiz, Hema Priya and Hema Dharini from the final year of MBBS, everybody.
How come, man?
Let's give all our quiz participants a huge round of applause.
So our publishers have been kind enough to provide some books as prizes for the 3 teams. Okay, so that first team will get that and that other book. Yeah, you also come, so that they need that. For who are the call the first, the third one. These 2. This is for. This is clinical, dental also. You keep it separate. That is for the library. This is for the team's second. This is for team first. 2 books of that, correct. This is team 3. Madam, you also come. I request Dr. Jailal sir, Srinivasan sir, Balaji sir, all of you sir, come.
I request all the
Sir,
dignitaries
all
to
of
join
you.
us on stage and help us felicitate our winners. Let's give them a huge round of applause. May I request our senior professors from our college also to join us on stage. Please, ma'am. Please, sir.
Call the third prize first. 1 minute, yeah.
And in third place, we have Jasim and Nidish from the second year of MBBS.
Oh. Thank you. Madam, sir, please. I told all of them. Call. Balaji.
Let the cheers keep rolling. Come on, everybody.
Sir, come. Sir, you come. Please give. Please give. You give. Sir, thank you. Yes.
Actually, they are the first, sir. Then they are juniors.
Okay, good.
They are supposed to be the first winners. Very sorry.
No, that's fine. Very good. You stay a little backside now. We'll call
They really did give a tough fight. Let's hear it up for them, guys. Come on.
Second.
Up next, the second prize winners, Apros Fatima and Mohana Shivani from the final year of MBBS.
Balaji, you put it there. 1 you give. Sir, Jailal sir, stand.
Let the cheers keep rolling. Come on, everybody.
Thank you.
On that note, it's time to welcome the winners of the quiz. Let's hear it for Hema Priya and Hema Dharini from the final year of MBBS.
Come. Madam, you go to that, you give 1 book to that girl and 1 to the servant. Madam, keep the book like. Yes. Correct. Thank you.
Before we can let them go, let's hear it up for them once again, everybody.
Sir, congratulations. All the best to you. Well done. Okay.
May I request all our Kindly stay back on the dais.
You keep that plastic open.
Congratulations, winners. Thank you, Dr. Rajagopal, sir, for that absolutely brilliant session. Let us give sir a thunderous round of applause. Dr. Rajagopal Shenoy, sir, the man behind... Dr. Rajagopal Shenoy, sir, the man behind most of us clearing our university exams and who simplified the general surgery for all of us. We are all honored and glad that you made our session even greater and grander. We deem it our esteemed privilege to have been in attendance of all your sessions. With the utmost privilege, may I request our general surgery department to felicitate Dr. Rajagopal Shenoy, sir. Please, professors.
Sir deserves nothing less than a standing ovation. Let's give it up for Dr. Professor Dr. Rajagopal Shenoy. Everybody could stand in the center for a photograph, sir. May I request the surgery department PGs and the entire department to kindly join us on stage. May I request all the PGs, senior professors to kindly join us on stage. Unitan sir, please join us on stage. That, ladies and gentlemen, is the entire team of Smart for You. Let's hear it up for everybody, guys. Thank you so much, professors. Thank you so much, everybody, for joining us on stage.
All right, everyone, time for lunch. We will break for lunch now, and all of you are expected to be back by 2:15. May I extend my sincere thanks to our scientific coordinator, Dr. Amuda ma'am, for the smooth sail of today's first session. See you all soon, sir.
All the students are requested to stay back for a minute. Kindly be seated. Kindly be seated. Students, kindly be seated.
So because no, madam. Somebody wants to dance, they can dance. I don't know. My songs are not for dancing songs, okay? They are for romantic songs actually. Only couple can do it. Who is Satya? So this is an old song taken from the movie. Many of us were not born that time. Movie is Madhumati. So very old song. I don't know whether you like it or not, but whether you like it or not, you have to sit in the hall. Okay, all right. I hope that is. Anybody knows the song? सुहाना सुहाना सफर और ये मौसम हसी सुहाना सफर और ये मौसम हसी हमें डर है हम खो न जाए कहीं सुहाना सफर और ये मौसम हसी सुहाना सफर और ये मौसम हसी ये कौन हंसता है फूलों में छुप कर बाहर बेचैन है किसकी धुन पर ये कौन हंसता है फूलों में छुप कर बाहर बेचैन है किसकी धुन पर कहीं रुंझुन के जैसे नाचे जमीन सुहाना सफर और ये मौसम हसी सुहाना सफर और ये मौसम हसी हमें डर है हमको न जाए कहीं सुहाना सफर और ये मौसम हसी ये गोरी नदियों का चलना उछल कर के जैसे अल्हड़ चले पी से मिलकर के जैसे नदियों का चलना उतर कर के जैसे अल्हड़ चले पी से मिलकर प्यारे प्यारे ये नजारे निहार है हर कहीं सुहाना सफर और ये मौसम हसी हमें डर है हम खो न जाए कहीं सुहाना सफर और ये मौसम हसी ओहो हो ओहो हो ओहो वो आसमां झुक रहा है जमीन पर वो आसमां झुक रहा है जमीन ये मिलन हमने देखा यहीं पर वो आसमां झुक रहा है जमीन पर ये मिलन हमने देखा यहीं पर मेरी दुनिया तेरे सपने मिलेंगे शायद यही सुहाना सफर और ये मौसम हसी सुहाना सफर और ये मौसम हसी हमें डर है हमको न जा
जाए कहीं सुहाना सफर और ये मौसम हसी।
Thank you. Thank you very much.
Thank you so much, sir, for that wonder-starring performance. Let's hear them for everybody. All students are kindly requested to stay back. Please be seated in your seats.
சொல்றேன் அவன் கேட்கவே மாட்டேங்கிறான். இப்போ வந்து வயிறு வலி அப்படின்னா என்னங்க பண்ண முடியும்?
மச்சான் மச்சான் மதியம் சாப்பிட்ட ஒரு கலக்கி ஏதாவது அவனுக்கு கலக்கி இருக்குமோ?
ஓ அப்படியா, சரி பாப்பா மச்சி.
டேய் மச்சான் 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 அவனுக்கு உண்மையிலே முடியலடா
மச்சான், ஜுரம் வேற அடிக்குதுடா
மச்சான். தூக்கம்டா அவனை மச்சான். வாமிட்டர் எடுக்கறான்டா.
The patient is taken to the hospital. Scene 2 EMD ward.
அண்ணா இது என்னாச்சு என்னாச்சு? பயப்படாதீங்க பயப்படாதீங்க.
மேடம் இது ஆக்சன் மேடம். இவனை வெளியில விட்டு பாருங்க, இவனை வெளியில விட்டு பாருங்க. இல்லாத வேலையெல்லாம் பாப்பா மேடம்.
மேடம் மேடம் உண்மையிலே எனக்கு வயிறு தான் மேடம் வலிக்குது.
இல்ல 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 இன்னும் பெரிய பிரச்சனை இருக்கு. சரி சரி பயப்படாதீங்க பயப்படாதீங்க. நீங்க யாரு?
நாங்க அவனோட ஃப்ரெண்ட்ஸ் மேம். நாங்க காலையில ரூமை தட்டி உள்ள வரும்போது பார்த்தா அவன் வந்து வயிறு வலின்னு படுத்திருந்தான் மேம். அப்புறம் தொட்டு பார்த்தா ஜுரம் அடிச்சு திடீர்னு வாமிட் எடுத்துட்டான் மேம். அதனால நாங்க இங்க கூட்டிட்டு வந்தோம்.
பேஷண்ட் பேர் என்ன?
கோபால்.
வயசு
18 மேம்.
சரி சரி ஒன்னும் பயப்படாதீங்க. நான் டாக்டரை கூட்டிட்டு வரேன், எல்லாம் சரியாயிடும், பயப்படாதீங்க.
நண்பனை எப்படியாவது காப்பாத்திருக்கேன் மேம்.
கண்டிப்பா கண்டிப்பா காப்பாத்திடுவோம். வந்துட்டீங்கல்ல? இல்ல இப்போ இது என்னாச்சு? பையனை பார்த்தா நடிக்கிற மாதிரியே இருக்கே, என்னாச்சு? எப்போத்துல இருந்து வலிக்குது?
நேத்து நைட்ல இருந்து ரொம்ப வலி டாக்டர். இன்னைக்கு காலையில ரொம்ப அதிகம் டாக்டர். தாங்க முடியல டாக்டர்.
ஓகே ஒன்றும் இல்லை பெயின் இருக்கிறத பார்த்தா ரைட் இலியாக் ஃபோஸால இருக்கிற மாதிரி இருக்கு. இப்போ நான் வந்து என்ன சைன் எலிசிட் பண்றேன்? மர்ஃபி சைன் மேம். ஓகே எந்த பாயிண்ட்ல வந்து இப்போ நான் வந்து பார்க்குறேன்? It is medial 2/3 and lateral 1/3 of the line joining the umbilicus and anterior superior iliac spine. அந்த பாயிண்ட் பேர் என்னது? அது வந்து மர்ஃபிஸ் பாயிண்ட். மெக்பர்னிஸ் பாயிண்ட். ஓகே இப்போ நான் என்ன எலிசிட் பண்ணேன்? ஓகே, இது பார்க்க வந்து அக்யூட் அப்பெண்டிசைட்டிஸ் மாதிரி தான் இருக்கு. நம்ம வந்து இன்வெஸ்டிகேஷன் போகலாம். பிளட் இன்வெஸ்டிகேஷன் அண்ட் யூஎஸ்டி ரிப்போர்ட் வந்து நீங்க ரிசல்ட் வந்தோடனே கொண்டு வாங்க.
சரி.
பேரண்ட்ஸ்க்கு இன்ஃபார்ம் பண்ணிட்டீங்களா?
உடனே பண்ணிடுறேன் மேம்.
Gopal's parents get a call from the hospital while they are at their home.
நீங்க உடனே போய் பேஷண்டோட பேரண்ட்ஸ்க்கு இன்ஃபார்ம் பண்ணிடுங்க. சரி, பயப்படுறதுக்கு ஒன்றும் இல்லை, டாக்டர் எல்லாம் பார்த்துப்பாங்க.
அப்பா 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 ரீல்ஸ் பா ரீல்ஸ் பா ரீல்ஸ் பா ரீல்ஸ் பா ரீல்ஸ் பா. எப்ப பாரு உனக்கு இதே பொழப்பு. இரு எடுத்து தரேன். வாட்சும்கா வாட்சும்கா வாட்சும்கா. காலங்காத்தால ரெண்டு பேரும் டான்ஸ் ஆடிட்டு இருக்கீங்க, வேலைக்கு போலையா? இரு, அவளே வந்து இப்பதான் கேக்குறா, நீ ஏன் வந்து குறுக்க வந்துட்டு இருக்க? நீ நல்லா தானே ஆடிட்டு இருக்க, போய் ஆடிட்டே இரு. என்ன உன் தம்பி காலையிலே கால் பண்ணிருக்கான், என்ன விஷயம்? ஹலோ
ஹலோ
கோபால், என்னாச்சு காலையிலே கால் பண்ணிருக்க?
நான் கோபால் இல்லம்மா, கோபாலோட ஃப்ரெண்டு பேசுறேன்.
என்னாச்சு?
கோபாலுக்கு ஒன்றும் இல்லம்மா, அவன் சும்மா வயிறு வலின்னு சொல்லி படுத்திருந்தான். நாங்கள் போய் பார்த்து ஒன்றும் பிரச்சனை இல்லைம்மா, அவனை கொண்டு போயிட்டு எங்கள் ஹாஸ்பிட்டலில் நல்ல ஹாஸ்பிட்டலில் அட்மிட் பண்ணியிருக்கோம்மா.
ஓ சரி, இப்ப நாங்க வரணுமா? அங்க ஏதாவது அட்மிட் பண்ணிருக்க வர சொல்லிருக்காங்களா பேரண்ட்ஸ்?
ஆமாம்மா, நீங்க கண்டிப்பா வந்து பார்க்கணுமா.
சரி,
ஒன்றும் பதட்டப்படாதீங்க, நீங்க வந்து பார்த்தா மட்டும் போதுமா.
சரிப்பா. என்னவா தம்பிக்கு? காலையிலேயே ஏதோ எக்ஸாமுக்கு பிளான் பண்ணிட்டான். சரி, என்ன இப்ப போகணுமா ஹாஸ்பிட்டலுக்கு? நீங்க ரெண்டு பேரும் அவனை கரிச்சு கூட்டிட்டே இருங்க. வாங்க நம்ம போய்.
அவனுக்கு உருட்டுறதே பொழப்பா வச்சிருக்கான்.
வாங்க போவோம். வாங்க வாங்க போலாம்.
Scene 4, hospital.
இன்வெஸ்டிகேஷன் ரிப்போர்ட் வந்துச்சா?
எஸ் மேம்,
ஓகே.
வந்துச்சு.
சர்ஜனுக்கு கால் பண்ணி இன்ஃபார்ம் பண்ணுங்க.
ஓகே மேம், நான் உடனே கூட்டிட்டு வரேன் சர்ஜன்.
டாக்டர் இதான் பேஷண்ட். என்னாச்சு
மேம்? நான் எக்ஸாமின் பண்ணல வந்து அக்யூட் அப்பெண்டிசைட்டிஸ் மாதிரி இருந்தது. நான் இன்வெஸ்டிகேஷனுக்கு அனுப்பியிருக்கேன்.
பேரண்ட்ஸ்க்கு இன்ஃபார்ம்
எஸ்
பண்ணிட்டீங்களா?
மேம், இன்ஃபார்ம் பண்ணியாச்சு மேம்.
இன்வெஸ்டிகேஷன்ஸ் வந்துச்சா?
எஸ் மேம், இதோ ரிப்போர்ட்ஸ் மேம்.
ஓகே, டோட்டல் ஈகோசைட் கவுண்ட் வந்து எலிவேட்டடா இருக்கு. அல்ட்ராசவுண்ட்ல வந்து அப்பெண்டிகுலர் டயமீட்டர் வந்து மோர் தென் 6 mm வந்திருக்கு. அது பெரிய அப்பெண்டிகுலர் ஃப்ளூயிட் கலெக்ஷன் இருக்கு. சரி, ஓகே. நம்ம இப்போ ஸ்கோரிங் வந்து என்ன பண்ணுவோம்? அப்பெண்டிசைட்டிஸ், அக்யூட் அப்பெண்டிசைட்டிஸ்க்கு
அலவராட்டோ ஸ்கோர் மேம்.
புரியல.
அலவராட்டோ ஸ்கோர்.
ஓகே, அதுல என்னலாம் வரும்?
மென்ட்ரல்ஸ் மேம், மைக்ரேட்டரி பெயின்.
ஓகே, சரி. அதுல இப்போ இந்த பேஷண்ட்க்கு எவ்வளவு ஸ்கோரிங் வருது?
8 மேம்.
ஓகே, இப்போ என்ன சர்ஜரி பண்ணும்?
அப்பெண்டிசெக்டமி பண்ணணும்.
ஓகே, இப்போ நம்ம அப்பெண்டிசெக்டமி தான் ஃபாலோ பண்ணிட்டு இருக்கோமா? இப்போ நியூர் மொடாலிட்டி என்ன? இப்போ என்ன கோல்ட் ஸ்டாண்டர்டா ஃபாலோ பண்ணிட்டு இருக்கோம்?
மாடிஃபைட் அப்பெண்டிசெக்டமி, லாப்ரோஸ்கோபி பண்ணலாம்.
ஓகே, சரி. ஓகே டாக்டர், நம்ம பேஷண்டோட பேரண்ட்ஸ் கிட்ட கன்சர்ன் வாங்கிட்டு சர்ஜரிக்கு ஆப் பண்ணலாம். நர்ஸ், நீங்க போய் கன்சர்ன் ஃபார்ம் எடுத்துட்டு வாங்க. ஓகே டாக்டர். ஹலோ, கோபாலோட பேரண்ட்ஸ் சார். ரிப்போர்ட்ஸ் வந்துருச்சுமா. அப்பெண்டிசைட்டிஸ்னு வந்திருக்கு. அதுல ஆமாமா, அப்படிதான் ரிப்போர்ட்ஸ் வந்திருக்கு. ஒன்றும் இல்லைம்மா, லைட்டா ஒரு வீக்கம் இருக்கு. அது ஒன்றும் இல்லை, சின்ன சர்ஜரி தான், உடனே பண்ணிடலாம். பண்ணா ஒரு ஆமாமா, நானும் ஃபர்ஸ்ட் வயிறு வலி, கேஸ்ட்ரைட்டிஸ் அந்த மாதிரி இருக்கும்னு தான் நினைச்சோம். ஆனா இப்போ வந்து ஸ்கேன் பண்ணி பார்த்ததுல அப்பெண்டிசைட்டிஸ் தான் வந்திருக்கு. ஐயோ, சர்ஜரியா? சரி சரி, ஒன்றும் ஆகாது டாக்டர், காப்பாத்திடலாம்ல.
அதெல்லாம் ஒன்றும் இல்லைம்மா, அதெல்லாம் சரி பண்ணிடலாம். சின்ன சர்ஜரி,
எப்படியாவது காப்பாத்திருங்கம்மா ப்ளீஸ்.
அதெல்லாம் ஒன்றும் இல்லைம்மா, சின்ன சர்ஜரி தான். அதுக்கு நீங்க கன்சர்ன் கொடுத்தாதான் சர்ஜரி பண்ண முடியும். ப்ரொசீஜர் வந்து
ஒரு சின்ன கீரல் விழுந்தா கூட தாங்க மாட்டேன் என் புள்ள, பச்சை மண்ணுங்க. சரி சரி, எல்லாம் டாக்டர் பார்த்துப்பாங்க, நீ அழாத.
லாப்ரோஸ்கோபிக் அப்பெண்டிசெக்டமி பண்ண போறோம். அம்மா கிட்ட நீங்க எக்ஸ்பிளைன் பண்ணுங்க. இந்த மாதிரி சின்னதாக தான் ஒரு ஓட்டை போட்டு தான் சர்ஜரி பண்ணுவோம். பெருசா ஸ்கார் எதுவும் வராது. பேஷண்ட் வந்து 24 மணி நேரத்துல டிஸ்சார்ஜ் பண்ணிடலாம். ஓகேவா? கன்சர்ன் ஃபார்ம் வந்து நர்ஸ் எடுத்துட்டு வருவாங்க. நீங்க அதை வந்து சைன் பண்ணா போதும்.
ஓகே டாக்டர்,
தேங்க்யூ. அவ்வளோதான்.
The surgery is completed successfully and the patient, Mr. Gopal, is shifted to post-op care. Thank you. Thank you so much.
Thank you, final years, for that absolutely brilliant show. Let's hear it for them once again. The next topic up for discussion is something I'm very sure all our seniors, professors, and even HOD sir has repeated time and again in all our posting classes. So to give us all a recap, elucidate, and give us an idea, it is time we discuss the few pathologies associated with the breast, which will serve as exam reviews. So watch and learn carefully. To give us an insight into the topic, approach to benign breast diseases, may I have the pleasure of inviting Dr. Balaji Singh sir, Professor and Head, Department of General Surgery, Sri Ramachandra Medical College and Research Institute, Chennai, to the dais. Please help me welcome sir with the largest round of applause.
So, good afternoon. I thank the management and the Department of Surgery for inviting me. Currently, I am not the HOD. I am a Professor of Surgery and Dean of the Medical College. But I'll tell you, firstly, you are all blessed.
With immense pleasure, may I have the privilege of welcoming sir who graced our session and shared various case presentations since yesterday. Sir, we are deeply honored and blessed by your presence. May I now request the entire team of General Surgery, SMIMS, to kindly join us on stage and help us felicitate Dr. Jailal sir. Please, professors. May I also request Balaji sir to kindly join the felicitation. Let's give him a large round of applause, everybody. Let the cheers keep rolling, everybody. Thank you so much, sir. Thank you, professors.
okay? Sorry, so I was just telling you, you're all blessed because I have never seen an undergraduate program in my lifetime. See, I have 35 years of experience as a teacher. I've never seen an undergraduate program so well organized. And also, student participation. See, ultimately you are the learners. We just teach how you grasp things. I saw the role model, role play. It was so nice. Before that, I was also witnessing your quiz, how committed you were. So it was nice. That shows the student commitment to this academic event. So first of all, I thank the Department of General Surgery for inviting me. As far as undergraduates are concerned, okay, benign breast disease, you may get 2 short notes, mostly about fibroadenoma, or they ask about Andy, right? Only these 2 short notes will be asked. Take it from me, right? But you should generally know what are the benign breast disorders that you may come across. I'm sure it will be useful for second years as well, because a little bit of pathology is also involved in it. So I think postgraduates are very few. Mostly it's undergraduates. So again, another simple tip. If a breast case is kept as a short case, it's fibroadenoma. If it is kept as a long case, it is CA breast, 100%. That's how it is. So, normally, fibroadenomas, most often you get in young patients. So whichever batch, more girls are there, usually we keep a short case fibroadenoma as a case. So that's how we all teachers think when we allot cases in the exams. Okay? So as I said, Andy is a short notes for you all, right? And in this, you do also get a lot of MCQs, right? It's nothing but aberrations of normal development and involution of the breast. It's a broad spectrum, okay? It includes variety of benign breast disorders occurring at different reproductive periods in the females, early matured and involution phase of reproductive age group. All conditions should be carefully clinically examined. You know why? Of late, it's not like we were taught above the age of 40, any woman who comes with a lump in the breast has to be taught as CA breast until otherwise proven. But of late, I'm telling you, dear students, young patients we are seeing. You know why? Physical inactivity is one of the reasons. Number 2, obesity is one of the reasons. Thirdly, diet. All these put together, of late, we see young patients. As young as 21, we have operated a CA breast. Okay? So that's why you have to carefully examine, be highly suspicious, then you have to proceed. So it's normally based on 3 phases of physiology of the breast. That is, initially lobular development occurs, then cyclical hormonal modification happens, then involution occurs. In all the 3 phases, you get spectrum of diseases, right? So now I said in the early reproductive age group, that is between 15 to 25, normal lobule formation may cause aberrations as fibroadenoma. Okay, fibroadenoma. And we call it as a giant fibroadenoma if it is more than 5 centimeter in size. And normal stroma may develop juvenile hypertrophy as aberration and causes multiple fibroadenomas. Okay, between 25 to 40 years, okay, normal cyclical hormone effects on the ground. You all know there are receptors, right? So ER receptors, progesterone receptors, and estrogen receptors, okay? So normal cyclical hormone effects on glands and stroma get exaggerated by aberration, causing generalized enlargement. And cyclical mastalgia, okay, with nodularities also occurs, and it's either called as fibrocystadenosis or fibrocystic disease, either of it you can call. Okay, now only that anti-terminology came. Initially it was all called as fibroadenosis. Then involution age group, that is between 40 and 55. So we have lobular invasion with microcyst, fibrosis, adenosis, apocrine metaplasia, and eventually aberration as microcyst of the breast, okay? And ductal involution may cause ductal dilatation and nipple discharge as an aberration. And epithelial changes lead to epithelial hyperplasia and atypia. This is where we have to be careful. And we do tell even a benign breast disease can turn malignant. And this is this situation wherein when there is epithelial hyperplasia and atypia, you can get cancer breast. So fibroadenoma, it's a benign encapsulated tumor occurring commonly in a younger age, between 15 to 25 years of age, and it is presently considered as hyperplasia of the single lobule of the breast, and it is the most common benign disorder of the breast under the age of 30. It's an MCQ. Okay, it's an MCQ. You should know that. It's an aberration of normal development of a lobule. Okay, it shows similar hormonal activity of normal breast like lactation, okay, perimenopausal involution. And incidence is 15% of palpable breast lumps. It is bilateral in 20% of the cases, and it's again by 20% are multiple, you remember that. And juvenile fibroadenoma occurred in adolescent age group. It is quite rare. Okay, it is clinically mimic, because the juvenile fibroadenoma may clinically mimic phylloid tumor, but does not turn into phylloids or malignancy. It can clinically mimic. So what will be the complex fibroadenoma? You do get fibrocystic disease along with fibroadenoma, then we call it as complex fibroadenoma. Occasionally it may turn into malignancy, as I said, when there is epitheliosis and epithelial hyperplasia and atypia, it can turn malignant. So don't have a notion that a benign breast disease doesn't turn into malignant. It is a pre-malignant lesion. You should remember that. And 30% of fibroadenomas may disappear or reduce in size within 2 to 4 years. But 10 to 15% will increase in size. And fibroadenoma will never turn into malignancy at all. This is just a fibroadenoma, a picture of it. Okay, grossly, clinically we call it a soft and hard and giant. 3 types of fibroadenoma. I said it will be asked as a short notes for you all. You can mention as soft, common after 30 years, it is more cellular. Hard, commonly below 30 years, it's more fibrous. And giant fibroadenoma, it is more than 5 centimeter. So microscopically, I am sure most of the pathology students would have already seen these 2 slides, which is commonly kept in your beginning of your pathology postings. It is intracanalicular and pericanalicular. So they are like painless swelling, okay, which are occasionally noticed by the patient while taking bath. They are smooth in consistency, firm, and we also call it as mouse in the breast. You know why? It freely moves within the breast tissue. So there are 2 things you have to know in the exams, whether the lump is moving within the breast tissue or with the breast tissue. If it moves with the breast tissue, it is malignancy. If it moves within the breast tissue, it is fibroadenoma. That's why we call mouse in the breast. Okay, and obviously it's not malignancy, so axillary nodes are never ever involved. Okay, but investigations, when you can do mammography, giant fibroadenomas, you can do a FNAC, and ultrasound to confirm the solid nature, because one of the things which can be a DD for a fibroadenoma is antibioma. In that case, right, if you do a ultrasound, it may say it is solid or just a cystic. Obviously, this is the mammogram picture. You can see a well circumscribed lesion. This is fibroadenoma. Okay, the treatment is excision with circumareolar incision, a cosmetic. So most often, as I said, it moves within the breast tissue. You can bring the lump close to the areola, give a circumareolar incision, and you can remove the lump in toto. And if there are multiple, you need not do anything. You tell the patient, nothing will happen, don't get worried or alarmed. Okay, it may regress as the day goes by. Okay, so you can always tell. Fibroadenoma, which is small, single, less than 30 years, can be left alone with just regular follow-up. So this is an X-ray specimen of a fibroadenoma. That's how it will look. So indications for surgery. Usually, if it is more than 3 centimeter, multiple in the same breast, giant type, recurrence, and cosmetic purpose, and complex type. Why complex type is? Because it also has fibroadenosis component in it, which may not be responding to your conservative line of treatment. In that case, patient may have pain, and pain may be the indication to operate upon in a complex fibroadenoma. This is about fibrocystic disease or fibrocystadenosis is the latest terminology. So it is due to aberration of the normal development and involution of it. Again, in a spectrum of AND you get it. It presents with cyclical mastalgia and you will have a nodular feel. Okay, that's why all clinical examination of the breast, you should palpate with the pulp of your fingers across, either goes Z-wise or circumwise, okay, circumferential wise. Only then you will be able to appreciate small swellings, nodules and nodularities. And again, as you all know, it's more common in the upper outer quadrant. That's because more glandular breast tissue is in that region. So most of the fibroadenosis, malignancy, everything is common in upper outer quadrant. The reason being more glandular tissue is there. So when there are a lot of cystic components, you may have variable consistency. Okay, initially it should be aspirated, and if recurs, then surgical excision is required. When diffuse small multiple cysts are present, okay, that is called as Schimmelbach's disease. It is most common breast disease earlier days. It is common in upper outer quadrant, as I already mentioned. It is exaggerated response of breast stroma and epithelium to the hormones and growth factors. So it is mostly hormone dependent. That's why you get this particular disease in active reproductive age group. So again, there are classifications. You may not need it. Mostly postgraduates should know about it. Non-proliferative and proliferative with atypia, that is severe aplasia, and proliferative with atypia is a risk factor for breast cancer, as I already mentioned. So the stages are stromal proliferation or hyperplasia, adenosis, and cyst formation. The pathophysiology is estrogen predominance. Okay, that's why estrogen predominance will be there in these patients, and progesterone is suppressed. Okay, right? And luteal phase is shortened, and progesterone level decreased to 1/3 of the normal, and corpus luteum deficiency and anovulation occurs in 70% of these patients. Patients with premenstrual tension syndrome tend to get this, and prolactin levels are increased 1/3 of, mostly in 1/3 of the women in such cases. I'll tell you, this slide is mainly for postgraduates. You just, if at all you want, you just brush up, no problem. These things again, it's, but presentation during menstruating age group, as are mostly they are bilateral. Remember, bilateral, it is painful, it will be diffuse, glandular, and tender swellings will be there. And as I said, it's common in the upper outer quadrant. Pain and tenderness are most just prior to menstrual cycle. That's why we call cyclical mastalgia. Once at that time there will be surge of hormones or more. That's why you get pain at that time. It subsides during pregnancy and lactation because the hormone level decreases, and as they go close to menopause, almost the disease disappears. Very occasionally, enlargement of nodes can be present in this. In that case, you have to be very suspicious, and all these patients will need mammogram. FNAC, ultrasound and mammography is the must. Okay, and treatment. Initially, conservative line of treatment is preferred. Drugs that are used are oil of evening primrose. Everyone will be writing capsule Simrose a day and all. Okay. Then gamolonic acid, 120 milligram per day. Danazol, you have to be very careful when you use danazol. You give only above the age of 40, not below 40, because they can get hirsutism and other things. Okay. Then bromocriptine with low dose of prolactin lowers the prolactin level. So it can be given. Tamoxifen, again, is an anti-estrogen, can be given. And vitamin E and B6 are also tried for this. Okay. So indications for surgery, not every patient we subject for surgery, only when they have intractable pain. Florid epitheliosis and FNAC, because as I said, it has a potential to turn malignant. So obviously the pathologist will write, if the FNAC shows florid epitheliosis, patient needs surveillance. So they need surveillance. Every 6 months better to do a mammogram, and so that if at all it turns malignant, you can catch up early, you can treat as early breast cancer. Okay. Then subcutaneous mastectomy with prosthesis placement if the whole breast is involved. Okay. Or excision of the cyst if it is only segmental. We call it as segmental excision, upper outer quadrant, where it is more painful and where there are more glandular feel. Only that area we can remove, and that is called segmental excision. So this is a phylloid tumor. Okay, it's also again a short notes. That's why I am going to emphasize on 3 important things. Fibroadenoma short notes. Okay, then fibrocystic disease is a short notes. And again this phylloid tumor again is a short notes. And in exams also they will ask you about the ulcer, how it is formed, right? So it's also called cystosarcoma phylloids or a serocystic disease of body. They show a wide spectrum of activity, varying from benign condition to a locally aggressive and sometimes as a metastatic tumor. So you have phylloids benign and phylloids malignant. Okay, depending on mitotic index and degree of pleomorphism, they are graded as low grade or high grade. Next is when malignant, it spreads to the bones and the lungs. So this is an example of a malignant phylloids. Okay, and most often, see, if carcinoma ulcerates, okay, it will be a ulceroproliferative lesion. Whereas here, if it ulcerates, it is due to the necrosis of the skin. They'll ask the difference about the ulcer. What ulcer you get in phylloids and what ulcer you get in malignancy. Malignancy, you get ulceroproliferative, it can bleed. Okay, whereas here, it is due to the necrosis of the skin and you will have undermined edge. You have to use a probe and see it will be undermined edge. Okay, so that's how it will be like. This thing, right? The difference between ulcer in a malignancy and this thing, right? Microscopy, it contains cystic spaces with leaf-like projection. That's why we call phylloid tumor. Cells show hypercellularity and pleomorphism. It may be a variant of intracanaliculair fibroadenoma of the breast. May be a variant. Okay, this is how it looks. Okay, phylloid tumor, that's how it looks, right? Then clinical features, they occur premenopausal women. It usually unilateral, grows rapidly to attain a larger size. It is a bossellated. Whenever you see a bossellated swelling in the breast, it is mostly phylloids. So just by seeing it, you can tell the bossellated lesion. And another important thing in phylloids will be, you'll have dilated veins. In your clinical presentation, when you tell no dilated veins seen over the breast, then they'll ask you what is a DD. Okay, dilated veins, yeah, highly vascular tumors can have, because sarcomas also have been reported in breast, but more commonly it occurs in phylloid tumor. Okay, swelling is smooth, non-tender, and it will be fluctuant with necrosis of the skin. And skin over the breast will be stretched, red with dilated veins over it. That's what I meant. Okay, tumor may be warm, not fixed to skin or deeper muscles of the chest wall. Okay, nipple retraction is absent and lymph nodes are not usually involved. But when turned malignant, yeah, there are cases where lymph nodes are involved. But mostly it is the carcinoma of the breast where lymph nodes are palpable. Remember that. Tumor grows rapidly, undergoes necrosis at the various places, causing cystic changes. That's why it will be variable in consistency. And recurrence is common. Okay, that's why most often they adopt even subcutaneous mastectomy or even some simple mastectomy. Okay, the investigations will be ultrasound of the breast, FNAC, core needle biopsy. When you do a core needle biopsy, what will happen? A lot of fluid will come and tumor may disappear, right? But after that, again, under image guidance you do it, you may pick up the lesion, right? Then mammography is mandatory. And X-ray chest and CT, if malignancy, if you suspect malignant phylloids, then you have to do a CT. Okay, treatment, excision or subcutaneous mastectomy, if the whole breast is involved. If malignant, total mastectomy. So no need of axillary dissection because axillary nodes are not involved. Then again, mastalgia, the pain, right, is again a common condition. 45% of the women report breast pain, an entity that is no etiology found out till date. Okay, but mastitis carcinomatosa, you all know, like, presenting with only mastalgia. Then patients who are on HRT, too much of caffeine and tobacco are being said as the factors for mastalgia. There are types of mastalgia, again, mostly for postgraduates. I don't think it's needed for undergrads. So cyclical is 65, non-cyclical type is 30, and chest wall pain maybe 5% of the mastalgias they come with. The pain related to menstrual cycles, usually seen in Andy with fibroadenosis, present in women of menstruating age group. Pain is more during menstruation. It is bilateral, diffuse with heaviness feeling. Treatment, again the same thing. Okay, whatever you give for fibroadenosis is the same treatment. But here you can give GRH and analogs. Okay, then there are non-cyclical types. I think these are all, I'll skip, you don't need it. Another condition, like for serous carcinoma of the breast, they'll ask you what is a DD. Elderly women, okay, a serous carcinoma of the breast. Okay, what is a DD, they'll ask, you have to tell. Traumatic fat necrosis. Okay, it may be due to direct or indirect trauma. Capillary ooze causes triglycerides in the fat to dissociate into fatty acids. It combines with calcium from the blood, resulting in saponification, which causes inflammatory reaction. This is what the pathology that occurs in traumatic fat necrosis of the breast. In later, it presents as non-progressive swelling in the breast. So it's a DD for a serous carcinoma of the breast. So you should know what is traumatic fat necrosis. So painless swelling in the breast, which is smooth, hard, non-tender. It will be adherent to the breast tissue, and it is non-progressive and non-aggressive. So investigation, mammography has to be done because it occurs close to the age of 40, 45. You should not miss out a malignancy. So you have to do a mammography to rule out malignancy. FNAC will show chalky white fluid with fat globules. Okay, differential diagnosis is carcinoma, breast, and the treatment is excision if pain persists. Then galactosile, again, may not be asked for undergraduates. So mastitis, again, subareolar, intramammary and retromammary type. Okay, I'll just go for another important topic which you all should know. Abscess, breast abscess, okay? So lactational breast abscess is common in a lactating breast. It's a very, very painful condition. So breast abscess, if they ask you what are the painful conditions of the breast, this should come as a first. Next, mastitis, then fibrocystic disease. Finally, only you should tell malignancy if it involves the adjacent structures, like muscle, bone, and others, right? Otherwise, painless will be carcinoma breast. Remember that. Okay, commonly seen in lactating women, bacteria enters during breastfeeding through the cracked nipples. Staphylococcus aureus is still the commonest organism. Okay, causes clotting of blood in the blocked ducts and multiply. And initially it begins in one quadrant and then entire breast can be involved. That's why once you diagnose breast, we also tell don't wait for fluctuation to occur. Okay, we never wait for fluctuation to occur in 4 important places. One is palmar space, parotid abscess, breast abscess, and ischiorectal abscess. These are the areas wherein we never wait for fluctuation to occur. By then, the whole tissue will be destroyed. Whole breast tissue may be destroyed. Okay, you never wait. Okay, then precipitating factors are cracked nipple, retracted nipple, improper cleaning, inadequate breastfeeding by the baby or milk expression causing stasis of the milk, then infection from the oral cavity of the baby, and hematoma getting infected. These are the causes of precipitating factors for breast abscess. Then clinical features, as I said, they'll have a throbbing pain in the breast with high-grade fever, right? And diffuse tenderness, all signs of inflammation like warmth, tenderness, induration will be present. And purulent discharge, if it communicates to the lactiferous duct, purulent discharge can occur. Again, discharge per nipple is a short note for you guys. And you all know commonest cause for discharge is type is greenish or serous, which occurs in fibroadenosis and duct ectasia. Next, it can be a purulent discharge if it is a breast abscess or mastitis communicating to the lactiferous ducts. Then it can be blood discharge if it is a papilloma of the breast. Next, malignancy, intraductal malignancy can cause blood discharge. Abnormal milkish discharge can be in galactocele. So these are the types of discharge per nipple, which is again a short notes for you guys. Then entire breast may be involved eventually. Occasionally tender and fluctuant swelling may be felt, but very rarely you feel a fluctuant swelling. Mostly it will be tender and indurated. So antibiotics can be tried, but it will not work. But repeated ultrasound guided aspiration can be done. Of late, image guided aspiration, because most often it will be loculated, and every locule you can go in and do an image guided aspiration, send for culture sensitivity. Most often it will be staphylococcus. That's why it responds to cephalosporins and amoxicillin. Okay, and if you think it's quite big, then you can do a drainage under general anesthesia. Why? Because when you do under anesthesia, you can put in your finger and break open all the locules, and the whole abscess cavity can be emptied. And often it takes a very long time to heal if you do IND. That's why we always prefer aspiration, image-guided aspiration. So what are the indications for drainage? Mastitis not resolving with antibiotics in 48 hours. Persistent fever and progression of mastitis when there is brawny induration, and never wait till fluctuation develops. That's what I told you, right? So whenever the patient comes with pain, fever, and signs of inflammation, immediately you can do ultrasound, find out, and aspirate it off. Or if it is involving the whole breast, under general anesthesia, you drain it off. So antibioma formation can occur, sinus formation, skin can get necrosed if you leave behind, you can get a fistula, okay, you can get recurrent infection, and you won't believe, if patient is immunocompromised, they can go for bacteremia and septicemia, right? So that's why you never wait for a for a breast abscess to become fluctuant. There are non-lactational abscess of the breast, commonly occurs in duct ectasia and periareolar infections. Again, common organism will be bacteroids, enterococci, and anaerobic streptococci. Microbiology students can, whenever you come across, you can write this. And it's commonly recurrent with tender swelling under the areola. Treatment is antibiotic, repeated aspiration. They are not huge abscesses, they're all tiny abscesses. With antibiotic, it may turn into an antibioma. So next is antibioma, right? Later date antibiotics are given. Later antibiotics are given after excision of the antibioma. Because antibioma patient will be thinking as if she's having a lump, she'll be scared, she'll be apprehensive. Then after aspiration it recurs, so they get more worried, the family gets worried, excision can be done. Then comes duct ectasia again, it's not as a short notes for you guys, but it's a dilatation, abnormal dilatation of the lactiferous duct due to muscular relaxation and duct wall with periductal mastitis. It's also called plasma cell mastitis. Okay, commonly many ducts are involved. Okay, this is how the ducts get dilated and clogged. it gets clogged. That's why you get greenish discharge per nipple in ductectasia. Greenish discharge from the nipple, indurated mass under the areola, which is often tender, retraction of nipple, which occurs at a later stage due to fibrosis. Okay, eventually it forms an abscess or a fistula. Okay, often they are bilateral and multifocal, may present as mastalgia. So investigations, discharge, you send it for cytology, they'll be ruling out malignancy. Okay, then mammography, as I said, because it occurs around the age of 40, mammograph becomes mandatory. And FNAC, when you are highly suspicious, and treatment, co-annexation of the affected ducts, followed by antibiotics. So gynecomastia, for the completion's sake, I thought I'll tell you. So it's nothing but hypertrophy of male breast due to increase in ductal and connective tissue, often attaining features like a female breast. So that's called gynecomastia. Okay, and most often it's idiopathic. Just remember a mnemonic called KILLED. Okay, causes of gynecomastia. KILLED, Klinefelter syndrome. That is XXY. I is idiopathic. 1L is liver disease, wherein estrogens are not destroyed, so you get more of estrogen. Okay, then another L is leprosy. Why leprosy? Because in leprosy, there will be testicular atrophy, so male hormone is less. Then E is estrogen excess, then drugs come. And drugs, if you go to nephrology ward, madam just left nephrology ward, most of them will be on spironolactone and they can have gynecomastia. That's all I think. I think my time is up. Anyway, I have covered up most of the important topics that has been asked. Okay, so fibroadenoma you all should know. Fibrocystic disease you should know. Andy, the broader spectrum you should know. Breast abscess you should know. Discharges from nipple you should know. Gynecomastia again is a short notes. I think I have covered up all important clinical and theoretical topics for you. Thank you for the opportunity. Thank you.
Thank you so much, sir, for that very important and much needed session. I hope our undergraduates have made the best out of this session.
We deem it our proud privilege to have been part of an exuberant session elucidated by Dr. Balaji, sir. On behalf of our undergraduates and audience here today, we would like to extend our deepest gratitude to Dr. Balaji, sir, for taking time out of his busy schedule to be here with us today. May I now request our dearest professors from the Department of General Surgery, SMIMS, to join us on stage and felicitate our guest speaker. Let us welcome our professors and give sir a huge round of applause. He has chaired 2 sessions and also has given us a beautiful insight into the benign breast diseases. He deserves a large round of applause, people. Let's give everybody a huge round of applause. Thank you so much, sir. Thank you so much, professors, for joining us on stage.
Our next topic is the one long case everybody has been practicing since day one of surgery posting. I'm pretty sure at least a section of you have presented on this topic in your posting classes. So this session is actually a revision for you of sorts, and hope that you guys pay closest attention. May I now take this opportunity to invite the gorgeous Dr. Shilpa Rao, Professor, Department of General Surgery, SET GS Medical College and KEM Hospital, Mumbai, to the dais, to give us an insight into the topic, approach to breast malignancy. Please help me welcome ma'am with the largest round of applause.
It gives me immense pleasure in introducing Dr. Shilpa ma'am. Dr. Shilpa Rao, Professor, Department of General Surgery, SET GS Medical College and KEM Hospital, Mumbai. Ma'am started the first multidisciplinary breast service in a public hospital in Maharashtra. She is the organizer for the GenSurg National Conference for PGs for the past 16 years. She has many papers and publications to her credit and is also a reviewer to national and international journals. Her field of interest include equal quality of life across all strata of the society and application of positive nutrition in all patients to improve outcomes.
I think that's good enough. You guys enjoying yourselves? You have to say yes, right? Okay, but I think the trustees and Dr. Alex and all the faculty here, I've seen them work, the number of phone calls they've made me, and the superlative hospitality. So I think you should give it up for those guys. I was watching your play. I didn't understand a word. Dr. Srinivasan gave me the gist of the story. But I think what it did do was get you out of your postprandial slumber, right? So this is a topic I am very passionate about. It's a topic I think all of us need to be passionate about. How do I change? Okay. I am sorry my voice is like this. I just finished with a 4-hour talk yesterday and the voice is pretty much gone. So whether you are a first-year MBBS student or you've done your MCH in urology or what have you, the number and incidence of breast cancer is increasing so rapidly, not only in the world, but also worryingly in India. And a lot of friends, people will come and ask you about the management. So you cannot say, I don't know. You, at every level of medicine, you have to be able to understand the basic principles of management of CA breast. So of course, like Dr. Balaji said before me, all lumps are not cancer. In fact, only 10% of the lumps that you will get when you examine a breast would be malignant. The rest would be 90% of it would be benign. And that's why we've started the services, because benign is more difficult to treat. There are no protocols in place for benign. CA breast is pretty much protocolized. So we are getting there slowly, surely and slowly we will get there. But you need to understand that only 10% of all the lumps you will see will, turn out to be cancer. I don't know if the anatomy has been taken, but so this will be available on Google Mata. In fact, pretty much of the data is available on Google Mata. I'll tell you what is not available. Calculated decision making is not available. Now you guys will tell me, but there is AI and there's Bing and there is what have you. But surgery still cannot be replaced. So we are safe for our generation. I don't know about yours. But calculated decision making is something you guys should learn and be proud of doing. Better than any programmed copy that there exists in this world. So this you can go look up. What I want you to just see is on the left-hand side, how it progresses, how your Robbins defines malignancy. It's such a elegant description of cancer. When the cells go beyond of their normal confines and their normal control, that's when they can turn malignant. So it's a lovely, lovely definition. And that's the progression where it can enter blood vessels or it can enter into lymph nodes, and that's how it spreads into the rest of the body. Now, you might call this slide flip, but honestly, out of 100 patients who come to me with CA breast, about 10 of them tell me, my husband found the lump. What is even more worrisome is 20 to 30% tell me, we went for a massage and the masseuse found the lump. So I think as women and as men who have, females in all, like women all over in their family, I think the awareness for breast understanding should start when a lady gets into her pubertal stage, and then understand the changes that happen. And we need to address this. It's like an epidemic that's happening now. So we really need women to understand the state of their breast as much as they pay attention to the rest of their body and to their families. So this is typically how patients present to us. Very sadly, unlike the West, we don't get T1 tumors at all. In fact, when I get a T1 tumor, my residents are dancing because they get to operate. But most of them are like this, okay? So in an MBBS exam, we are not looking at what diagnosis you make and what management protocols you will get. We are looking at, can you reach a diagnosis? Can you find out what are the relevant questions that you need to ask to come to a diagnosis? So it is important to elicit history to find out what possibly could have gone wrong after the patient's presenting complaint. Most times the patient comes to you with a lump in the breast. So the history has to be to understand, because breast is not a local disease, it's a systemic disease. So you need to understand the cause. You need to, now, like I said, all lumps are not cancer. So which are the lumps which are likely to be malignant? And for that we have the standardized triple assessment, which is asked of you in your, Dr. Alex, this is I don't know where he's gone, but this is a very unfair talk to give before the presentation. Who's presenting? So you have all your answers here. So you look like, you seem to be a favorite of his, because after this, take a 10-minute break and add everything that you've not, right? So you need to have triple assessment. Everybody should know what triple assessment is. The idea is to establish a working diagnosis. On history, you're going to establish a working diagnosis. And then we go on to stage the disease, the complications. In breast, genetic studies plays a very, very important part. I'm going to tell you a bit about what a multidisciplinary approach means, and then we'll talk a little bit about the management protocols. So TBA means you basically do a clinical breast exam, which includes history taking. Then we go to radiology and pathology. So it's like a triangular series. Unless one of them, all three of them are into the right points, a diagnosis cannot be made. So what is the story you're going to ask? The first thing you need to write is what the patient came to you with. And again, in your case, please don't call them women, female, okay? Call her either a patient or call her a lady, because that's not how you would like your near ones to be addressed, like that female, that woman. So get into that idea. If you're going abroad, you can be failed on this point, okay? So you need to know what she's come with. If there are any complications, then any personal habits that she has which can increase the risk, any comorbidities, family risks, again an important aspect of CA breast, and whether she's taken any previous treatment, any previous surgery kind of ups your risk for breast cancer, specifically in certain kind of diagnosis. So that is also important. So what are the red flags? Age. Indian women 10 years younger than their Western counterparts. So Western counterparts, the average age is 54. Indian women, it is 44. Very unfortunate, and because they're younger, they go more into triple negative, more aggressive diseases. We'll talk a little bit about risky lumps a bit, thoda. And reproductive history, again important, family history. You're listening, no girl? Yes? And metastatic history. So these are the things that will maybe raise your antlers towards making a diagnosis. An axillary lump, pretty much kind of, most other places will have, like cervical you can have infections, inguinal you can have infections, but axillary, most times if it's palpable, it's some kind of malignancy. Painless progressive breast lump, and then the rest of it. So again, history would be about the lump, and like you have a history of a swelling, all the 7 S's and the 3 P's, you will tell all of that for the lump. You look for scars, you will look for any involvement of solid organs, as in terms of whether the patient has had a recent history of jaundice, abdominal swellings, any bone tenderness, fractures, any kinds of central nervous system issues like convulsions, epilepsy, focal issues. And comorbidities are important because a lot of medication cannot be given if they have any cardiac issues or CT disorders. So a comprehensive history is essential. I don't know why this is doing this funny thing. Addiction. So alcohol and smoking. I know it's a fad today. When I go into colleges, I see most of the youngsters and more women than men smoking today. Smoking ups your risk. Alcohol ups your risk. A single glass a week ups your risk. A single cigarette a day ups your risk. Okay? And binging, obesity ups your risk. So this is getting to be a really global phenomena. All 3 of these together, I think, just messing up with the system. Again, The reproductive window, all of you all will know, it's all written in the books. The estrogen windows, early menarche, late menopause, pregnancy. Again, pregnancy is supposedly protective, but that doesn't mean that you can keep producing forever and hope it will protect, okay? So it's up to 3 pregnancies is protective. After that, the protection goes, right? So you need to remember that. Abortions, yes, because you have a unchallenged estrogen response, which is bad. So multiple abortions can cause that. Infertility treatments, which are again increasing these days, can increase the breast cancer. HRT, again, thankfully not common in India, but abroad in the US, everybody started HRT, and they kind of noticed a 20% increase in the incidence of breast cancer. So all these things are important. You can have a short note, you can have obviously a full question, a case. You can also have a short note on inherited breast cancer, but I'm not going to talk about this. This is theoretical, so go read this up. We've discussed this. So coming to the clinical breast exam. Consent, okay? If you are a male student, please never go to a female patient, no matter for what examination, unless you have a female attendant and you verbal consent. You will get into a lot of trouble. Communication is vital. You have to tell the patient what you're doing. And counseling, obviously, after and before. Like I saw the script, I mean, everything went well. If you're added a little bit of counseling at the end of it or pre-surgical, it's important now. You need to add that, right? So these are the positions in which we examine the breasts. The hands up position is basically to see the inframammary fold, and it gives me a lot of information about the nipples and the contour of the breast and other things when we are considering plastic surgery for the breast. And then you have the other positions. What you look for is obviously whether both breasts are the same. Sometimes one is, you know, it's normally larger than the other, like your right foot is larger than your left. So whether it's significantly different, whether there is symmetry, the nipple positions, any other changes that you can see in the area. It is important that you play by the rules, especially for the MBBS students. Don't skip, don't do shortcuts. Ask the patient to raise both their hands, and you have to be at the level of the nipple. Now, if that's not possible, you don't have to bend down to funny positions. You can sit and the patient can sit and you can look. Okay, so, but ensure that your eye level is at the nipples. And you can pretty much make out whether, again, in a benign, it just pushes the breast outwards, away from it. In a malignant, it pulls it towards. So these are things which, just by looking on a clinical exam, you can kind of figure out what's going on inside there, right? The upper outer quadrant is the commonest. Now why? Because that's the area which has got the maximum breast tissue. No other reason really, okay? And this different quadrants are important to me because it will help me decide whether I can offer conservation to the patient. So, yeah, this is. How many of y'all guys have entered the kitchen? Nobody? I'm not asking to cook. So I entered the kitchen until I finished my, the exams and I got married. Have you seen people doing the bhakri? You know what a bhakri is, right? I don't know what the local term for bhakri is. You know the thing you do like aisa on the, you know or not? No. Not chapati. Chapati is done with the belan. Bhakri is with your fingers. Yeah, you've seen? Otherwise, please go home and ask your parent, your mom or. So it's a flat surface, the platform, and there is a ball, and then you do it with your hands. So that's the kind of palpation you have to do for the breast. The flat surface is the bone, the chest wall, and you can't palpate like this or like this and like this. You have to do that motion. Understand? So all of you will go home and try and do bhakris. You will surprise your parents no end, and you will learn something as well. So you have to do it in 3 dimensions. First is the skin and subcute, then the breast itself, and then below that in the muscle. Again, we've talked about this. So one of my residents clicked this photograph of me yesterday. So that's the position in which you examine the axilla. Please note, and this is important, okay? It's the same side. So my left hand is depressing the shoulder. My right hand is supporting her arm. Again, this is still not very good. The elbow has to be a little higher than the wrist. And that's how you relax the fascia, and you will be able to actually examine. And the thumb is on the pec major muscle. So you push it down, and you can actually examine the entire axilla like this. I'm not going to talk on this, again, theoretical. So you have to remember that the lump can also, the malignancy can also spread to the opposite axilla. So you should never examine only that breast and axilla. You must also examine the opposite axilla always. A diagnosis is not complete without radiology and pathology. So that's mammography. Basically, this is a mediolateral view. And how I teach my bachas is, you start with A, B, C, D, E. So A is the architecture. So as you can see here, it's not a regular lump. It's got an irregular architecture. B is breast lump. C is calcifications, microcalcifications. D is density of breasts. A lot of Indian women have dense breasts. So a mammography might miss. So a lot of times you have to do a sonography along with a mammography. And the standard age for doing a mammography in India is 40. In the US and UK it's 50. But you can miss small lumps on a mammography. Therefore you need to do a sonomammography. E is extra fat. So you look at the axilla and you look at the fat planes beyond. And F is, I forgot what. So anyway, so that's how you examine a mammo, and that's how you'll not ever kind of lose out on anything. Here you can see at 12 o'clock, those are the popcorn calcifications. So this is a benign disease. Nice rounded bodies. The rest of the breast architecture is normal. So these are small fibroadenomas. Again, pathology, you will never, ever, ever, ever say an FNA for breast lesions unless it's a fibroadenoma which you're conserving. Okay, other than that, the standard, the gold standard for diagnosing breast lesions is a biopsy. Whether it's benign or malignant, you do a 5-core biopsy. It gives you a lot of information, and we need the immunohistochemistry status because the whole treatment of breast cancer is now changed. It involves a lot of various modalities. So in very short, if I have an early breast cancer, I can get away with doing a complete blood count, a liver function, and ALK phos, but I will still need the ER/PR status. If it's a locally advanced breast cancer, the NCCN guidelines today says you can go ahead and do a PET scan instead of doing multiple scans, and then you can go ahead further. So we do PET as a standard modality of management for all our patients with locally, and most of them are locally advanced cancer. A mammography should always be done before the biopsy. Okay? This is the staging, again, standardized staging given in all your textbooks. This much you should know about management of early breast cancer and locally advanced breast cancer. Early breast cancer, you could do upfront surgery, but women today want to preserve the contour of the breast. So if the lump is large in relation to the breast, we can give neoadjuvant chemotherapy, reduce the size of the lump. It also tells us the response of the lump to chemo, because if the response is not good, the lump is really not going to do well. So we also give an ACT to understand whether the lump is responsive to chemotherapy. So we could do an ACT and then do surgery, or we could do upfront surgery. We have to handle the axilla. We could do sentinel nodes if it's negative axilla, but for you all guys, it has to be a complete axillary dissection. So BCS or MRM with complete axillary dissection. You can continue with adjuvant chemotherapy. Today immunotherapies come, so 1/3 of our patients are HER2 positive, so we need to give trastuzumab to those patients for a year. Hormonal therapy is the mainstay, so all ER/PR positive patients, pre-menopausal will be given tamoxifen, post-menopausal will be given letrozole. Tamoxifen for up to 10 years, letrozole for 5 years. So that's what a simple mastectomy is. Nobody really does it anymore, except if it's for a phylloids, which is really large. This is your modified radical mastectomy, wherein you take out the entire breast along with the tail. A lot of people forget to take the tail down, and then you have recurrences, and you take down all the levels of the lymph nodes. Ideally, the pathologist should have at least 10 lymph nodes to call it a satisfactory yield. Okay? There are certain contraindications. There was a paper from Tata. We are writing a paper on the ability to do breast conservation in locally advanced disease. There are certain criteria that need to be met. We can't do it for triple negative. Very stringent criteria. But if the patient has connective tissue disorders, the patient is pregnant and there's widespread, I mean, you can't, if there's DCIS, you can't really do a BCS. So there are a lot of, again, adverse reactions that happen because of chemo. Patients will get osteoporosis if they are on letrozole. They will get endometrial bleeding if they are on tamoxifen. So you need to have an annual checkup. You need to give them bisphosphonates. So it's not a single-time disease. The patient follows with you for life. So you have to figure out what keeps happening. So we started this, it was one of the first we started in Maharashtra, pretty much in all of India. 2010, we now have a fellowship from MUHS for this. Seen about 10,000 plus patients. So it consists of a multidisciplinary. We cannot do without this. So we have plastic surgeons, we have a med-onc, obviously, rad-onc, a radiologist, radio-oncologist, a radiologist, pathologist, and very important people, a medical social worker because our patients need funds, a psychiatrist because obviously issues, and an admin to kind of oversee the whole thing. So tumor boards have been proved to be successful all over the world. They increase or they reduce the mortality by almost 30 to 40%, a good tumor board versus a no tumor board. So today we cannot say we can't have a tumor board. Also understand that when somebody has cancer, especially the lady of the house, the whole house gets affected. So you have to be very empathetic. You have to be fully involved. You cannot be treating it like just an appendicitis or a cholecystectomy. She becomes a part of you for her life and a large part of yours. I don't know if you've heard this song by Dido. Yes? Anybody? Anybody? Yes? No? Put up your hand. Okay, go look up Dido, the white flag. Okay, so basically what she says is, if the ship is sinking, I will not go down with it. I will not put up a white flag and surrender. And she says, because it's love, I call it passion. I don't think we're going to put up white flags. We're going to keep fighting for our patients. And so does that make me a problem solver? How many of you agree you all are problem solvers? Nobody agrees? Are yaar, come on, man. So we are essentially problem solvers as of today. But, sorry? But I want your batch, the juniors, the fresh faces to go a little beyond this. You have to be a solution provider. You have to understand why it is happening. You have to understand how to stop it. Like there's a place called Barshi in Maharashtra which has a very low prevalence. Nobody knows why, but there is no breast cancer seen in that place. Multiple studies are going on. So it's your generation which can take up the field of preventive medicine, the field of preventive oncology, and you can make a difference by making sure that it's stopped at its origin, not when it's too late. We are now doing a study on AI thermography with mammography. We're screening 6,000 patients. Most of my juniors are involved, and we are including a few of the UGs as well. So the next step towards the management of any malignancy is its prevention. And I hope if I leave you with that one thought, I would have done my job. Thank you.
Thank you so much, ma'am, for conducting that much needed session with care and precision. I think now we can actually put our UGs to the task to do justice. So let us move on to a case presentation on the topic of carcinoma breast, and to present the same, may I now invite on the stage Mohan Shivani, Mudukirtana and Madhura from final year MBBS SMIMS. To fine-tune our students and give them the viva feels, may I request Shilpa ma'am, Dr. Srinivasan sir and Dr. Gayatri ma'am back to the dais. Please, professors.
or a 63-year-old female will be. You put the name, you put the town, you put the religion. Please, if anybody, any case, don't put. I think Madam will agree with me.
So religion, when it is essential, because certain religious identities are identified with certain diseases, but definitely not the name and details. I'm happy you called her a lady. I have a little issue with you calling the patient apparently normal. Patient, no, go next. Patient is never apparently normal. Patient is asymptomatic when she comes to you. The malignancy has been or disease has been happening for a long time. So you never say apparently normal. You say patient was asymptomatic 6 months, before 6 months, right? Go on.
After which she developed a lump in her right breast, which was insidious in onset, initially small in size and gradually increased in size and attained the present size. The swelling is not associated with pain, fever and trauma. No history of nipple discharge, itching, ulceration. No history of cough, hemoptysis, breathlessness, bone pain, nausea, vomiting, abdominal distension, jaundice, backache, seizures. No history.
Wait. Where are you running so much? I mean, you should allow us time to ask you questions also, no? So after nipple discharge and this thing, don't you want to talk about the axilla? Don't you want to talk about the neck fullness before you run away to the rest of it? And you can sum it up that there is no evidence of respiratory, abdominal or CNS symptoms. If the examiner feels like asking you, they will ask you. But don't run away like that. The most important thing is an axillary lump, right? And is there usually a history of weight loss in breast cancer?
No, ma'am.
So what should you be asking?
TB is obesity.
Suspect that lump is a tuberculous lump. So yes, ask. No, why you?
Did you ask for? Did you ask only for weight loss? Because what did I mention was a risk factor for breast cancer?
Obesity.
Especially postmenopausal, now even premenopausal. So you have to ask for both, especially in breast cancer, right? Go on.
Past history, no history of similar complaints in the past. Medical history, history of diabetes mellitus for past 3 years and are on regular medication. No history of hypertension, tuberculosis, COPD, asthma and epilepsy. No history of previous irradiation. Drug history, patient is on oral hypoglycemic drugs. No use of OCP, HRT. Patient is not allergic to any known drugs. Surgical history, no history of any previous breast surgeries. Menstrual and marital history, the patient attained menarche at 13 years of age, married at 25 years of age.
Just because I pick up the mic, you don't have to shut up.
No.
First childbirth at 27 years of age, second childbirth at 39 years of age, attained menopause at 50 years of age.
Between that first childbirth, second childbirth and menopause, would she have done something else also?
Yeah.
Which is protective? Contraceptives are protective, Rani.
Breastfeeding.
So you have to say that. Breastfeeding of at least a year. Right? That is a protective risk factor. So that also has to be mentioned.
So this has to be there itself. Do you understand? When you talk about delivery, then you should say that she breastfed for so long, 6 months or 2 years or whatever it is. Now see, because you brought it to the next slide, or if you have taken it to the next page or next sentence, this is what will happen. The examiner will stop you and ask you. So we said 25 years back she delivered her first child. She breastfed the child for 6 months or 2 years, whatever it is. Okay, so it has to be continuous. You do it there itself.
Obstetric
Did you mention about the nipple retraction? Nipple retraction?
History of recent history of
nipple retraction.
Did you ask for the history?
Yes, sir.
What history will you ask?
Nipple discharge, nipple retraction, recent.
Reason. Why you ask that reason?
Because some for people congenital will be present, sir.
So if the patient doesn't know, by examination can you make it out whether it is?
Yes,
congenital or due to infiltration?
We have to examine the normal breast. Or we can...
Before I forget, that's why I'm asking. So in palpation, if there's nipple retraction, if you try to catch hold of the areola and squeeze it, if the nipple comes out, it is congenital retraction. If it is due to infiltration of the ducts, it will not come out.
So there's a sign for that. Do you know what the sign is?
Slit-like.
Huh? Bacha, you know, you just be a little louder, na?
Slit-like and circumferential.
No, there is a sign for it.
Sign, name of a sign. Okay, where you press the areola at the bottom and with one finger here and then two fingers from the sides and you kind of try and, okay, it's called the Allen sign. Also, if it's congenital, it will be a circumferential retraction, right? Whereas in a malignancy, it will be like one-sided.
And it can be bilateral in congenital. Yes?
Yes, personal history, mixed diet, adequate sleep, normal appetite, bowel and bladder habits are normal, no history of smoking or alcohol intake. Family history, no similar complaints in the family, no history of colorectal, ovarian, prostate, malignancy among family members.
Enough.
And if you write it, then thyroid is not mentioned.
To write it, they ask questions.
So you don't write.
Who are the family members now?
First degree relatives, mother, sister, daughter.
The first degree relatives?
Mother, sister, daughter.
That's all.
Grandmother.
No cousins.
No, it has more chance of, it is a relative risk of.
Most of the breast cancer is because of genetic, is it? Even then you are going to ask about the relative. Yes, family history. Then how can you say it is only the mother, sister, daughter? Yes?
And prostate is mother, sister, daughter mein hoega.
Okay. So
high risk.
It's a difference, man. Hereditary breast cancer is different, familial breast cancer is different. That's not a bit higher stage. So what is the gene responsible for the family?
BRCA1.
I do not know what is BRCA. Kindly expand BRCA. What is BRCA?
Breast cancer genes.
Breast
cancer gene.
Breast cancer gene. Okay, 1 or 2?
Both. Sir.
Which is in which chromosome?
17q and 17q. BRCA1, BRCA2, 13q.
Male carcinoma, which carcinoma?
BRCA2.
Right, okay.
Since you're doing so well, there's also a BRCA3 now. Go read it up. You're able to hear me, right? There's also a BRCA3. Go read
Since
it
you are
up.
doing well, madam is asking the next question. BRCA3.
I'm asking, I'm
This
just
is
telling you to go and read.
3. This is the reason one. I think the PGs will go.
She's doing very well. Go on.
Summary. A 63-year lady who is a known diabetic came to the OPD with complaints of painless lump in her right breast for the past 6 months.
General examination. After getting the consent from the patient was examined in a well-lit room. The patient was conscious, oriented.
In the presence of a female attendant. That's better. Female chaperone, female attendant. Even if you are a female, I think better to have it under a relative. In this era of litigation.
I think now we still allow ourselves to. It's not yet legalized that you need, when a female doctor is this thing, it's still not legalized, but it's safer not to have somebody. Not a male this thing, but some relative of the patient, better to have, right?
The patient was conscious, oriented, moderately built and nourished. No pallor, ictus, cyanosis, clubbing, generalized lymphadenopathy. ECOG score is 0 and Karnofsky score is 80. Vitals, pulse rate is...
So again here, bacha, you will write the BMI and the waist-hip ratio. In breast cancer, likha hai kya? Okay, please, that's not vitals, no? That should come in your general exam. So BMI and waist-hip ratio, waist-hip ratio is more important. So usko uppar dalo fir vitals. And you don't really need to say all this on vitals. If you're saying the vitals are normal, again let the examiner ask you. right?
Examination of breast. After getting consent from the patient was exposed till her waist and examined in a well-lit room. Left breast and axilla is normal. Examination of right breast. Inspection. The patient was inspected in a sitting position with arms by the side of the body, arms raised above the head, hands on the hip, leaning forward position and semi-recumbent position. Both breasts are symmetrical. Nipples are at the same level. No dimpling, tethering or puckering. No discharge from the nipple. No engorged veins. Nipple areolar complex is normal.
Now she knows when I'm going to ask a question. Okay. No discharge from nipple. What kind of discharge?
See, bloody discharge.
Huh?
Bloody discharge.
It's called spontaneous. There's no spontaneous discharge. Very important. I mean, you may express it, but spontaneous discharge, pseudosang discharge, is either a papilloma or a CA breast, right?
Single.
Is pathological. Multiple duct discharge is physiological. Okay.
Nipple area complex is normal. Axilla and supraclavicular fossa is free. Arm and thorax is normal. Palpation.
What have you looked?
Wait. Nothing about what you were looking at. What do you want to know? You just saw the breast and left it. You are supposed to mention whether you are seeing any lump or ulcer or nothing is there. Nothing.
No mass was
No
vis-
lump,
no lump
no
was
fullness.
No lump was visible.
You just saw the breast and went away. You didn't know what to look for. What were you looking for in the breast?
Lump not visible.
Okay.
Actually, have you put the picture? No, you should put the.
So you were trying to look for a lump, right? She has come with a lump in the breast. So won't you look whether there is a lump or not?
Lump or fullness is seen.
No visible lump seen or no fullness. Okay? So that word, that important thing is not there at all. Do you understand? So you were concentrating on everything else and you left about the lump. You should say, even though the patient complained of lump breast, I could not see any obvious lump or obvious fullness. Okay, that is important. Okay, that is the most important thing here. Okay.
What did you look for in the arm?
Cancer and curious.
No technical terms. You could have said any fullness or any edema of the arms. You can say.
Ideally, what you should do is you should take the circumference of the mid-arm on both sides. But if you're saying axilla is normal, unlikely that the arm circumference will be different, right? But you should know what you're looking at. Arm, I say normal, axilla free, nipple. You have to be able to justify yourself, right?
Palpation. All inspectory findings are confirmed. No local rise of temperature, which is non-tender.
Wait. You said no lump or no fullness seen on sitting position. So suppose the next, if you want to see whether the lump is visible or not, what is the next method of inspection?
We have to ask the
No, arms raised above.
Arm raised
What is the importance of raising the arms above? So a seen lump will become more prominent, number one, or a not seen lump will become visible. Above. Raising. The dimpling, puckering or tethering, all three are almost the same terms only. Why do you get these three things?
Infiltration of Cooper's ligament.
Infiltration of ligament. This will become. Number three, the most important is look for there is no lump visible. You have to look for the inframammary fold. So inspection by sitting, you said. By arms raised above, did you say? You went for palpation. Now arm bent
In
by
all positions, you are supposed to examine, inspection,
by,
and then you are supposed to go for palpation. Right, sir? That is what you are trying to say.
Then by inspection, by leaning for, bending forward. Did you see that one?
Yes, sir.
You didn't mention, ma. So,
Mentioned in the first slide itself, all the examination.
All
on inspection, right? All these things, no lump is visible, no.
Oh, you have done all the inspection and then finally you are telling us a gist of it. No.
Sitting,
position
you
you are supposed to.
you got certain things. This position of the breast, the symmetry, the number of breasts is important. Because one breast would have been removed or something. The number of breast, the symmetry of the breast, the contour of the breast, nipple size, the areola, then the skin changes on sitting position. Then arms raised above, you can make a lump visible, number one. Number two, the tethering. Number three, the inframammary fold. Bending forward, You can look for what?
Chest wall exaggeration.
Huh?
Chest wall.
Chest wall, so falling forward. So these three things you should do separately. Then only come for the palpation. Okay. The semi-recumbent position, the position of arms on the hip. Arms on the hip, what are you looking for?
We are looking for pectorals
Fixation. That is done only by palpation. So the palpation, when you come, you do these two things. Inspection, you have to mention separately.
I think the most important point that she made was you mentioned no lump ka status. And you just went running like one marathon runner. So give us, you have to address the presentation complaint first. Say that you can't see it, fair enough. In all the positions, like, yeah?
Morning in the lecture, I told them, anything you try to speak fast. So because half the time the examiners will be sleeping. That she has taken it.
We didn't have the lunch, okay? So we are wide awake.
Okay, go to inspection. So, inspection, da. So, first is, the patient was inspected in a sitting position, arms by the side. Okay, that's all. And then you are supposed to talk about all this. Then next one is, next slide will be arms raised above the head. So no lump found in the inframammary space or something. Or if the lump is already seen when the arms are by the side, then you say the lump becomes more prominent. Or only when a fullness was seen already, a lump is seen now. Do you understand? So that is why arms are raised above. So that will give you more information than arms by the side. So when the arms are raised above, you also take a look at the axilla. Do you get it? So each and every step has got its own significance. You cannot put everything together and say, yes, over, go. Okay? Okay. So each and every position has to be mentioned separately so that the significance of each and every position is known. Okay, palpation now.
No. And if you have no positive inspectory findings, what findings are you confirming? ऐसा randomly नहीं लिखने का. Inspection is inspection, palpation is palpation. Don't use that sentence, right? कुछ है नहीं, तो just randomly मत, so leave that line. Start with no local rise.
Your findings are confirmed, so there is no lump. You finish the case.
Yes, because you said no lump on inspection. Confirm means there is no lump on palpation also.
Palpation, no local rise of temperature, it is non-tender. Single lump of size 6 cross 4
What
centimeter.
is non-tender?
The skin of the breast is non-tender, ma'am.
Skin of the breast.
Lump is non-tender.
Lump is not tender. Then why do you want to say it there? Do you understand? Yes. Carry on.
The single lump of size 6 cross 4 centimeters, spherical in shape in the upper
Again, hold. So in a breast lump, the 6 cross 4, 10 cross 5, it's the largest diameter. So it's a single lump with the largest diameter of 6 centimeters. That's going to do your TNM classification. So it doesn't matter what the other end is. The longest diameter is what we talk, right?
Spherical, I don't agree with you. Could be hemispherical. Spherical means only when you see the full circumference, you call it as spherical. Here you can call it as hemispherical or irregular, whatever shape you know. Oval. Yeah. Upper outer quadrant. Yes.
hard in consistency, well-defined margins and fixed to the breast tissue. No fixity to the skin, underlying muscles and chest wall.
You also, Hari Baba, wait na. Where are you in a hurry?
You're not waiting for a reaction at all.
He is hoping that we'll bypass. I forgot what question I was going to ask also. You have to also mention the distance from the NAC. Okay, nipple areola complex.
Nipple areola complex.
So you have to say whether it's 3 centimeters, 4 centimeters at periareola. So that is important because of the management that will happen later. So get into the habit of saying it's 4 centimeters from the nipple areola complex from 3 o'clock to 6 o'clock. So that gives you a very definite idea, right?
Also, don't say hard. It's not a stony one, no? It's not a bone also. So you'll have to say again firm only. Okay? And well-defined margin. What is well-defined? What lump or swelling is well-defined?
conditions.
Yes, benign or malignant one?
Benign conditions.
Benign. Then why do you use it for this?
Since
Yes? You have a doubt, is it? Whether it's benign or malignant?
not really.
Yes? So it cannot be a well-defined one. Usually, 99% it is going to be an ill-defined one. Okay? What are the underlying muscles you're talking about?
Serratus anterior pectoralis muscle.
So when the lump is in the upper outer quadrant, you're going to talk about serratus anterior. Is that so?
No, pectoralis major.
Pectoralis? Major.
Does pectoralis major count at all?
No, ma'am. Minor.
Then why are you trying to tell me about the attachment to it? And you know, if it's a lump which is 1 centimeter, 2 centimeters, early breast cancer, I'll still take this well-defined margin and mobility. 6 centimeter lump cannot be well-defined, cannot be mobile. It has restricted mobility. It may not be fixed to skin or chest wall, but it is restricted mobility. So those words have to be, the adjectives have to be used very well. To be very clear in what you're saying, right?
On examination of right
Oh,
axis.
you're saying, no, it's not that fixed to the chest wall. The word must be moves along with the breast tissue. I think because of that she has used this word.
Yeah, so fixed to the breast tissue, it is restricted mobility because it is spread into the breast tissue. It's not involved the skin, which locally doesn't count for any staging. But you can just say that it's unlike a benign lump, it is not it's not freely mobile like a mouse. It has got restricted mobility. So don't say fixed, it's got restricted mobility. Okay, and margins are not, they're not, so you can say defined margins, but well-defined you cannot use, right?
Madam said, how do you palpate a breast? If it's a benign one, when you try to move it, when you try to move the lump alone, the skin will be normal. When it is fixed to the breast tissue, when you try to move the lump, you can see the dimpling or some, in the changes, you can see the fixity to the skin there. When you try to move the lump away from the quadrant from which it is existing, if it is malignant.
Examination of right axilla. A single node of size 2 cross 1 centimeter. Central group, hard in consistency, mobile, no warmth and non-tender. No palpable supraclavicular lymph node.
What are the various methods you palpate that breast lump? Do you know?
Dial clock method.
Dial clock, yes, one.
Horizontal.
Stripes, cross stripes, one. Then vertical. Okay.
They were listening to my talk.
That's why I asked.
What happened to the opposite axilla? Wo bhi boli na main. You said
mentioned in the front.
You started with the normal breast and then you went to the pathological one.
So systemic examination is normal.
Yes.
Huh?
Yes.
Which system you examine first? You suspect some metastasis from the breast malignancy, isn't it?
Spine.
Which system you think is more affected? Is it the abdomen?
Spine.
Is it spine or respiratory system?
Respiratory system.
So what do you think get in respiratory system?
Malignant pleural effusion.
Pleural effusion, yes. So what will be the features? Difficulty in breathing rather than hemoptysis. Hemoptysis occurs only when there is central, peripheral spread, you get pleural effusion. When it goes to the blood, you will get it gets deposited in the lung, hemoptysis. So pleural effusion. Number 2 is your bone metastasis. Which bone do you look for usually?
Lumbar vertebra.
Why?
Because of metastasis, bats and plexus.
Oh, bats and plexus of vein. Right. Then
Plexus of nerve.
veins. Yes. No focal neurological deficit. Why?
No brain mets.
Brain mets. We come across, madam, so many cases.
So just because you all are doing so well, okay, which if you have done a IHC on a 63-year-old lady, what is most likely? Positive, negative?
HER2 positive is likely for bone brain mets.
No. I am asking what is the capital of India? You are telling me where you are staying. What did I ask you? 63-year-old lady में ER/PR status क्या होगा? What will happen? Is it likely to be positive or negative? Older women? Older the woman, more positive the status. HER2, again, younger patient, middle age, whatever. HER2 actually doesn't listen to anybody, but we are seeing a high incidence, like almost 1/3 of our patients are coming HER2. And triple negative is the worst of the lot. The younger the patient, the more likely to have triple negative disease. So here, that's why you can justify, we check bones first, because this is a 63-year-old lady. So if you know the information, you can apply it. Okay. Summarize.
Summary: a 63-year-old lady, postmenopausal woman, with a lump in her right breast for the past 6 months, no significant family history. On examination, a 6 centimeter lump is present on the upper outer quadrant of the right breast, which is
What's your diagnosis?
So,
The bell has been rung. What's your diagnosis?
I so love this. Seriously, you're a pathologist?
Talk to the mic.
Are you a
Probably.
pathologist? Carcinoma is a pathological diagnosis. You have to say or whatever, breast, it's cancer of the breast. Neoplasm of the breast, probably malignant. You cannot use the word carcinoma. Huh? And you have to complete the whole thing in a 63-year-old postmenopausal lady with no positive risk factors. And then the stage. So what is this stage called? This is a very unique stage. What is it called?
Locally advanced.
No. Huh? You're going to give me MCQs and I have to tick mark. Locally advanced, okay. One word for this. 3A. It's called LOBC.
LOBC, you know, it is EBC, LABC, LOBC.
Locally operable.
Local law.
Only this stage, right? Okay. Tell us what you'll do.
Into two, operable and inoperable. When it is operable, then you can go straight away to surgery. Okay. Inoperable, then you go for
palliative mastectomy. Palliative care would be good.
What will you do? Palliative
What will you do for this one?
How will you manage this lady with the 3A?
Triple assessment. First clinical examination already. Then we have to do radiological investigation. Sonomammogram. We have to.
Sonomammo?
We got to breast and axilla.
So you have to do both. You have to do a mammography plus a sonography. Yes. I don't know. Is it called, if you're doing it together, it's called sonomammo here? Okay. 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 You do that then.
What mammogram you do? Mediolateral and craniocaudal.
Conventional or digital?
Digital.
So all our studies, whatever we read in the books, yes, it's all about digital mammogram. Okay, so but because we see the conventional, we always think it to be a conventional one. No, they're all talking about digital mammogram. So we are talking about digital mammogram now.
Okay. So radiology then?
Then we have to confirm the diagnosis by coronal biopsy.
How many cores do you take?
5 to 6 pulses.
5 to 6 cores, right? And you have to make sure they don't float in the water or whatever formalin. Okay.
What's the size of the needle? 16. Yeah, good. 16. Okay.
Very nice. Okay.
Right, you are taking a biopsy. You are coming to mammogram. It comes as a carcinoma, infiltrating ductal carcinoma.
What else?
What else will you do?
Such a big axillary node is there, no? You want to confirm whether it's...
No, when there is a node positive, palpable, why do you want to go for a sentinel node? By?
What is the diagnosis for the axilla? Will you do a core?
No.
Will you do a core needle biopsy for the axillary lymph node?
If somebody is asking you a question like that, the answer is usually a no.
Have you seen the size of the core needle?
She said 16. How big it is? Length.
16 is a thickness. Yes, so long. Yes, can you put it into the lymph node in the axilla?
No, ma'am.
That will enter the chest only. Okay, so you cannot do a core needle biopsy for the
Axilla.
So what do you do?
FNAC.
So it comes as
Deposit, secondaries.
IDC with axillary meds. Again, what else? Finish because they've been ringing the bell there.
See, mornings we were told, no, yes, investigation for diagnosis and confirmation, investigation for to rule out the extent of the disease, that is metastatic. Investigation for anesthetic purpose. So you're finished with your diagnosis and now you have to look for the metastatic workout. What are the things you look for?
Ultrasound abdomen.
Ultrasound abdomen gives normal, yes. Next.
Chest X-ray.
Yeah, ordinary chest X-ray. Again, I say there's absolutely normal. I give you the report.
Bone scan.
You want to go for a bone scan. There's no bone pain. She's 63-year-old. Bone scan, or you want to do any other thing. You can take a X-ray plane. If there is anything, you can go in for a CT. You know the cost between a bone scan and a CT? So it's costly. So you can ideally do a CT will be better if the patient complains of pain. Otherwise, keep quiet. Okay. Now all things come as normal. What will be your final, fit for anesthesia? Echocardiogram, the ECG, these all things are normal. What is your plan, line of management? How will you treat the patient? The patient is on the table, is on you, with you.
Neoadjuvant chemotherapy.
Don't you want to find out what is the IHC of the patient? You will not touch any patient of breast cancer without knowing the IHC. Ask us. He's been telling you all the information. He'll tell you what the IHC is also. If you ask him nicely.
No, here you have done a Trucker biopsy. I gave only infiltrative ductal carcinoma. What is the advantage of core biopsy over FNAC?
Invasive or non in situ.
Other than that.
Hormonal status.
Receptor.
So old age, the ERPR status will be high, she said, isn't it? So ERPR positive, again I give you. HER2 negative. What is your final plan? The patient is with all the array of investigation sitting next to you.
Okay, give us one line
So
management.
carcinoma breast is based on what classification? Is based on what? It is classified according to what? It is based on the subtypes.
Hold the
So
mic closer.
this is how the subtype is divided into. ERPR positive and HER2 negative, or ERPR negative and HER2 positive, or all positive or all negative and all that. Yes?
Do you know luminal A, luminal B?
Molecular
Yeah.
classification.
Molecular classification. Yes.
And sir, accordingly, we are going to go for management, right? Okay. Now you know about the ERPR. Sir told you ERPR is positive and HER2 negative. Now, what are you going to do?
Hormone therapy could be given for the patient.
You are telling 3 surgeons that you want to give hormonal therapy.
No, this case, it is your case, not the case of all breast cancer. This case, what will you do first? It has been already answered by Professor Shilpa Rao.
Locally operable breast cancer. ERPR positive, HER2 negative. 6 centimeter lesion. Tell us what you will do.
Ma'am, I have to do neoadjuvant chemotherapy first.
Again you go for me. She gave you the answer.
Modified radical mastectomy.
Neoadjuvant chemotherapy you give to make it operable. But now, ma'am says it is operable.
Modified radical mastectomy.
Modified radical
Mastectomy.
mastectomy.
So at your level, you should stick to this. Don't go into BCS and don't go into making it operable. LOBC, as far as you all are concerned, it says, no, locally operable. Upfront surgery, adjuvant therapy, hormonal therapy. You don't give chemo and hormonal together. You do hormonal therapy and radiation depending on the number of lymph nodes. How many lymph nodes should come positive for radiation?
6 lymph nodes.
10 she's telling.
10 is what you have to say. That's it.
Minimum 4 lymph nodes have to be positive to give for axillary radiation. So chemotherapy, after upfront surgery, you have to start the patient adjuvant chemotherapy. The drug of choice is AT regime. Okay, you give for how many cycles you give?
6 cycles.
6 cycles. What is one cycle? 28 days.
21 days.
Okay, 21 to 28 days.
No, ma'am. At the interval of 21 days will be.
Okay. Or 21 days, or 6 times you give.
No, ma'am. We'll divide it as before adjuvant and then.
No,
we'll
I asked what.
So if lymph nodes are very simple, if lymph nodes are positive, you will start with taxanes and go on to AC. If lymph nodes are negative, you go and start with AC and wait and watch for this thing. Okay, but any lymph node positive disease have to give taxanes weekly, backly, 12 cycles, followed by AC, followed by hormonal therapy and radiation SOS, right? Lymph nodes are negative, good disease, you can only give AC. Itna yaad rakho, huh? You all have any questions, you should ask me.
No. Yes, all the PGs could stand up. 1, 2. How they are getting up slowly.
So all your PGs are girls. Wow. One guy standing there.
He's sandwiched between the girls. Poor fellow. Lucky fellow. Oh, you are also there. 1, 2, 3.
The guys are hiding.
Yeah. Morning somebody was talking on the stage. The surgery field is dominated by males. But now it is female. I do not know. I was searching for that guest speaker who was standing. But now you see, out of the 18, and see that side is full. This side is almost silent. But when somebody comes on the stage, this side erupts. When I ask question, it's all right. Right now, back end of the day, we are also getting. I congratulate you for your good presentation as an undergraduate. We have to. And if we sit and keep quiet, we are not worth it. We have been called all the way. So for the money spent and for everything, we have to ask you questions. And we have to share our knowledge. No, I'm just telling, Alex sir has called all the... So we are asking you questions, correcting you, and other thing. It's a passion. We have to ask questions.
I like interacting with undergrads. I find them far more sincere than our postgrads at some point in time. So you're all very welcome to come and visit KM if you ever come and look me up. And great job. The reason we ask questions is that you can question issues in your mind and get your clarity. It's not about anything else. The reason I like to go and to places like this is because I enjoy teaching. I've been doing it for 28 years. So you should carry the flame forward. All the very best.
Thank you.
I fully agree. When they called me, as I said, Mokambika Medical College, Kanyakumari, somewhere, okay, that's all. Then now they've called me for some international conference and they said chairperson for some robotic surgery and all. Even then I said yes, at least I will do something or I will discuss with somebody and I'll try to justify myself there. So this is a way of learning also for us. Okay, so we love doing it. Whenever somebody calls for teaching or examiner, whatever it is, something to do with the students, interaction, we readily go. There are few people like us who are found everywhere, keep roaming around everywhere. And in turn, teaching is a passion for us. Thank you all. And I should thank the, yes, definitely Alex sir and the team for bringing us all here. Thank you, sir.
Thank you so much, Mohana Shivani, Muthu Kirtana, Madhura. Thank you, professors, for appraising our presenters.
And I think has done some research work. I heard that she has done some research work in breast. Yes? Very good, Ra. Yes, hats off to you.
Madam wants to know which.
I want to know on what.
Madam, we want to know what research. Please come out and state.
Come a little closer. I'd like to know this.
No, undergraduate doing research.
You'll be amazed the number of undergrads who come to us for a research paper. Basically, it helps them get abroad. But they do come and they help us. I don't know. She may be purely academic. Yes, Bacha, what are you working on?
Metastatic breast cancer and its association with the subtype and distant site of metastasis.
Nice. It's a good start. You need to understand because everything is about, it is about India putting itself on the map. We're very poor on publications. So I think it's time you guys took over and started putting us on the map. All the very best to you. Thank you.
On behalf of all our undergraduates and audience, we deem it our proud privilege to have been in attendance of your sessions, Dr. Shilpa ma'am and Dr. Gayatri ma'am. We extend our sincere most thanks and gratitude to both of you for gracing this wonderful session and elucidating on the most important topics for our UG exams. May I now request our general surgery team to kindly join us on stage and extend a token of our love and appreciation to both our distinguished professors. Let the cheers keep rolling for the entire department of SMIMS and our guest faculty members. Let's keep the cheers rolling for that awesome awe moment, everybody. Thank you so much, professors, for giving us that wonderful moment. Let's hear it up for them, everybody. All right, everyone. That brings us to the end of the academic session of Day 3, Smart UG 2023. May I extend my sincere thanks to the scientific coordinator of this session, the wonderful Dr. Subarathina ma'am, for curating these wonderful topics. Let's hear it for Subarathina ma'am, everybody. All right, on that note, I think it's time for some fun, isn't it? Don't you agree? And ladies and gentlemen, the girls are back. The duo that has been set out since first year is now back with a performance. Let's hear it up for Sneha and Sri Lakshmi from the final year of MBBS for a duet performance. One, two, three. Let's hear it up for them, everybody.
நீ நிதானமா இல்ல, உன் கால் தரையில படல. முதல்ல நில்லு, அப்புறம் வந்து சொல்லு.
Come on now, follow my lead. Come on now, follow my lead. I'm in love with your body.
Hello, musicians. Attendama.
Americaniana, Afghanistanana, கல்யாணம் எங்க ஊரு கூடு. ஊரு ஓகேடா, எங்க ஊரு ஓகேடா, பின் லாடன் என்ன சொல்றான் பாரு. ஓ மேல பிட்டு 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 நோய் தீரு, முத்து 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 முத்து. ஓ மேல பிட்டு பிட்டு நோய் தீர, முத்து முத்து. காதல் ஊசி போட நுஞ்செட்டு வேகத்து.
Bange, yes sir. Change the song.
Io solo sé che montaron.
மம்மி வீட்டில் இல்ல, நடுவோட யாரும் இல்ல, விளையாடுவோமா உள்ள பிள்ளடா.
So beautiful, so elegant, just looking like a wow.
their dazzling duet performance. Let us hear it for them, everybody.
So next, let us give it up for the third year girls who will join us on the stage today with a group performance.
Check.
தமிழுக்கு எண் 3 அழுத்தவும்.
மனிதன் மீது மண்ணுக்காசை, மண்ணு மீது மனிதனுக்காசை, மனித மனிதன் மீது மண்ணுக்காசை மண்தான் கடைசியில் ஜெயிக்கிறது இதை மனம்தான் உணர மறுக்கிறது கையில் கொஞ்சம் காசு இருந்தால் நீதான் அதற்கு எஜமானன் கழுத்து வரைக்கும் காசு இருந்தால் அதுதான் உனக்கு எஜமானன் வாழ்வின் அர்த்தம் புரிந்துவிடு வாழ்க்கை வாரி கொடுத்து விடு ஒருவன் முதலாளி உலகில் மற்றவர் தொழிலாளி இதை நினைப்பவனே மாளி அதை வென்று முடிப்பவன் அறிவாளி பூமியை வெல்ல ஆயுதம் இருக்கு பூப்பறிக்க கோடாளி இருக்கு பொன்னோ பொருளோ போர்க்களம் இருக்கு ஆசை தொடர்ந்தால் அகிலம் உனக்கு
நடுநடுல மானே தேனே பொன்மானே
காயம் எங்கும் நாளை ஆறி போன மாயம் என்ன பொன்மானே பொன்மானே என்ன காயமான போதும் என் மேனி தாண்டி கொள்ளும் உந்தன் மேனி தகாது செத்தேனே எந்த காதல் என்னவென்று சொல்லாமல் எங்க அழுகை வந்தது எந்த சோகம் உன்னை தாக்கும் என்றென்று போது வந்த அழுகை நின்றது மனிதன் உணர்ந்து கொள்ள இது மனித காதல் அல்ல அதையும் தாண்டி புனிதமானது சாமியே தாலாட்டும் சாமியே நான் தானே தெரியுமா சிவகாமியே சிவனரி பாதியே அதுவும் உனக்கு புரியுமா சுபலாலி லாலியே லாலி லாலியே அபிராமி லாலியே லாலி லாலியே ஓஹோ லாலலா 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 கொல்லானாலும் குளிச்சு குடி கந்தலானாலும் கணக்கு கட்டு அறம் செய்ய விரும்பும் அவனை ஒப்புற ஒழுங்கு சரி நீராடு உங்க மதை கைவிடே நதி படவே இளமயக்கள் நீ கெடுப்பதே ஒளி கனிமலை மர பச்சமாவ தன்ன மாத தன்ன வனம் நடந்து மேல நடன கையும் திறன பாடு ஆத்தி சூடி ரத்தின பாடு if you wanna grind around ஆத்தி சூடி tell me now தமிழ் பேசி மக்களுக்கு வணக்கம் சொல்லி move around ஆத்தி சூடி ஆத்தி சூடி ஆத்தி சூடி ஆத்தி சூடி இது ஆத்தி சூடி இது ஆத்தி சூடி go go lady go move move lady உன்னை பார்த்து சிரிச்சா அது உள்ளுக்குள்ள நெருப்பாக்கு அவமானம் கிடைச்சா அது கிரீடம் உன்ன உருவாக்கு உன்னை சுத்தி உலகமே ஒரு ஆனந்தம் அடையுமே திருப்பி அடிக்கும் போதுதான் யாரு நீன்னு புரியுமே it's time to give it back மாமே இது திருப்பி கொடுக்கும் நேரம் மாமே it's time to give it back மாமே இது திருப்பி கொடுக்கும் நேரம் மாமே உடைஞ்ச மேகமே மாமழையை கொடுக்குமே கிழிஞ்ச விதையிலே தான் காடு பொறுக்குமே புதிய எதிரியே வா என்ன எதிர்க்கவே பழைய எதிரிகள் என் ரசிக படையிலே இது தளபதி கேட்டா விசிலடி இது தளபதி உங்கள் நெஞ்சில் அதிபதி இது தளபதி பேரு கேட்டா விசிலடி இது தளபதி உங்கள் நெஞ்சில் அதிபதி
Give a huge round of applause for that amazing performance. Up next, we have Jerinish of second year with a performance. Please give a round of applause here, guys.
Hi.
Let's give it up for Jeranish for that wonderful performance. Up next, we have all right, ladies and gentlemen. With a short break in between, I think on popular demand, it's time to welcome back the future doctor, Alan Paul from third year with the performance, everybody.
Check, check, check. Check, check.
Ladies and gentlemen, I know you guys are excited for your friends and juniors' performance, but over the next 2 minutes to 2.5 minutes, kindly just maintain silence as a video profile has been going on outside. So once that is done, then you can blow off the roof. All right? All right. Thank you.
Check, 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 check. Check, 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 check. காற்றே கண் பார்த்தால் காதல் காற்றே பூ பூத்தால் தேன் வருமே பெண் பார்த்தால் தீ வருமே என்னாச்சு தோணலையே ஏதாச்சு தெரியலையே நச்சு லவ் இல்லையே லவாச்சு நட்பில்லையே நேற்று என்பதும் கையில் இல்லை நாளை என்பதும் கையில் இல்லை இன்று மட்டுமே நெஞ்சில் மிச்சம் உண்டு தோழா மொத்த கூத்துக்கள் யாருக்காக மொத்த பூமியும் கூத்துக்காகத்தான் அன்பே நேற்று என்பதும் கையில் இல்லை நாளை என்பதும் கையில் இல்லை இன்று மட்டுமே நெஞ்சில் மிச்சம் உண்டு தோழா மொத்த பூமியும் யாருக்காக மொத்த பூமியும் கூத்துக்காகத்தான் அன்பே அந்த நேரம் கண் பார்த்து கந்தலாகி போன நேரம் ஏதோ ஆச்சு வாரம் திரும்பி வந்தாச்சு அப்பாவும் குட்டி எல்லாம் காற்றோடு போவே போச்சு ஒசான என் வாசல் தாண்டி போனதே ஒசான வேறொன்றும் செய்யாமலே நான் ஆடி போகிறேன் சுக்குனராகிறேன் அவள் போன பின்பு எந்த நெஞ்ச தேடி போகிறேன் வாழ்வுக்கும் பக்கம் வந்தேன் சாவுக்கும் பக்கம் நின்றேன் ஏனென்றால் காதல் என்றேன் நீயும் என்ன நீங்கி போனா இளவனும் தண்ணீர் சென்றோம் பேசாம தான் போகாதடி பாசாங்கு தான் பண்ணாதடி சத்தியமா ஓ நினப்பில் முச்சு முட்டி திக்கிறண்டி கோபம் எத்தி கொள்ளாதடி கொத்தி கொத்தி தின்னாத வயசாத உசுரத்தான் உருக்காத மனசத்தான் அலசாத என் சட்ட கிழிஞ்சு வெளியா பறக்கும் இதயம் கனவெல்லாம் சிரிக்காத என விட்டு விலகாத கறி கெட்ட மனசு ஒன்ன தேடி அலையும் அடியே அடியே You are my sun, you are my earth. You didn't know all the ways I loved you, no. So you took a chance, made other plans. But you didn't think that they would come crashing down, no. You don't have to say what's again, I already know. I found out from now there's just no chance for you and me. There'll never be. Don't make you sad about it. Told me you love me. Why did you leave me all alone? Now you tell me you need me. Then you call me on the phone. Girl, I refuse. You must have me confused with some other guy. Bridges were burned, now it's your turn to cry. Cry me a river, cry me a river, cry me a river, cry me a river, yeah. Let's pretend like it's 98. Like I'm eating lunch off a styrofoam tray. Trying to be the next rapper coming at the age. Hoping for a record deal to ignore my pain. Yo, let's pretend like I'm on the stage. And when my beat drops, everybody goes insane, okay? Now everybody know my name. And everywhere I go, people wanna hear me sing. Oh yeah, and I just dropped my new album. On the first week it did 500,000. Gold in the spring and diamond in the fall. Then the world talk just to top it all off. Let's pretend like they call me the greatest. Selling at arenas and big stages. And everybody love me and no one ever hated. It's trying to use imagination.
Pretend that airplanes in the night sky like shooting stars. I can really use a wish right now. Wish right now. Wish right now. Wish right now. Can we pretend that airplanes in the night sky like shooting stars? I can really use a wish right now. Wish right now. Wish right now.
Okay, let's pretend like this never happened. Like I never had dreams of being a rapper. Like I didn't write verse up in all of my classes. Like I never used to run away into the blackness. Now, let's pretend like it was all good. Like I didn't live staring in a notebook. Like I did the things that I probably knew I should. But I ain't have neighbors, that's why they call it hood. Let's pretend like I ain't got a name. Before they ever call me B.O.B.O. a.k.a. Bobby Brent. I'm back before the mixtape, before the videos and the deals and the fame, before they ever once compared me to Andre, before they ever got on my space, before they ever noticed my face. So let's just pretend and make visions out of airplanes.
Can we pretend that airplanes in the night sky like shooting stars? I can really use a wish right now. Wish right now. Wish right now. Can we pretend that airplanes in the night sky like shooting stars? I can really use a wish right now. Wish right now. Wish right now.
Let's give it up for Alan Ball, people.
All right, everyone. Up next, we have a group performance by the second year girls. Give it up for them, everybody.
Takataya taya 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 takataya taya 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 takataya taya 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 kuri kid taya taya kuri kid taya takataya taya 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 takataya taya 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 takataya taya 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 takataya taya 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 அதுக்கு இப்போ என்னங்கற ஆத்தங்கர ஓரத்தில் நாளே கோயிலுக்கு பங்குருவிய போல அக்கம் பக்கம் யாருக்கு தெரியாம லுக்கு விட்ட பக்கன்னு மேல காத்தடிக்கும் தசையில்லையா மனச கழுத்த கட்டி இழுக்குது சேல ஆபத்துக்கு பாயா கறி போல ஆராயி முழுங்குறால சிரிக்கிற கண்ணால ஏக்கத்தில் தவிக்கிற பொண்ணால ஒரு கரப்பா பூச்சி போல என்ன கவுத்து போட்டால மோசமா கட்டிக்கிற கண்ணால பேசவே முடியல என்னால அடி இன்னொரு தடவை இதயம் சுலுக்க இடுப்பு ஆட்டாதே அத்தங்கர ஓரத்தில் நாளே கோயிலுக்கு பங்குருவிய போல அக்கம் பக்கம் யாருக்கும் தெரியாம லுக்கு விட்ட பக்குன்னு மேல
ഒരു ഇളക്കം എന്താ ഇളക്കി കൂടെ
On the floor, baby, hit it hard, baby, rock the party, baby, patu lengi podi. On the floor, baby, hit it hard, baby, rock the party, baby, patu lengi podi.
എന്റെ കരിയർ എന്റെ അംബിഷൻ അതാണ് എനിക്ക് വലുത് വെറുതെ പ്രേമിച്ചു കളയാനിപ്പോ സമയമില്ല
संग ढोल बाजे ढोल बाजे धाय धाय धम धम धाय नगाड़े संग ढोल बाजे धाय 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 धम धाय धिनकड़ाक आजा और केसरात पैरों से बीड़ी जरा नगाड़े संग ढोल बाजे धाय धाय धम धम धाय नगाड़े संग ढोल बाजे धाय 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 धम धाय नगाड़े संग ढोल बाजे धाय धाय धम धम धाय नगाड़े संग ढोल बाजे धाय धाय धम
Okay, guys, give a huge round of applause for that amazing performance.
Okay, for the last performance of the evening, up next we have with us the newest star in the Department of General Surgery, here to showcase his talent. Give it up for Dr. Aravind, JR1 postgraduate, General Surgery, with a dance performance.
நீ வெளுத்தது ஏன் கருப்பாயி கரு கரு கருப்பாயி நீ வெளுத்தது ஏன் கருப்பாயி தொட 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 மாட்டேன் தொட்டா நானும் விட மாட்டேன் நெருப்பு போல ஒட்டிக்கலாமா you up. Uptown, funk you up. Uptown, funk you up. Dance, jump on it. If you sunset and flown it. If you freak dead and own it. Don't brag about it, come show me. Dance, jump on it. If you sunset and flown it. Well, it's Saturday night and we in the spot. Don't believe me, just watch. Come on. Don't believe me, just watch. Mira que tú estás rica.
For that absolutely spectacular performance. All right, ladies and gentlemen, we have come to the flag end of day 3 of Sri Mookambika Academic Review and Training Program conducted by the Department of General Surgery, SMIMS. With a lot of learning and lots of fun, we depart to meet again tomorrow for yet another brand new session. Until then, thank you and good day.